Good morning.
Morning. This is the SME room. Can you all hear us?
Roger that. Okay, so let's go ahead and convene the second day of this particular meeting of the ACIP, Friday, December 5th, 2025. We begin with a roll call. If I can move as I did before, from my right to left, Dr. Pagano.
James Pagano, no conflicts.
Dr. Blackburn.
Hillary Blackburn, no conflicts.
Dr. Griffin.
Evelyn Griffin, no conflicts of interest.
Robert Malone, no conflict of interest. Dr. Zada. She's a DFO, so she works for the CDC. Dr. Pebsworth.
Vicky Pebsworth, no conflicts.
Dr. Levy.
Retzef Levy, no conflict of interest.
Dr. Stein.
Kathy Stein, no conflicts of interest.
Dr. Pollack.
Raymond Pollack, no conflicts.
So with that, we'll move on to my opening statement.
This is Joe Hiblin. I'm here, and I have no conflicts of interest.
Oh, yes. Who else do we have online? Is Kirk on? Cody. So Cody and Kirk are not currently online. Thank you, Joe, for interjecting. I apologize.
You're welcome.
For
not a worry.
Overlooking. We need to go down the ex officios. Is that right? Okay. So, do I have a list? Oh yes. Andrew Johnson from CMS.
Good morning, Andrew Johnson, Centers for Medicare and Medicaid Services.
Tracy Beth Hogue from FDA.
Good morning, Tracy Beth Hogue, FDA.
Reed Grimes from HRSA.
Good morning, Reed Grimes representing Health Resources and Services Administration.
Matthew Clark from Indian Health Service. Matthew? Mike Carilla, are you here from NIH? Okay, so that's that. Now, regarding our affiliate organizations, the liaisons, American Academy of Family Physicians.
Good morning, this is Dr. Laura Morris representing the American Academy of Family Physicians.
Thank you. American Academy of Pediatrics. American Academy of Physician Associates.
Good morning, Marie-Michelle Léger, present.
Thank you. American College Health Association. American College of Nurse Midwives.
Good morning, Carol Hayes, present.
Thank you, Carol. American College of Obstetricians and Gynecologists.
Good morning, this is Kevin Alt, and I'm representing ACOG this morning.
Thank you, Kevin. American College of Physicians.
Dr. Jason Goldman, General Internal Medicine Private Practice, President, American College of Physicians, Affiliate Professor of General Internal Medicine at Florida Atlantic University. No conflicts and present.
Thank you, sir. Appreciate that. American Geriatric Society.
Dr. Ken Schmader for AGS.
America's Health Insurance Plans.
Dr. Lori Kaloya for America's Health Insurance Plans.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle and Tisha Lucas, representing ERA.
Thank you. American Medical Association.
Sandra Freithofer, practicing general internist in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you, ma'am. American Nurses Association. American Osteopathic Association.
Dr. Masood Mahmoudi, good morning, present.
Thank you, sir. American Pharmacists Association.
Good morning, Dr. Kelly Good, representing the American Pharmacists Association.
The Association of Immunization Managers.
Robert Schechter, AIM, good morning. Thank you.
Thank you. Association for Prevention, Teaching, and Research. Association of State and Territorial Health Officials.
Good morning. This is Dr. Natasha Bagdasarian representing ASTO.
The Biotechnology Innovation Organization.
Good morning. Phyllis Arthur and Emily Acker representing Bio.
Thank you, Phyllis. Council of State and Territorial Epidemiologists.
Dr. Christine Hahn for CSTE.
Thank you. National Association of County and City Health Officials.
Yes, good morning. This is Dr. Judith Schley from Denver Health, Public Health Institute at Denver Health, representing NACCHO and all the public health organizations, local public health agencies throughout the country.
Canadian National Advisory Committee on Immunization. Infectious Disease Society of America.
Good morning, Dr. Flor Munoz, representing IDSA today.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett for ISTM, present.
National Association of Pediatric Nurse Practitioners.
Good morning. This is Dr. Stacy Buchanan, pediatric nurse practitioner, present.
The National Foundation for Infectious Diseases.
Dr. Bob Hopkins and Dr. Jeff Goad for the National Foundation for Infectious Diseases.
Thank you for joining us. National Medical Association. Pharmaceutical Research and Manufacturers of America, PhRMA.
Good morning. This is Dr. Carolyn Ha and Dr. Mike Ybarra, present from PhRMA.
Thank you. Pediatric Infectious Disease Society.
Good morning. This is Grant Paulson with PIDS. Thank you.
Society for Adolescent Health and Medicine.
This is Dr. Amy Middleman representing SAM.
Society for Healthcare Epidemiology of America.
Dr. Preeti Mehrotra here for SHE.
Thank you, and a sincere thank you to all the liaisons for your willingness to get up yet again early in the morning and join us through today's deliberations. And I hope it's clear that we value your input, and we look forward to learning from you again and listening carefully to you as we anticipate the upcoming vote. We do ask, please, in the interest of time, that comments in the discussion that will be coming up regarding the voting language be restricted to 2 minutes maximum, if you don't mind. And I'm going to have to be a little firm on that, or this could last quite a long period of time. So if you can take time now to prepare a 2-minute commentary that's focused and preferably addresses some specific question that you wish to raise. That'll be much appreciated and help us move through the morning's activities. Now with that, I'm going to read the Friday opening statement. Good morning and welcome to the second day of the ACIP meeting. Yesterday's discussions were constructive and grounded in the kind of careful analysis that this committee is known for. We examined the hepatitis B evidence in depth and voted 7-3 to postpone the vote on the vaccine language to first thing this morning. That level of candor and discipline is essential for a process that the public can trust. After the vote, we will shift our attention to the remainder of the agenda, which includes discussion of the childhood and adolescent immunization schedule, where we will hear from Erin Seary. For your information, Drs. Paul Offit and Peter Hotez were invited to present and discuss their perspectives as well. Our intention was, sincerely, to hear a diverse set of views, but Drs. Offit and Hotez declined our invitation. Mr. Seary will discuss the U.S. child immunization schedule and how it compares to other countries. If time permits, we will also discuss some of the issues relating to exposure to aluminum adjuvants in vaccines, but this will not be an exhaustive, detailed discussion. As always, our responsibility is to evaluate this information with clear eyes, recognizing both its strengths and its limitations. No voting language relating to these issues has been prepared. By that, I'm referring to the schedule and to the adjuvants and alum in particular, because these issues are complicated and will require quite a bit more discussion, as well as internal evaluation within work groups. But ACIP leadership and membership hope that these discussions will help the acting CDC director and Americans to improve their understanding of the current data and complexities associated with these issues. I wish to reiterate a point I made yesterday. The credibility of the ACIP rests not on speed, but on rigor. We serve the American public by taking the time to ask the right questions, scrutinize the data, and articulate a transparent rationale for whatever recommendations we produce. That approach is not only scientific sound, it is necessary for restoring public trust in vaccine policy. Even the best and most objective advice should be reevaluated when new information and risks become apparent. Across today's agenda, I encourage us to continue approaching each item with the same seriousness and, frankly, openness that we have applied in the past. What does the evidence actually show? What does it not show? What are the gaps and risks in what is actually known? Where do uncertainties remain? Where might implementation challenges affect outcomes? These questions are not obstacles. They are the core of responsible scientific deliberation. Not easy stuff, often quite contentious, but necessary. That is the nature of science. In all of my experience, scientific discussions and debates are contentious. If they're not contentious, if they're not approached with rigor, then we end up with bad decisions. We end up with bad science. We must actively engage in responsible debate concerning contentious issues. We must boldly address change, risk, new ideas, and conflicting hypotheses, which is the proper nature of evidence-based science. Robust scientific dialogue is not a sign of disagreement, it's a sign of a healthy process. Thank you again for your continued service and commitment. I look forward to helping guide us through another productive day. Now I'm going to go off script for just a moment. And I want to acknowledge the American public. And I want to acknowledge that there are many members of the public, in some surveys a majority, that have been quite affected by what transpired during the COVID period. And I think that's pretty self-evident. Many members of the public have lost faith in the vaccine enterprise. Please keep in mind that I have spent over 30 years working in the vaccine industry. I am not an anti-vaxxer. I am absolutely opposed now to vaccine mandates. That's my personal position. But I am committed and have spent my entire life working to develop improved vaccine technology and more safe and effective vaccines. I'm committed to it. Our affiliates are committed to it. We're all committed to it. But the public has been impacted by practices that occurred during COVID. This includes compulsion, coercion, and enticement. I was trained in bioethics that these are things that are not acceptable. That the absence of coercion, compulsion, and enticement is the essence of informed consent. What I heard yesterday was a commitment by many in the pediatrics community to informed consent. And yet we have JAMA documenting that many pediatricians are not willing to accept patients that will not fully comply with the vaccine schedule. The JAMA article actually indicates that that's greater than 50% of pediatricians. This is troubling. And the policies that the American public have experienced during COVID has severely damaged their confidence in public health and in the vaccine enterprise. And I think we have to recognize that. And when we refuse to acknowledge the nature of the actual data, such as the CDC data that was presented yesterday in terms of the timeline for the decrease in incidence of hepatitis B infections in continental United States, we do the public a disservice. Those were data. They were CDC data. There was a statement made that those were disinformation. Disinformation is intentionally false information presented for political purpose. That is a gross mischaracterization. And I hope, I pray, I plead that we all can commit to a open consideration of alternative points of view. The committee and myself worked very hard yesterday to ensure that we listen carefully to our affiliates and their points of view. I plead with all of us that we try to come together and recognize that the scientific process requires that we treat each other with respect, and we recognize that although we may have differences of interpretation, there are core data that we can use to guide our thinking and our decisions, and we shouldn't just discard information because we find it inconvenient. Now, forgive me for that editorial. I thank you for tolerating it. Those are my personal opinions. Now let's get to work. Dr. Meissner, have you been able to join us virtually now?
Yes, I have been able to make it, and apologies. And I would like to add one comment to your presentation.
Please do.
Dr. Malone, thank you. I would like to note that it appears as though the American Academy of Pediatrics has once again chosen not to participate in ACIP deliberations. The Academy has a long history of working closely with ACIP to the betterment of vaccine recommendations for children. Vaccine guidelines are improved by discussion of a variety of views. My concern is that by not participating, the Academy will be seen as more focused on making a political statement rather than focusing on the health of children. Along with other advances in public health, such as clean drinking water and pasteurization, immunizations are one of the most important medical interventions available. Vaccines are a standard of care, and pediatricians should be part of these discussions. Refusal to participate in ACIP meetings does not appear to be in the best interest of children. Over.
Thank you, Dr. Meissner. And a tiny little technical thing. Can you share with us whether you have any conflicts of interest?
Thank you. No, I have no conflict of interest.
I thank you for that. Additional ex officios that may have joined us, do we have our representative from the Indian Health Services with us?
Yes, Matthew Clark, representing Indian Health Service.
And from the National Institutes of Health? Do we have our NIH representative? Okay, when the NIH representative joins, I look forward to recognizing them. Dr. Milhound, I know you're traveling, very complex schedule. Have you been able to join us now?
Yes, sir. This is Kirk Milhound, no conflicts of interest. Greetings from Hong Kong.
Thank you, sir. Now I'm just recapping. We may have missed some of our liaisons. Do we have a representative from the American Academy of Pediatrics? Hearing none. Do we have a representative for the Canadian National Advisory Committee on Immunization? Sorry, neither of those have been able to join us. Perhaps they will introduce themselves at a later time when we open discussions. So now we're going to move into the period where we're considering the language of that has been proposed for a vote. And Dr. Vicki Pebsworth is once again going to walk us through the origins and basis and support from the work group that gave rise to that language.
Thank you. And thank you again. The presentation that I gave yesterday afternoon under the heading of Summary of Information is the what the work group did. That presentation included the work group process, the work group findings, and so I won't go through all of that step by step, but just try to hit some of the highlights that shaped the recommendation that was developed. To begin with, the work group was asked to assess the use of a universal birth dose of hepatitis B vaccine in children whose mothers are hepatitis B surface antigen negative. And the terms of reference document that guides our work required that we review the efficacy and safety of the immunization schedule for children and adolescents, identify efficacy and safety problems, and address stakeholder concerns. And to do that, we met a number of times, which I described yesterday. I also described areas where the work group members were in full or nearly full agreement. I'll touch on those in a minute. And then I discussed the central themes that came out of the work group's efforts. We evaluated 3 different types of recommendations: universal, no recommendation at all, or an individual-based decision-making option. That was the option that was most preferred. And then yesterday I went through the rationale that was provided by the work group members for preferring the individual-based decision-making option. I also discussed the rationales that were provided for not preferring that, and discussed the new policy approach opportunities. So just to recap, the areas of full or nearly full agreement that the work group came to, and these are the components that were used to build the recommendation. Those areas are that hepatitis B virus can be transmitted vertically and horizontally to infants, is a serious disease, and can be prevented by vaccination with the hepatitis B vaccine. There was full agreement on the statement. There is uncertainty about the true rates of incidence, prevalence, and horizontal transmission. There is also uncertainty about whether all 3 recommended doses are needed to acquire protection. There was agreement that there are gaps in evidence and limitations related to safety. Then there's agreement that infants born to mothers who test positive for hepatitis B surface antigen should continue to be vaccinated with hepatitis B virus vaccine and receive hepatitis B immunoglobulins soon after birth. There was also very strong agreement about those mothers who are of unknown status, any gaps in screening of pregnant women should be eliminated so that all infants receive appropriate care. There was discussion about rescreening of pregnant mothers upon admission for delivery and should be considered so that there are no mothers where their hepatitis B surface antigen status is unknown. And there was strong agreement that any situations of this sort should be regarded as a serious quality of care problem, if not a medical error, and that women or infants born to mothers who test negative for hepatitis B surface antigen do not need to be routinely vaccinated with hepatitis B virus at the moment of birth or soon thereafter. So these components are what were used to build the following statement, the recommendation. So as I explained earlier, that our focus was on infants born to mothers who tested negative. So the preamble to the voting language states there should be no change to the vaccination recommendation for infants born to women who test hepatitis B antigen positive or have an unknown hepatitis B surface antigen status. The existing recommendations remain the same. And that just that statement is in there to make sure that we narrowly focus on what the charge was to the work group. Vote number 1 is for infants born to hepatitis B surface antigen negative women. ACIP recommends individual-based decision-making in consultation with a healthcare provider for parents deciding when or if to give the hepatitis B virus vaccine, including the birth dose. Parents and healthcare providers should consider vaccine benefits, vaccine risks, and infection risk. For those not receiving the hepatitis B virus birth dose, it is suggested that the initial dose is administered no earlier than 2 months of age. There's a footnote in this recommendation that states parents and healthcare providers should also consider whether there are risks, for example, such as a household member who is hepatitis B surface antigen positive, or when there are frequent contact with persons who have immigrated from areas where the hepatitis B virus is common. That is the recommendation we came up. Should I read the second one too? Or
read vote 2.
Vote 2, okay. Vote 2 is when evaluating the need for a subsequent hepatitis B virus vaccine dose in children, parents should consult with healthcare providers to determine if a post-vaccination serology testing should be offered. Serology results should determine whether the established protective antibody titer threshold of 10 has been achieved. The cost of this testing should be covered by insurance.
Thank you, Dr. Pebsworth. With that, I open for the next 60 minutes discussion among the ACIP members and ex officios concerning the language specifically, and I ask that each of us that wish to discuss this keep your initial discussion to 3 minutes or less. Then we'll go through, I'm going to basically do round robin through the committee and the ex officios, and then ask that once again we'll go through that and that you restrict your comments to 2 minutes or less in response to what you've learned from discussing with the others. We'll then proceed to a not greater than 30 minutes discussion section with the liaisons, and you'll recall my gentle suggestion that we restrict those comments to 2 minutes each, and ideally they're structured around a question or a specific issue. So with that, I'm going to actually do this as a roll call, if you don't mind, for starters. Jim, do you have any specific things you wish to share about your comments regarding the language?
Not at this time, though I would like to reserve the opportunity to speak after there's been some conversation.
Hillary?
Sure. So I support the intent of maintaining strong protection against hepatitis B while empowering parents to work with their pediatricians, and offer a clarification on vote 1 and some questions on 2. So I recommend clarifying that for infants born to negative mothers who do not receive the birth dose, the Hep B series should begin at 2 months as part of the existing routine schedule. This is important because many infants already receive the combination vaccines at 2, 4, and 6 months that already include Hep B. And starting at the 2 months allows the child to complete the standard 3 dose through those routine combinations to simplify and support adherence. And then for 2, I respect the intent to look at what the need for additional doses, and but the introduction of serology testing would be a new practice. And while I understand we have limited evidence on how these young children are going to achieve protective titers after 1 or 2 doses, so I just have some concerns about feasibility, and just want to have a little bit more information before going forward with that one.
So it would be acceptable to you that we revisit these concerns in a second round when there may be a motion to change some of the wording. So in order to change the proposed wording, we would need a motion, a second, and a specific proposal for how it would be changed, just to be clear on our process. Dr. Griffin.
I'd like to reserve time for comment later. Thank you.
I have no comment at this point in time. Dr. Pebsworth?
No comment at this time.
Dr. Levy?
So thank you. I would like to take a few minutes to reflect what I think this very positive change in policy reflects, and then also try to put the hat of a parent, trying to understand as a parent how do I think about this and how I'm resolving the potential confusion. At the high level, I believe that this policy, this new proposed change, is rejecting the existing policy that relies on the principle that everybody should be receiving the same care when it comes to vaccination. And that based on really a sense of fear that everybody is in the same level of risk, a sense of we need to treat or use babies and children as safety net, and that essentially vaccines are risk-free. And I think that the alternative policy is saying something very different, very different. And it starts by saying that if you are a baby born to a mom that was tested positive to hepatitis B, you absolutely are recommended to take this vaccine because it's a very effective vaccine that will protect against very serious outcomes of a very serious disease. And the same holds if you belong to another high-risk population. We have an effective intervention and against a very serious illness. However, if you're a baby that was born to a mother that was tested negative to Hep B, you need to realize as a parent that your risk of infection throughout your early stage of life and probably throughout most of your childhood is extremely low, to the extent that it's even hard to quantify how low it is. It's probably 1 in several millions. And that means that as a parent, we encourage you, in consultation with your physician, to think very carefully, do you want to expose your child, your baby, to an intervention that could have some potential harms when the risk is so low? And mind you that we are talking about a very, very young baby in the first few months of their life where they are not fully developed and where we don't know the exact potential impact of exposure to vaccines, but we do know that their immune system is not fully developed, their metabolism is not fully developed, their brain is not fully developed, and we know that all of these systems are interacting with each other. And I think that implicit to that, we are also saying that we don't think that it's the correct view to view vaccination of children as a safety net for adults' mistakes and flaws in our healthcare system. That's not the right way to think about those flaws. We need to be very vigilant to fix them instead of telling babies that they need to be vaccinated. And it's also reject the idea that vaccines in general, and this vaccine in particular, should be used to mandate vaccination and coercion to vaccination and condition attendance to education settings or clinical care settings just because you vaccinate or not. Now, as a parent, how do you actually make sense of this? Because I think that you're hearing a lot of statements that could be very confusing, and I would like to offer, based on my experience as a scientist, but also as a parent, how I suggest parents should be thinking about. When you are being told that your baby is at high risk, even though your baby was born to a mom that was tested negative for Hep B, I think you need to ask yourself why they are not providing a specific number, and maybe at the more intuitive level, ask yourself, do you know and you ever heard about a case when a baby like yourself or a child like yourself was infected at school, at home? Ask your friends if they know about a case like this. I think that you will realize that while there are many bad things that can happen to kids that you do hear about them, again, they're rare, but you do hear about them, this is even more rare than that. The second thing is, I suggest to parents to be very, very suspicious when people tell them that something is safe, especially a vaccine. Because we have been adopting a very, very confident way of telling parents about vaccine products that they are completely safe, where we essentially never tested them appropriately. And just in the same way that you would never agree to fly on a plane that the aircraft vendor tells you that it's safe, not because they tested it rigorously, just because they didn't test it or didn't find anything and they didn't test it, you will never be willing to take off with that plane. I suggest that you view giving vaccines to your babies as taking a flight, taking off with the plane, and apply the same level of scrutiny to the safety of your child as much as you will apply to the safety of a plane. And I don't believe that we currently do that. Thank you.
Thank you, Dr. Levy. Dr. Stein.
Thank you. I want to start by reemphasizing and mostly for our affiliates and for the public, that this voting language does not change the recommendation for the children born to mothers that are hepatitis B confirmed positive, and also for those that are unknown status. And again, the unknown status addresses the gaps in care that we discussed extensively yesterday. Again, for children, especially born to hepatitis B confirmed positive moms, this is an important, very important intervention for those children. So what we are addressing here are vaccinations for children who are born to hepatitis B confirmed negative mothers, and as Dr. Levy just pointed out, are exceedingly low risk. And what this gets at is the point of informed consent. And as we discussed yesterday, there are children who either, and this has also been pointed out earlier, that are denied medical care. They are removed from pediatricians' offices if their parents have an informed choice to decline the vaccine. They are prohibited from attending school. And that is not informed consent. That is a violation of informed consent. And as I heard the affiliates, many of them mentioned yesterday that they are proponents of informed consent and full discussions with parents. I think this is consistent with that. And I also commend those affiliates for making that very strong point that informed consent and discussion with parents is a key part of practice. Another point that came up yesterday was the point of access to care. I'm not access to care so much as access to these vaccines. And again, because this language includes individual decision-making, that will enable full access to these vaccines for the parents that choose that for their children. And again, it will be available for those situations where there is decreased access to testing, for example. There will be access to those vaccines. And as we heard yesterday from Vaccines for Children and from CMS, nothing changes in terms of insurance coverage. And so access to care should not be a concern. And that closes my comments.
Thank you very much. Dr. Pollock.
I just want to thank the work group for having the fortitude and the willingness to revise their voting language based on the discussions yesterday. And I think I'll reserve any other remarks once there's a motion on the floor. Thank you very much.
Thank you. So I'm going to do one more round. I apologize. We have the folks that are online. I keep overlooking them, and it's absolutely a bad thing on my part. Dr. Hiblin, do you have anything to share?
Yes, I agree. You continue to overlook us, and I'm glad you've identified that and seek to change that issue. As requested, I will specifically restrict my comments to the language of the proposed votes. Number one, the preamble is illogical because the status of unknown members is not part of the current recommendations. Therefore, we cannot say that these recommendations should remain the same. Furthermore, we have no opportunity to vote on this preamble and either agree with it or disagree with it. For the specific language of vote 1, the last sentence says that for those not receiving the HPV birth dose, it is suggested that an additional dose is administered no earlier than 2 months of age. This specific point is the reason why we tabled this issue for 3 months to more fully discuss it. However, we have still not had any information or science presented or discussed with regards to this issue of before or after 2 months of age. This is unconscionable. How can we go forward when this is a specific issue that was supposed to be identified? It's unconscionable. With regards to the language of vote 2, there is an absolutely novel concept being put forth here to vote, that a serology test should be offered or required, should be offered after the first dose before the full series of vaccines are administered. This has not been debated. No information has been presented on this issue. And, the full series of doses is required to achieve 95% efficacy. So, in addition to this not being discussed, there has been no data presented that this plan would actually work. So, for vote 2, this novel proposition presented today at the last minute has no science of efficacy and increases the burden of administrative work, creating new barriers to achieve protection. So, in contrast to the chair's directive for today, no rational science or discussion has been presented on these two novel issues, and there's no evidence that especially vote 2 has ever been discussed as a work group item. So, overall, in general, I consider that this fourth iteration of votes in 96 hours is still incredibly problematic. Thank you.
Thank you for sharing that. Dr. Meissner.
Okay, thank you, Dr. Malone. And as I'm sitting here gathering my thoughts, let me begin by saying, thoughtful inquiry is always commendable, and but that inquiry should not be confused with baseless skepticism, which is what I think we're encountering here. When any vaccine is administered, as I've said, I think several times before, the healthcare worker needs to consider the balance of benefit and harm. And in terms of what these two votes propose, it's very hard for me to agree with what's possible, what is stated. For example, I guess people are opposed to the neonatal birth dose because they think there's harm that outweighs benefit. Well, why does that change at 2 months? Is there any less evidence or any evidence of less harm if the series is started at 2 months instead of 1 month? I'm unaware of that. And I think there is plenty of evidence of a likelihood of lack of protection in an increased number of infants if the vaccine series is started at 2 months of age. So I would like someone to explain to me what is the advantage of giving a dose starting at 2 months rather than at 1 month? We'll lose at least some of the protective effect, and I don't think there's any reduction in risk. Not that there is any risk that we're aware of from the vaccine. So it simply it would be hard for me to accept. Then in terms of vote 2 is kind of making things up. I mean, it's like Never Never Land. We discussed yesterday, I think pretty carefully, that serology is not an adequate basis for deciding whether someone's immune. If a person has greater than 10 milli-international units of antibody after 1 dose, the implication is that's enough and they don't need any more. We have no basis for saying that. That's been kind of pulled out of the air. So the serology is performed as recommended by most people to be sure that the hepatitis B vaccine and the hepatitis B immune globulin protected the infant, and the infant is not hepatitis B surface antigen positive despite the intervention, which is very unlikely, but can happen. So testing serology at less than 3 months that's made up. Where does that number come from? And I want to correct a couple of you. Several times I've heard people say that we're viewing children as a means of protecting society against hepatitis B. And why should they bear the? That's absolutely not true. Several people have said this. We are giving the vaccine to protect the infant. We're not giving it to protect society. We're giving it to protect the infant against a potentially fatal disease, which we know is very effective. And there was a statement made a few minutes ago that nobody said that physicians say a baby born to a hepatitis B surface antigen mother is at high risk. No one ever says that. If no one ever says that, we give the vaccine in case that child is exposed after the neonatal period, because we know that a dose of 3 immunizations, 3 vaccine doses, confers pretty much lifelong protection, as we discussed. So I don't. The analogy, Retzef, with an airplane safety, I think is not accurate. We know vaccines are safe. There's no question that the COVID recommendations were dishonest and disingenuous, but the hepatitis B vaccine recommendation is very well established. We know is safe, and we know is very effective. And to make the changes that are being proposed, we will see more children and adolescents and adults infected with hepatitis B. Over.
Thank you, Dr. Meissner. Now, Dr. Milhound. Dr. Milhound, do you have any comments to share with us regarding the voting language, sir?
Yes, I do. I'm sorry, I am in an airport right now, but I do want to share a few things. One is, this is regarding the 2 months. We've always considered neonates a very protected class. They're at higher risk for almost every procedure you do. Their blood-brain barriers are not the same. The GFR is not the same. How they handle things is not the same. So it's very important that even without abilities to have real good safety, that we do everything we can out of an abundance of caution to this very important and fragile group, is to treat them with safety. Make sure that what we do has to be done. Regarding the language for suggested at 2 months, that is because we're trying to get out of the neonatal period and allow a sensible approach to when it can begin, especially if people want to give a multivalent vaccine. Okay, so that's that issue. Now, with regards to serology, what we were shown in the work group, I've looked at many studies on this from different places, but it was described in the work group from CDC that the seropositivity in a neonate is approximately 26%. So that's not very good. And and with regards to serology testing, someone said we do 3. I think Dr. Philbin said we do 3 because of efficacy. We do 3 because of herd immunity to try to get to a 95% threshold. Okay, so when we look at serology testing, what we're trying to be is scientific about this. We're trying to actually look at what are the data. If we have a 95% uptake of the vaccine after 3 doses, people realize that's still 1 in 20 children have not shown serology, seroprevalence for that child, right? They haven't shown an immune activation. Now, they might have cell-mediated immune, but those usually go hand in hand, as the study showed from the group out of Winston-Salem, Wake Forest, and China when they were looking at cell-mediated immunity in a newborn. But what we're trying to do, what the purpose was, is actually not to actually even give parents more confidence that your child is covered, as opposed to say, well, we think they are. Because I think many of us know, and as medical care providers, many of us have had titers drawn, and if we did not meet a 10 milli-unit threshold, we are expected to get a booster. So that is proposed that should happen. At the same time, people are saying if you have full immunity, then it never wanes. I don't disagree with that, but you can't really have it both ways. So I think that looking at this, yes, it's novel, but I think it really looks at is, do I need to give this injection that has some risk? It's not risk-free. It was mentioned from one of the discussions yesterday that what does it matter if they get a third dose? What does it matter to complete the schedule? First, do no harm. First, do no harm. So if this patient really, and maybe that's because of our ignorance in how we've been doing some of these vaccines, are we vaccinating for the child or for herd immunity? And so that's the question. I'm trying to get at the point where I want to have the maximum amount of benefit from vaccines. I want to do everything I can to limit the risk, even if it's small. So that is how I look at things. Thanks so much. I appreciate it. Sorry, I'm traveling and walking through an airport at the same time. Thank you.
I think you did a pretty good job of hitting some key highlights that had not been covered. Now we turn to the ex officio members. Dr. Hogue from the FDA, do you have any comments regarding language, ma'am?
Yes, thank you, Dr. Malone. I just have a few comments. I think I want to say that I agree with Dr. Levy that I think this is a very positive move, vote 1, that brings us in line with peer nations to not recommend giving the hepatitis B vaccine routinely at birth. And I think an important concept that hasn't been mentioned in this meeting yet is that of the burden of proof. You know, do you give a vaccine to an infant when you do not know for sure that the benefits will outweigh the harms? And of course the answer is no, and I think this is why our peer nations have not chosen to do this for non-high risk infants at this age. And we've talked about the limitations in the randomized control trials and the data that we have to really rule out serious safety issues on a magnitude that where, at a magnitude that where we would say that the benefits for sure outweigh the harm. So because this is such a low risk situation, you really need to have a very large randomized control trial with long follow-up. It would be tens of thousands. And we just don't have that information. And so then the question arises, should we give the hepatitis B vaccine at all in childhood? And so I think a lot of people have brought up a very fair point. What is the difference between giving the vaccine routinely at birth versus at 2 months? And I agree that we really don't have good data to distinguish those two. It is a different situation in terms of informed consent, right when a mother has given birth, that there is a lot going on. And I think you brought that up before, Dr. Malone. And so, again, I think that this is a favorable move to not routinely recommend it at birth. And I would just encourage the ACIP to do a very diligent risk-benefit analysis, acknowledging the known risks and the unknown risks, what we don't know, as we have been discussing, and consider why, when we have a similar prevalence of hepatitis B in the United States as they do in Denmark, why Denmark has decided that they should not routinely recommend it to children, and that they should identify children who may be higher risk, and then it can be individual decision-making for those children. And then for vote 2, I think some very good points have been brought up about that, and I guess I would just say that I haven't seen evidence that this serology has been validated as a correlate of protection, and I guess just because it's done in adults doesn't necessarily mean it's the right thing to do. And so I guess I would encourage ACIP, if you're going to vote yes on that, to accompany that with data that shows that that serology has been validated as a correlate of protection. I just haven't seen that. So those are my comments. Thanks.
Validated correlate of protection, a key concept often bandied about and rarely are those that use that language recognizing how complicated it is, but it is at the core of some of the new recommendations coming from the Center for Biologics Evaluation and Research, that we should not just assume a titer equates to protection. We do need to, the new standard is that we take the time and effort to verify that our assumptions that antibody response correlates with protection are actually valid. So you're raising the key point that just because we've been doing it in the past and assuming that this historic titer threshold has meaning, I'm not aware that the 10 unit threshold has actually been validated in any way. It's just been a historic precedent. Do I understand that correctly, Dr. Hogue?
Well, I don't have any information that contradicts it. I haven't seen that presented, that it has been validated. And if I'm missing something, please someone let me know.
Thank you. So the next affiliate is Dr. Andrew Johnson. Can you share with us your point of view?
Thank you, Dr. Malone. CMS, having reviewed the updated language from the work group, it is our position that with regard to Medicaid, the Children's Health Insurance Program, private insurance, and employer sponsored insurance, that we see no coverage gaps in the newly proposed language, and don't believe that it would restrict access.
Let's see, so if I can summarize that in plain English for the average American, if these votes were to pass, they would not have any predictable impact on equity, availability, or availability for federally supported distribution and administration of hepatitis B vaccine products that have been approved by the FDA. Is that correct?
That's correct. Covered by insurance without out-of-pocket cost.
Thank you, sir.
Yes, sir.
We have two of our members that are raising hands right now, and I want to recognize Dr. Meissner.
Thank you, Dr. Malone. I am not a hepatitis expert, but I do have an understanding of 10 milli-international units as a measure of an appropriate immune response to the vaccine. And the recommendation is that after a series of 3 doses, if a person has a level of greater than this number, within 3 months after receiving the dose, then that person is reliably protected against hepatitis B. And as was confirmed yesterday by the CDC, if you attain that titer, there has not been a documented instance of a person developing acute hepatitis or chronic hepatitis. So that is a desired goal. Now, the question that was raised by one of the members earlier said that if he has a titer less than 10 milli-international units, he should receive a booster dose. That is, if it's less than 3 months after the 3rd dose. That is because he is a healthcare worker and is at very high risk of being exposed to hepatitis B. But for the general public, that's not the case. For someone who's not at increased risk because of their employment, that is not the recommendation. We know that antibodies will decline over time, but there will be what's called an anamnestic response to a booster if it is administered years later in someone who initially responded and who's otherwise healthy. So the fact that hepatitis has not occurred in someone who has received the hepatitis B series is about the best proof you're going to get that the vaccine is effective. Over.
Thank you, Dr. Meissner. Just a small point of clarification. Would you accept that we don't have documented evidence of this occurring, but the absence of evidence does not prove the absence of the incidence? Is that fair?
I would answer it this way. I think if someone had a documented case of acute hepatitis B in someone who was otherwise healthy and fully immunized, that would be the lead story in the New England Journal of Medicine.
Interesting standard. Dr. Milhound, you've raised your question.
So it's just curious to me. I don't disagree with Dr. Hogue, but I guess it was okay to use it for seroconversion. And we've accepted it that is a standard. So it's, as Dr. Meissner said, that it works. But we don't really have any data on if you get one dose and you seroconvert, or you get 2 doses and you seroconvert. When I was taught in medical school in '92 that we did this for herd immunity and not for individual immunity. So I agree. I don't disagree with Dr. Hogue, but we have to be very honest that we're going to use that number when we like it, and we're going to discount it when it doesn't serve our purpose. And for regarding the healthcare workers, by the standard we're using for neonates, wouldn't we also apply that titer to people who had high-risk home contact? So I don't disagree at all with Dr. Hogue. This is part of the paucity of data we have that was rigorously evaluated. How much is needed for the individual? And have we proven or demonstrated clear evidence that 1 is not enough and 3 is better? So I understand the robust immunity that comes with a booster, but does that mean that the burst was not good enough? When we asked for that data was not there. So I'm bringing up issues once again, just like we did for safety. There's a paucity of data, and I prefer do no harm to children. Thank you.
Can I answer that?
Okay, hold it. You're specifically addressing Tracy. So could we allow Tracy to respond first before yourself? Would you mind? Is that okay?
That's fine.
Thank you.
My response is that I want Dr. Meissner to respond.
Okay, Cody, you've got the floor.
I haven't. Thank you, Tracy. Let me recollect my thoughts. The point is, I think we're confusing what we know and what we don't know. We do know that a titer of 10 milli-international units within 3 months after the 3rd dose is sufficient. It is protective. But I think the question that has been asked is whether 15 milli-international units after a single dose is sufficient. And that we do not know. It's possible, it could be, but we have no idea, at least that I'm aware of. Perhaps somebody at the CDC has data on that. But when you talk about minimizing harm, well, giving 1 dose and then letting a child become susceptible later in subsequent years, because we don't know if that will induce sufficient cellular immunity. I mean, to me, that's the harm. The harm is not giving 3 doses. The harm is not giving 3 doses as prescribed.
Okay, so thank you. We have a reference. He's indirectly requesting consultation or feedback from CDC experts to address the issue of what data may exist regarding protection afforded by one or more doses that achieve the historic threshold titer? Do we have any data on those issues from our CDC experts? Over.
Good morning, everyone. This is Adam Langer from the Hepatitis Center. So there are historical data from the original controlled trials where the vaccine was approved that do show that about 25% of recipients, infant recipients that received the first dose would develop what would be considered a protective titer, then a larger number after the second dose. And after the third dose, you get up, I believe, above 90%. The problem with pointing to those data and saying, okay, well, we can just test after each dose and stop, is that all of the efficacy studies in terms of looking at outcomes were done after all 3 doses. And so we would be making a really huge assumption that one dose that just happened to get that particular baby's titer up above 10 was in fact lifetime protective. And there really is no reason not to give the full series. There's no evidence of any significant long-term adverse events that occur from giving the full series. And certainly there is no evidence to suggest that there would be any less risk of giving 1 or 2 rather than the 3. I also just want to take a moment and provide some insight on the issue of peer nations. The United States is a unique country. I think that most of us would agree that we don't really have a peer nation in this world. There are other high-income nations, certainly, but let's talk about Denmark. Denmark, the entire country, has 6 million people. The population of New York City alone is 8 million people. More than 95% of pregnant women in Denmark are screened for hepatitis B. This is far higher than the number in the United States. Prenatal care is free for both citizens and refugee or asylum seekers in Denmark. We all know this is not the case in the United States. Denmark has a national health registry that compiles health information at the individual level using a unique national ID. The U.S. does not have that, and I imagine that our privacy culture would not permit us to ever have something like that. In Denmark, pregnant women who screen positive for surface antigen are followed up, and their infants are followed up to ensure that they are vaccinated and tested for hepatitis B. In the United States, many of these infants are lost to follow-up as soon as they leave the hospital. Denmark, and for that matter, virtually all other high-income countries, are not really peer nations. If we'd have any true peer nation, it would be our friends to the north, Canada. In Canada right now, hepatitis B vaccination recommendations for children are developed at the provincial or territorial level. However, recent studies in Canada have shown that universal hepatitis B birth dose is going to be needed to achieve elimination of Hep B in Canada, which is exactly what we learned here in the United States decades ago. They've also done economic studies in Canada and determined that universal hepatitis B birth dose is cost effective. And a number of professional societies, medical societies in Canada have already gone on record as advocating for a national change in policy to adopt universal hepatitis B birth dose. So let's talk about apples to apples, not apples to oranges.
Sir, can I ask a couple follow-up questions of you as the expert within the hepatitis branch? First off, I guess I am the nominal representative of fundamental immunology. If one generates a significant titer, such as indicated, that is explicitly demonstrating that there have been activation of both effector and memory cells of the adaptive immune system. And there's no reason to think that the if that population of effector and memory cells has been elicited after dose 1, that they are going to have any different kinetics over lifespan from those patients that have required dose 2 or dose 3 to get to that level of effector and memory cells. Is that a fair statement from your understanding of fundamental immunology?
I think it's a fair hypothesis to set forward. The problem, though, and this is a discussion that we have been having continuously, this meeting and the last meeting, is we don't have any data to actually demonstrate that that is in fact the case for hepatitis B vaccination. A number of committee members have called for doing controlled randomized clinical trials to demonstrate pretty much evidence for any assumption that we might like to make. There's a reasonable argument behind that. My suggestion would be that if the committee wanted to consider recommending a shorter course and fewer than 3 doses, that the committee would be well within its rights to make that as a recommendation and recommend that an appropriate trial be done. The manufacturers could then decide whether or not they wanted to do that. They could submit their data to FDA asking for a label change if they do in fact find that fewer than 3 doses is sufficient, and we could go from there. But I think at this point, we simply do not have the data to support recommending serology without really having any proof that that does in fact tell us what the long-term outcomes are going to be.
A fascinating argument that there might be a competitive advantage for manufacturer 1 versus manufacturer 2 with fewer doses. That certainly has been the trend historically in the vaccine community, and I'm grateful for that. So what I hear in sum is once again we face the dilemma of inadequate data, which is at the core of the angst of the practicing frontline physician, which is that decisions have to be made in managing patients in the absence of the full breadth of data that one might wish to have. A core issue here that we're not discussing, I believe, except perhaps Dr. Levy to some extent, is the right of self-determination. And by extension, the right of self-determination for the dependent from their caregivers. And what I'm hearing is the logic of public health, which is focused on maximizing the greatest good for the greatest number, and that we are the counterbalance to that is the need to respect the rights of the individual for self-determination. And this topic that we're on right now seems to me to be right at the center of that paradox between managing individual patients and focusing on the rights and interests of that particular patient in front of you, which is what practicing frontline physicians have to deal with all the time, and the interests of the maximizing greatest good for greatest number that drives public health policy. And my personal bias is to err on the side of enabling individual decision-making and individual rights over the rights of the collective. That's my personal preference. And I think that is at the heart of what we're dealing with here is whether I think we have to recognize that these advisories that go to the director of the CDC, who is the one that sets national policy, it's not the ACIP, that we are torn. To be honest, we're torn by these two conflicting points of view, and that doesn't mean that we're wrong or those that disagree are wrong. It means that there are these two fundamental differences of opinion about the rights of individuals versus the rights of society and the goals and objectives of society. And it seems to me that that is the essence of what we're dealing with. I'm seeing you nod. I'm very grateful to see you assent that this is not a trivial thing, and it reflects fundamental, frankly, philosophical disagreements about the role of public health in medical practice.
I think actually that we're nearly on the same page in terms of this issue of personal autonomy, informed consent, the doctor-patient relationship. And that is something that is uniquely reflected in U.S. policy and U.S. law, that an individual licensed medical provider has a great deal of discretion to deviate from guidelines, to deviate from label requirements. Off-label use is done all the time. What is important to keep in mind is that ACIP recommendations, CDC recommendations are our best recommendation at the policy level or at the population level for the entire country. It's simply not possible for us to look at every single individual case and make a decision about what's best for that particular baby, those particular set of parents. That's why we have individual practitioners who are making those decisions in conjunction with the parents, with adult patients when that's relevant. And I would never want to take that ability away from parents or from providers. What I'm saying is that we need to if the committee were to do anything, I would encourage you to consider just making a statement that these recommendations, all vaccine recommendations, are recommendations. They should not be treated as mandates. I agree with you that mandates that were put in place, which I'd like to point out were not put in place in almost all cases by CDC or the federal government, but were decisions that were made by state and local jurisdictions, are problematic. We have a lot of challenges with our culture and our traditions in this country with telling people what they must and must not do. But that's not what we're saying here. We're saying that at the population level, in the majority of cases, this is what the science shows is the best practice. If, speaking to a particular provider, if in working with your patient, the parents of your patient, you feel that that's not what's best for your patient, then that's the reason why you went to medical school. That's the reason why you've been entrusted with a license to practice medicine. And as long as you can justify your decision, then I don't think anyone at CDC is going to criticize you.
I am really, really grateful for that honest and open-hearted commentary. I can't. It actually brings tears to my eyes. Honestly, thank you so much for that. Now I have to return to my role as chairperson and stop editorializing.
I would like to jump in.
No, I'm sorry. I'm sorry. You're on the queue. You're on the queue.
Have had long
okay, the next person.
And you have not cut off other people in their comments.
The next person is Retzef Levy. You are on the list. I call Retzef Levy.
Okay, so first I want to join you, Robert. I really it was a tremendous important statement against mandates. I think it's good to know that we have consensus around that. I want to have quick reaction. So about the multiple the screening between doses. So if I understand correctly, what we know. We had a trial, and the success in the trial was measured by arriving to the seroconversion measured by the serology test. And the reason why we arrived to 3 doses was because that was when most people converted. So essentially, we are left now with a situation when, if I'm a parent and a physician, correctly so, I need to decide if I converted after 1 dose or after second dose. I need to decide whether I'm willing to take the risk that maybe despite me converting, I don't have full protection versus the risk of taking another dose. And I think, again, that goes back fundamentally to I think that there is one fundamental difference, and Dr. Meissner, I tremendously respect your perspectives, but I think that we have significant different view about the quality of the safety data that we currently have, and I think that's fair. That's why we have those discussions. I do want to, and Dr. Hiblin is going to go after me, but I do want to address Dr. Hiblin's initial comments. Because I think that
point of clarification. The list was yourself, Kirk, Cody, and then Joe.
Sure. So sorry. So I just want to address Dr. Hiblin's initial comment. So this is. I think that what is unique about this team that there are debates and different opinions, and they're going to be voted at the end. And I don't know what the outcome of this vote will be. I know what I'm going to vote. I think that we all need to respect that we will not like all the votes as team members. And I think it's more generalized to society, right? Like, we need to accept the fact that sometimes we will disagree, and the people that will make decisions are not going to make the decision we would like. And I think that we just need to not to suggest that because we don't like the decision, people didn't do the appropriate work in the work group or did not look on all the information. I just want to give an example. Like two meetings ago, there was a vote on RSV products. I voted against. The majority voted in favor, despite of what I perceived major risk signals from clinical trials. I still think that was not the optimal decision, but I think what I want to call out is that I want to respect the work group members that did a tremendous amount of work. With the CDC help, with experts, and I suggest that we don't mix up not liking the decision with trying to suggest that there is no rigorous process leading to those recommendations. Thank you.
Thank you, sir. The next on the list, just to recap now, we have Kirk, Cody, Joe, Tracy, and then I suggest we consider proceeding to our affiliates, liaisons. So with that, Dr. Milhound.
Thank you. With respect to Dr. Langer, I don't think we can say scientifically that there is no difference between 1 dose and 3 doses, especially in the infant period when we're going to be talking about aluminum and other adjuvants very soon. So I don't think we have that data. What I'd be interested to query from the CDC is if they have breakthrough in incomplete hepatitis B vaccine series. They should have that data. If that breakthrough, they'd want to know what the history was. So do they have any data in a hepatitis B infection in someone who had partial series versus full series? So those are my 2 thoughts. Oh, one last one is regarding the autonomy. I think this is important because if a mother or parents are thinking about 1 dose or 2 doses or 3 doses, and if we're going to use this number to say they're seroconverted, then we have to have data to say to the mother, yeah, you seroconverted, but you need more. Do we have that data? I don't think we have that data. So this is actually part of the decision-making, shared decision-making, that allows the parents more information if they're willing to take an additional dose. So I appreciate the idea of looking at this, and part of what we argue about is we have two different ways of looking at things, and some of us fall more on the side of patient physician decision making, and the other are looking at it from a public health. So thank you very much. I appreciate it. Bye.
Thank you. Next person, Dr. Meissner.
Thank you for the opportunity to comment. First of all, there's no question that parents have the key decision-making in administration of vaccines. But society also has to make recommendations in terms of an infant who is too young to make decisions for himself or herself. So essentially what we're doing is making a recommendation based on what we know and what we don't know. And we know that 3 doses given to the existing, according to the existing schedule, are safe and are effective in preventing hepatitis B. If the recommendation stays in place as it is, a parent can still decline the opportunity to have her child vaccinated against hepatitis B. The issue about the stress of delivery, I completely understand and I'm very sympathetic, but that doesn't mean we should take away what we know is safe and what we know is not effective. So whereas the mother has the final decision without any question, we also have a responsibility to think about the infant. We have plenty of evidence of efficacy. There is no evidence in regard to lack of safety. Yes, you are right. Maybe 2 doses would work. Maybe 1 dose would work. We are seeing that with the hepatitis B virus vaccine. There is data that's become available this week that suggests a single dose may be adequate, and we don't need to give 2. We started out with 3. It's a very interesting question, and I think Dr. Langer's comment that this might be something for the vaccine manufacturers to consider is an interesting one. I think I'm going to stop at that point. Over. Thank you.
Thank you for your wise counsel. Dr. Hiblin. Dr. Hiblin, are you muted?
Thank you very much. I appreciate you recognizing me. I want to respond first to Dr. Levy's comments. And his discussion was that there's a difference between not liking the decision and whether it was examined or not. And I'd like to clarify that it's not that I did or did not like decisions. It's that the decisions should be based on data. And it's not a matter of me liking or not liking. It's a matter of whether there was data presented to evaluate the questions. Well, after 4 months, there was no data presented on the question of giving vaccines before or after 3 months. So this is not a confusion between liking and that it was not examined. If it was examined, how come the data wasn't presented? It's not a matter of liking or not liking. It's a matter of presenting data or not. So what I was going to comment earlier on is that I agree with you, Dr. Malone, that we do not have exactly all of the data we would like to have to make decisions. That's the nature of science. We do the best that we can. And I also agree with you that we have to make decisions with the data that we have, and we must use only the credible data to make the decisions, and not speculations, and not hypotheses. So things like deciding or commenting about the 3-month issue because there may be differences in the baby's blood-brain barrier not being fully developed, or there may be some possibilities of harms that we don't know of. Well, those are all speculations, and those are all hypotheses, and they're not data-based. So thank you for that opportunity to comment.
Thank you, sir. I think the changes in pediatric blood-brain barrier and physiology are extremely well documented. Dr. Hogue.
It's a speculation regarding 3 months as to, yes, they're not matured. Yes, that's true. They're in development. But that is completely still a hypothesis that this impacts whether a dose should be given before or after 3 months. We must distinguish carefully between hypotheses and speculations as compared to substantive data. As you started off today and yesterday's meetings with giving that admonition to the council.
Okay, thank you.
To the
thank
committee.
you. Dr. Hogue.
Yes. So I actually just wanted to quickly respond to Dr. Adam Langer's comment from the CDC just about the differences between the U.S. and Denmark, just because I think there's a fundamental misconception. And that is, why scientifically and medically would we consider a baby or a child that is low risk for a disease such as hepatitis B, or we could even say the same example with COVID-19, that lives in Denmark or in the United States, if they have the same risk of exposure to the disease, should be vaccinated in one country but not the other, just because there's an imperfect healthcare system. There's not really a scientific basis for that. As a mother of children who were born in Denmark, moving to the United States, they were low risk there, they were low risk here. I couldn't understand why you would use a vaccine in one country but not the other for the same level of risk. So I think that's sort of, I think the frustration maybe that American parents face is if they know that their child is at low risk, why we as a country choose to try to vaccinate our way out of an imperfect healthcare system. And I think probably Canada is doing the same thing. And both of our countries, our country more than theirs, has a declining and very low level of trust in public health recommendations and in public health in general, whereas in Denmark there's a very high level of trust because they make recommendations based on the available science, acknowledging the known and the unknown risks and doing, very diligent harm-benefit analyses, and I'm going to get into that later in my talk. In my talk later today. So I just think that those are important things to consider, that we cannot just say that because our healthcare system is different, that there's a reason that we should have universal vaccination for low-risk children when they really face the same risk of the disease in the two different countries. So thanks.
Thank you, Dr. Hogue. Okay, I'm going to inject myself now into the stack. I just want to acknowledge the elephant in the room. And the specific elephant in this case has to do with cumulative risk across the entire childhood vaccine schedule. And that is a risk for which we do not have adequate data. I think we can all agree on that. That in its wisdom and practice, the Food and Drug Administration and the Centers for Disease Control and Prevention have focused almost exclusively on risks associated with a single product. And in the case of the childhood vaccine schedule, we have a potential cumulative risk of common components of vaccines which may sum to a greater risk than the risk of the individual products, since they are functionally co-administered within a very short time frame within the neonatal/pediatric population. And this is a topic that has been raised repeatedly by a variety of communities, and my point of view is that this topic has merit. It's the whole reason why we now have a childhood vaccine schedule working group. So I just, in sum, wanted to acknowledge that while we may not see individual risk within a given product, when we have a biologically active material that is in common across multiple products that are all being administered at the same time, and we don't have cumulative toxicology for that common material, and of course I'm referring to a specific category of adjuvants based on aluminum salts, which is just one of many categories of potential adjuvants. It happens to be one of the earliest ones, first discovered in the 1920s. But we don't know whether, this is another data gap, we don't know whether there is cumulative risk associated with this component of multiple pediatric vaccines that are administered essentially concurrently. So I just wanted to acknowledge that. Now, the next person on the queue is Dr. Blackburn.
Okay, I just wanted to acknowledge, as a mother of 2 young children, the important point that we're looking at regarding individual-based decision-making. For many families, particularly those who wish to delay or decline the birth dose, true choice has not been existing in practice. And I know many parents who have been dismissed from pediatric practices for wanting to discuss timing or spacing of vaccines. So if our goal is to support childhood safety and promote thoughtful, informed decision-making, then we must acknowledge this reality. And recommendations that emphasize parental choice and clinician consultation only work when families have access to clinicians who will continue to care for them. So no child should lose their medical home because their parents are engaging in the very individualized based decision-making that we're encouraging. And as we move forward, I believe it's important to consider how this recommendation will be implemented in real clinical settings and how we can ensure families are not left without care.
Thank you. So with that, I want to ensure that we have the opportunity to learn from the perspectives of our valued liaisons from the various societies, and gently remind that we strongly desire that those comments be restricted to 2 minutes, just in the interests of getting through the day. Now, the first person on the queue for our liaisons that have requested an opportunity to speak is Dr. Amy Middleman. Amy, are you there?
Yes, thank you so much. I want to be really respectful, and I appreciate the opportunity to talk. I want to redefine misinformation. Misinformation is false or inaccurate information that's spread without the intent to deceive. So I wanted to clarify that because I think this was directed at my comment from yesterday.
Yeah, I
As a hefty
apologize. I had
researcher-
heard, I must have misquoted you. I thought you said disinformation, not misinformation. If that's the case, I apologize.
No, and that's okay. I mean, I think, misinformation, the assumption is that there's absolutely no intent to harm or deceive. And I believe that about this committee. I think we all can agree that we're looking out for the best interests of children. But as a hefty researcher, I can confirm there has been a lot of misinformation presented in the last couple of days, and it would take a long time to go through it. One example is the surveillance system that comprised the graph about acute hepatitis B cases probably also doesn't show a decrease in infant cases because infant cases are very rarely symptomatic. There was a misinterpretation of the conclusions of my own study. There's been misinformation about serologies and what they mean versus cellular immunity. Many have demurred as not being hepatitis B experts. Again, I would urge that we go back to our true experts who do this all of the time, our amazing CDC colleagues who live and breathe this data every day. They could have actually vetted those kinds of pieces of misinformation before they were presented to the public. It's so important to responsibly present this information to the public. As Dr. Malone, you said, it's not about speed, but rigor. And I think we need to really vet this vote very carefully with a systematic process and with rigor.
Okay, thank you. That's
mentioned.
Amy, if you don't mind, I'm very grateful for that. We did have a timer set up, and you're a little bit over it. Forgive me, but I certainly appreciate your commentary and advice. Can we move to
I
Dr.
don't think it's 2 minutes.
It was 2 minutes. It was 2 minutes. Can we please proceed? Can we please proceed to Dr. Schley?
Amy, do you want to finish?
And Amy, if you don't mind, I put you on the end of the queue to finish your statement after we get through the others. Is that acceptable?
Will I definitely be able to speak?
If that assumes that your colleagues are similarly constrained in their comments. Okay, let's allow them to get through.
Thank you. I appreciate that. That's very kind.
Okay, Dr. Schley.
Okay. Yeah, hi, this is Judy Schley from representing NACHO. One thing I wanted to bring up was in regard to the HBV birth dose, to have the 2-month requirement is probably inappropriate because some parents may delay the birth dose, but they might come at 2 weeks or the couple days after delivery when they come and see the nurse and say they want to get it then. So I think we should not restrict that it has to be a 2-month time period. I personally do not believe that we should even vote on this birth dose changes at all, but I will, if we do vote for that, I would say the 2-month period should be stricken. The other thing is, I think that before we can say about serology after an initial dose, that we should do the studies first to know if one dose causes protection. Like we've done with the HPV vaccine, we have been able to reduce the number of vaccines because rigorous trials have been done to show that we don't need as many doses, especially in younger children. So we need to think about that. Thank you very much.
Thank you, and thank you for taking less than 2 minutes. Just a point of clarification in vote 1, the language is for those not receiving the hepatitis B birth dose, it is suggested that the initial dose be administered no earlier than 2 months of age. So this is not a recommendation that is as prescriptive as perhaps you might have imagined. The wording is suggested.
Thank you, Dr. Malone. I would just suggest that we actually not even have that in there, that it allows, there's no discussion. It's if that we do have this vote on vote 1 and change this, that we don't even say that there's a suggestion of anything. It's really any time that the parent and the provider discusses it and decides to vaccinate.
Duly noted. Thank you. Dr. Goldman, please share your 2-minute summary of your point of view, if you don't mind.
Thank you. First, I agree with you on the principles of scientific inquiry and rigor that you opened the meeting with. I would just like to see this committee actually use it in practice. In addition, I would ask that the members of this committee listen to the liaisons and not use it as their personal time to eat into hours to pontificate. In addition, your concern of COVID mandates, if they're there, why are we trying to change the Hep B schedule when your concerns are over COVID mandates? Where is a universal recommendation considered a mandate as opposed to a simple recommendation? If your problem is with informed consent, why are we trying to change the recommendations that are not supported by evidence? Where is the detailed drill down of which stakeholders want changed? Is it a majority of the country, or is it just a small segment who oppose the birth dose on ideology and not on science? Where is your cost analysis of serology testing, and have you considered the difficulty of implementation by having to bring children back for blood draws, adding another layer of burden to this healthcare system? Why are you comparing it to countries with universal healthcare, which we do not have? What do you do with those patients who do not have insurance and cannot have access to care to get that testing? Where is your data on the serology for one dose giving lifelong protection? And in deference to statements made, we do not make recommendations by asking our friends if they know who has been infected, but rather what does the evidence and data show? School mandates do not have any relevance to a birth dose vaccine that we are discussing today. This vote is an unnecessary solution looking to find a problem to solve. It will not fix your concerns of informed consent, but it only endanger children and increase risk of death for millions. Your role is population health, not the individual. We are looking at what are the population risks and how do we make those recommendations. As a physician with over 25 years of direct patient care experience and representing 160,000 internal medicine specialists throughout the world, the largest single specialty organization in the world, I urge this committee to do the right thing, do no harm, and reject all of these votes. Thank you.
Thank you, Dr. Goldman, for schooling us on what our proper role in charter is. I am grateful for your teaching.
My pleasure.
Dr.
I'm happy to
Munoz.
assist.
Dr. Munoz.
Thank you so much for the opportunity to speak on behalf of IDSA. I wanted to just address the voting language and just support the comments from Dr. Hilbert and Dr. Meisner. I would really have concerns regarding any of the language here, and wanted to share with you why we in the professional societies, why practicing physicians, and even the public who have had the opportunity to express their opinion in the context of this meeting have concerns. The concerns relate to the lack of scientific framework for decision making or lack of data to support the changes that are expressed in these votes. There's also concern about some members of this committee pushing assumptions made on personal opinion and no data, again, to support it, with incorrect or inadequate interpretation of actual information that is already available, including understanding proper immunology. I also would like to highlight the fact that the remit of the CDC is public health, and ensuring the public health is really the goal of recommendations. Recommendations are not mandates. We have already addressed many times the issue of consent not being solved with these changes. And actually what these changes will do is actually undermine the trust that people have, because people are now confused with the discussions that have been taking place in this meeting, with the fact that doubts have been casted regarding not just the existence of data and the fact that 30 years of information regarding the safety and efficacy of these vaccines are very strong to continue to support the existing recommendation, but of the intent of these discussions today. I support completely the data and the statement from Dr. Langer regarding comparison with other countries and how we need to address the needs for our country and our people. Some of us do international work. and
Okay,
see
but
the
that's
success
you're
of
you're
this.
now over 2 minutes, so I need to please move on to Dr. Bagdasarian.
I'll just finish with a statement to say that we please would like to ask for your responsible decision to dismiss this vote if you really are with the best interest in the public in mind.
Thank you, Dr. Munoz. Dr. Bagdasarian.
Thank you so much. I'm speaking on behalf of ASTO. I am a practicing infectious disease physician, and I have seen firsthand the consequences of hepatitis B. In my role as a state health official, I also engage with health providers across my state. And I'd like to give you an understanding of some of the real world implications of a vote like this. One concern I've heard again and again is when a specific vaccine recommendation includes excessive language around shared clinical decision making, it actually creates barriers to care. Many healthcare providers interpret it as a sign that the vaccine is controversial, that additional steps are required, or that they may be exposed to additional liability. Now, I have heard from multiple people on this panel that you are committed to ensuring vaccine choice. I believe that is the case. I believe that you don't want to create obstacles for those seeking the protection of vaccines. Informed consent has always been a cornerstone of medical care, and I think it should be emphasized for all clinical recommendations, not just for specific vaccines. When it comes to vaccine guidance, healthcare providers are looking for clear population-level guidance, and adding excessive or ambiguous language around shared decision-making for routine vaccines muddies the waters, creates a false sense of scientific uncertainty, and places unnecessary burden on clinicians and families. I also want to point out that this group has discussed improving hepatitis B screening for pregnant women. And that, of course, would be ideal, but we should be realistic here. We've seen how difficult this is with congenital syphilis. In my state, we review every single maternal case with missed screening opportunities for congenital syphilis, and these mothers usually had no prenatal care at all, or care that was fragmented and inconsistent.
You have
Our
15,
healthcare
you have
system
10,
is not
10
seamless,
seconds
and
left,
people,
just to let you know. It's 10 seconds
Okay.
left. Please wrap up.
Weakening or removing the universal birth dose recommendation would widen those cracks, and I urge this committee to consider not just the theoretical implications of its decisions, but the real-world impact on the children we're here to protect. Thank you.
I think we all have shared consensus. Now, we're running out of time, but I promised Dr. Middleman a second bite at the apple. So, Dr. Middleman, can you please carry on with your comments?
Thank you so much. I will try to make it as brief as possible. I just want to say I believe that historically risk of disease acquisition always goes down with a successful immunization program, and that's what this is. This vote to weaken the hepatitis B birth dose recommendation will be the first time in my 21 years of experience as a liaison to ACIP that ACIP is voting on a policy that, based on all of the available and credible evidence versus benefits and harms, regarding benefits versus harms, it actually puts children in this country at higher risk rather than lower risk of disease and death. Data show that the universal hepatitis B birth dose recommendation increases adherence to the vaccination series. Any policy that weakens the recommendation and allows children to potentially fall through the cracks of an imperfect medical system will harm children. We need to create policy that understands this and protects the children of this country. Thank you very much.
Thank you very much for a well-reasoned and succinct comment. Now, with that, I apologize to our other liaisons, but we do need to move on. And at this point in the agenda, by the way, we're way over time. We are asked to have a 5-minute break before we will have a presentation from the Vaccines for Children representative. We break for 5 and then reconvene at 10:05. Thank you. Okay, we're reconvening now after our break. I'm obligated to do a roll call. Dr. Pollack.
Dr. Pollack here, no conflicts.
Dr. Stein.
Catherine Stein, no conflicts.
Dr. Levy.
Retzef Levy, no conflicts.
Dr. Pebsworth.
Dr. Pebsworth, no conflicts.
Dr. Malone, no conflict. Dr. Griffin.
Dr. Evelyn Griffin, no conflicts of interest.
Dr. Blackburn.
Hillary Blackburn, no conflicts.
Dr. Pagano.
Dr. Pagano, no conflicts.
And our ex officios, Dr. Hoag. I apologize. I did it again. Dr. Meissner. Dr. Meissner, are you with us? Calling Dr. Meissner. Hopefully he'll join us in a moment. Perhaps he's taking a bathroom break. Dr. Milhound.
Dr. Kirk Melhone, no conflicts.
Dr. Hiblin.
Joseph Hiblin, here, no conflicts.
Dr. Meissner. Once again, Dr. Meissner. Dr. Meissner, if Dr. Meissner becomes available, we will acknowledge him and ask him about conflicts of interest. We're about to move into. Dr. Meissner, there you are.
Sorry, I'm back.
Okay, name and conflicts of interest, please, sir.
Meissner, no conflicts of interest.
Thank you, sir. I have a clarification from the parliamentarian from the CDC that as we head into the vote, I wanted to make explicit. The chairperson of this committee is Dr. Milhound. As chair, in the event that we have a tie on any votes, Dr. Milhound will be responsible for breaking that tie. I'm just acting in his stead as vice chair. But so long as he's available, then he will be the one empowered to break any ties. Just want to make that clear. Now that we've taken care of that business, what are you pointing to? Yep, I made that clear. Okay, so now we move into the real business of today, not to diminish our presentations after the break, which has to do with the upcoming vote and the voting language. Dr. Santoli, who is on the schedule from the VFC, has indicated that her prior comments stand, and so it's not necessary for her to present again regarding the Vaccines for Children program. The same holds true with our representative from CMS who's just arrived. Dr. Johnson, do you concur? Is there a reason? Do you wish to make additional comments prior to our discussing the vote?
Not on the current language as proposed.
Thank you, sir. So then we've moved past that, and we now move into the substance. The floor is open for commentary focused specifically on the voting language right now, and any proposals for modifications or motions to proceed to vote. So I recognize, looking, Dr. Pollack, I recognize.
I think, I'm not sure of the parliamentary rules here, but I think first you need to make a motion and have it seconded and then have the discussion. Or are you doing it the other way around?
If you wish, please, do I have a motion, Dr. Pollack? Yeah, I'm the chair, so I'm hamstrung.
Okay, I move that we open the discussion on vote number 1.
Do we have a second?
I second.
Any objections? Let's proceed. Discussion on vote number 1. Comments?
So I can open the discussion. Based on my previous comments on vote number 1, I guess informed consent is inherent in the practice of medicine. And what we are doing by vote number 1 is subsuming that our colleagues in obstetrics and other branches of medicine in dealing with this problem in pregnant women and newborn are actually not providing appropriate informed consent. So I have some concern with the way this is worded, because I think, again, as I mentioned before, some of it is redundant. Secondly, the notion that we're going to wait until earlier than 2 months, even though it's a suggestion, again hamstrings the practice of our colleagues in pediatrics. And I'd like to hear from perhaps Dr. Meisner and others on the committee how this would impact the practice of pediatricians. My sense is that they probably will ignore it and go ahead and vaccinate their children per the current schedule. And there's also a tension between this 2-month recommendation and the statement at the top of the page, which also it conflicts with the current published CDC guidelines in the vaccination schedule for infants and neonates. So given the way the language is now, I would probably have to vote no on vote number 1 and be interested to hear from the rest of the group and others how they feel about this vote number 1.
Dr. Pollack is calling for other opinions, particularly from others that are practicing in pediatrics. And specifically, Cody was requested.
Yep. I'm here if I may respond.
That you were specifically called out to respond, sir.
Yeah, thank you, Dr. Pollack, for that important question. I think let me first answer your specific question, and then I had my hand up because I have a few comments. I am hopeful that pediatricians will continue to administer the birth dose within the first 24 hours of delivery and before discharge from the hospital. I think to follow any other course is not in the interest of the infant. As we've repeatedly stated, there is no evidence of harm, and there's no reason to think that the outcome would be different if the vaccine were administered at 2 months of age instead of 1 month of age, except for there will be more children who will be injured, who will catch the infection. I also want to note that one of the liaisons said that this would increase the risk of death for millions of children. I think that was a hyperbole. It will not increase the risk of death for millions of children. But it will certainly increase the risk of hepatocellular carcinoma, cirrhosis, early premature death to a number of children, whether that's low thousands or high thousands, I don't know. It isn't going to affect millions of children. The other point that I wanted to make is that this disease has become a victim of the vaccine. That is, we're seeing disease rates go down because of the effectiveness of the vaccine. But that doesn't mean that the virus has gone away. And it really means the vaccine is working effectively. So it's a mistake to say because we're not seeing so much disease, we can alter the routes or the frequency or the schedule for administration, because we will see hepatitis B infections come back. The vaccine is so effective. It does not make sense in my mind to change the immunization schedule. So I'm quite uncomfortable with the wording in vote number 1. Over.
Thank you very much for that comment. Dr. Hiblin, recognize you. You're on mute, Joe.
Many of my critical questions have been discussed by Dr. Meisner. With regards to all of the questions, we were requested to present our scientific framework for evaluating these decisions, and I've prepared a brief address of 11 questions of the evidence the recommendations framework. I will not address all of them for time and brevity.
But
there's a
Joe,
few
right
critical
now,
ones.
I'm sorry to interrupt you, but right now we're focused on the question and the wording of the question. We've already talked about the substance. Can you constrain your comments to the wording of the vote question? That is what is on the table right now.
Certainly. Number one, the preamble is not giving us any opportunity to agree or disagree with it. It is not logical because the status of unknown mothers is not part of the current recommendation. Vote number one, again, as I have described, the issues in the data of 2 months of age were not discussed and presented in the 3 months since the last meeting. Vote number two, we've had a long discussion.
But vote number
about
two is not open for discussion right now. So
Okay,
thank you.
Fine, I'm done.
Okay, thank you. Dr. Milhound.
I believe that the work group has tried very, very hard not to decrease access at all. And I think we need to be very careful of thinking hypothetically when we've been asked to regard in terms of what we're making available. We are trying to actually follow the data that we have as best as we can. And so I think it's very important we've made sure we've gone to great lengths that we've given doctors and patients the freedom, and we've made sure that it was paid for. And so we have a very, very, very low risk disease, and we're giving a shared decision making for that. I don't, as a person who has to counsel children, I've been doing this for over 20 years. I don't have any problem with that. And I have the freedom in this vote to either do it at birth or do it whenever I like by shared decision making. So those are all options. So I don't look at this as being a difficulty to me as a practicing pediatrician or pediatric cardiologist. Over.
So, Dr. Levy.
Yeah, so I just want to point out that I believe that the use of individual decision-making reflects a purpose to basically assert that the broad recommendation that currently exists is not appropriate, and that we don't believe that you can make gross recommendations to all the babies that were born to moms that were tested negative for Hep B. And moreover, I think that the 2 month is no earlier, but I think that the intention behind is that parents should carefully think about whether they want to take the risk of giving another vaccine to their child. And many of them might decide that they want to wait far more than 2 months, maybe years, and maybe up to adulthood. I think that's going to be up to them and their physician. So I think that this is not just merely reinforcing a concept that currently exists. It's actually suggesting a fundamental change in the approach to this vaccine and maybe more broadly. And I feel that no language is perfect, but it's doing a pretty good job.
Okay, I'm going to opine on just a couple of things that I think are clear facts, hopefully, that we can all agree on. One is that whatever transpires here, there is a document. It's actually a graphic a spreadsheet of sorts published by the Centers for Disease Control and Prevention that will reflect whatever is or is not decided today in terms of language. So that is one consequence. It's not just advisory. It's actually reduced into a document that, and here's the second clause, there are many states which, I'm choosing my words, have chosen to accept as their policy whatever the policies are of the CDC. So it's not, this is not in the abstract, and I think we all need to acknowledge that the truth is that whatever does or doesn't happen here, will impact on some fraction of the United States population, acknowledging its states that have the right to regulate the practice of medicine, but many of these states feel it's most appropriate to accept without modification the recommendations of the director of the CDC. Again, please, it's not ACIP that sets policy, it's the appointed director of the CDC. So what we are debating is the advice that we would provide to the director of the CDC about whether there should or should not be any changes in current CDC communications and public recommendations if the director of the CDC concurs with our recommendations. That's where we're at. So I've said enough on that. Others, Dr. Pagano.
Yeah, just as a matter of clarification, the preamble was placed here merely for information purposes only. We're not being asked to vote on anything in the preamble. So that shouldn't be conflated with the body of the vote language. And as far as the language of vote 1, have been comments made about the redundancy of certain things in there. I personally do not find them to be overly objectionable, and I think it adds perhaps a bit more clarity to what it is we're trying to do. There is a suggestion that we can delay that first dose to the 2-month range without getting back and rehashing why that might be the case. It's still in the language here, provides the opportunity for the individual parent and physician to administer it sometime before that, should they deem that to be the reasonable course. That's it.
Thank you. Dr. Griffin.
Thank you. And dovetailing off of what Dr. Pagano said regarding the redundancy, language is important, and the more we say it, the more we remind ourselves of what we need to do. And one of the highest ethical principles we need to live by is do no harm, and through informed consent, we remind ourselves with every interaction with patients to do this. So I would be fine if we'd be more redundant. I think it's very important to keep reminding ourselves of this. With respect to the program and commentary on how this program started out, the history of it, in 2005, listening to the proceedings and decision on how this infant program was decided to be moved to within the first 24 hours of birth, there was commentary that was made with regards to and perhaps defining this safety net. And it was spoken and said, transcribed, although infants who require post-exposure immunoprophylaxis should be identified, administering a birth dose to infants serves as a safety net to prevent perinatal infection amongst infants born to hepatitis surface antigen positive mothers who are not identified because of errors in maternal hepatitis surface antigen or surface antibody testing or failures in reporting of these test results. So this safety net it looks like a big part of this decision. There was long discussion afterwards as to what these errors were. And we know that medical errors are a large proportion of the, even there are death rates that are due to medical errors. So this is a real problem that was addressed in this manner. So I do have a problem with treating our babies as a safety net. I obviously do not want any babies to be missed and to have infection, but there was a discussion of safety net built in a completely different context. Thank you.
I motion to vote.
There's a motion to proceed to vote. Do we have a second?
I second.
Do we need a motion? I'm sorry, to be technically correct, I probably need a motion and concurrence to close discussion first.
Motion to close discussion.
Second.
Seconded. Any objections? I'm looking specifically just to cross-check with our online community. Hearing no objections, then we have closed discussion. I'm open for a motion to proceed to vote.
Motion to proceed to vote.
I second.
Seconded. Do we need a vote? Are there objections to proceeding to vote? I seeing none. Then I'm going to go ahead and call for the vote. I think that's my proper role, acknowledging that once again, if we have a tie, it is up to our chair, who is there broadcasting from God only knows where, Hong Kong, who would break the tie. So I'm going to move Dr. Pollack, yay or nay on vote 1.
Going to vote no, no conflicts of interest.
Pollack says no. Stein?
Vote yes, no conflict of interest.
Dr. Levy?
I vote yes, no conflicts of interest.
Dr. Pebsworth?
Vicki Pebsworth, no conflicts of interest. I vote yes.
Malone, no conflicts of interest, yes. Griffin?
Evelyn Griffin, no conflicts of interest. I vote yes.
Dr. Blackburn?
Blackburn, the language offers flexibility, access, coverage at any time. I vote yes.
Do you have conflicts of interest?
No.
Dr. Pagano?
James Pagano, no conflicts, yes.
Dr. Meissner? You're on mute. I apologize. Cody?
I'm sorry. Thank you for the reminder. I have no conflicts. And I will just say, we've heard do no harm is a moral imperative. We are doing harm by changing this wording. And I vote no.
Roger. Dr. Milhound?
Dr. Kirk Milhound, no conflicts of interest. I vote yes.
Dr. Hiblin?
Dr. Hiblin, no conflicts of interest. I agree with Dr. Meisner that this has a great potential to cause harm, and I simply hope that the committee will accept its responsibility when this harm is caused, and I vote no.
Roger that. For our DFO, what is the result of the vote? The DFO has transcribed 8 votes yes and 3 votes no. The motion passes. Do we have a motion to proceed to discuss on vote 2?
Dr. Pollack, here make a motion to discuss vote 2.
Do we have a second?
Second.
Are there objections to proceeding to discuss vote 2? Hearing none, the floor is open. I notice Dr. Pollack is requesting.
Thank you, Dr. Malone. In discussing the language for vote 2, there are a number of problems with the language. I'm not sure what the term children means in this context. Are children aged 0 to 18, or are we talking about neonates or children in general? So I have a concern about how we define children. The second concern is, if you read the first sentence, parents should consult with healthcare providers. So this places the onus on the parents to approach the healthcare provider and presumes that the parent actually has has an understanding of a very complex and difficult practice management problem. I'm not sure that parents, with great deference to the parents in Denmark and elsewhere, I have to agree that our patient population in the United States is very different culturally. Many of them are not well versed in the nuances of vaccination, biology, and immunology, and placing the onus on parents to consult with their healthcare providers, I think, is perhaps disingenuous, and perhaps it should have been worded the other way around, that physicians should consult with patients in order to discuss whether this strategy should be adopted. Thirdly, while this is a wonderful attempt to mimic the management and treatment of other viral diseases, such as in my own practice, say with cytomegalovirus and hepatitis C, where we closely monitor viral loads and serology in applying our therapeutic armamentarium, this is not quite the same. And to emphasize what has been said earlier, we have no data on whether monitoring serology actually implies immunity, whether one dose is given or three. In practical terms, I think what will happen out in the world of pediatrics is that the practicing physician will follow the current three-dose protocol, because the published CDC data suggests that 3 doses does provide 95% protection, whereas the data for any fewer doses is lacking. And given the fact that our committee is supposedly data-driven, I would urge that the vote, a no vote on vote 2 until, we can properly consider the kinds of concerns that I have with regard to the language. Thank you.
Who else would like Dr. Levy?
Yeah, I hear the argument. I think that the way to perceive this vote is, again, in the realm of giving choice and empower patients. I think we should not underestimate any patient, and I think that the dilemma that this is addressing is we had clinical trials that basically treat additional doses as nothing. So we had a metric that is being captured here by the serology test, and we wanted to ensure that everybody, or almost everybody, converts. That doesn't mean that, given this uncertainty, every single patient would like to take 3 doses. I think there is it's reasonable to hypothesize that if you convert it after 1 or after 2 doses, you have reasonable protection. I think at that point you are balancing the risk of taking another dose of the vaccine versus the risk that maybe that hypothesis is not correct. We should be honest that we don't know the answer, but in the face of uncertainty, we should let patients and their providers to make that choice between what uncertainty they want to embrace.
I have a point of order to discuss.
Oh, please do share.
Are we in the category of discussing these questions, or are we in the category of discussing the wording, or are we currently in the category of voting?
We're clearly not in the category of voting, so please share.
What is the current motion that we are discussing?
Discussion focused on the language in particular.
The language in particular, okay, because your comments did not address language, nor did many of the other presenters. And as I was presenting language, discussions on language, I was cut off. So I just want to know exactly where we are in the motions.
The floor is open to you. Do you have any comments that you wish to share regarding vote number 2?
Not at this time, thank you.
Thank you, sir. Evelyn, Dr. Griffin.
Definition for children is a little different depending on what global institution is used, but the CDC refers to anybody under 19, legal perspective 18 and under. But Dr. Pollack, would you consider parents may consult with healthcare providers?
Could you?
For language?
Could you rephrase the question?
She's suggesting the language in asking your opinion on her suggestion.
May would be fine. Should is more explicit, and I think may perhaps is a little better.
Would you change your vote as a result of that, if I may ask? Is that something that changed your understanding about the vote?
Okay,
my point is that
careful.
Sorry,
if that's not an allowed question, I'm sorry. I've just been coached on that.
Yeah, you could change it to May. That's fine.
Okay, have Dr. Griffin, have your comments been addressed? Do we have further discussion regarding the language here? Dr. Pagano.
Hi, without trying to garble this more than it is, may works, but when possible also works. And I think that takes into consideration the difficulty people may have getting back and forth to have multiple visits to first have a lab draw done, then to return to get a vaccine. It would be helpful to have that data, since everybody complains about the fact that we don't have sufficient data to make decisions, and this would be a great way to collect it, but I don't know that we necessarily want to make it so burdensome that people may not show up. So when possible makes some sense.
And I'm as a experimentalist and trialist, I am really intrigued by the possibilities that this recommendation might open up. Dr. Meissner.
Thank you, Dr. Malone.
Yeah, we'll get there.
Couple of comments. I think that Retzef, I was surprised at your last comment. I very respectfully, for a man with your accomplishments and full professorship at MIT, I'm surprised to hear you say that one dose may be as effective as 3, and that may suffice. There are absolutely no data to support that. And just because we achieve a serologic titer of that we're trying to pass based on our limited understanding of a correlate of protection that passes 10 after one dose of a vaccine, that we would get the same immune response as we would after a series of 3 doses. I think it's an important question. I think it is one area of potential investigation, but the risk of harm is great if we do not complete the hepatitis B immunization schedule. I just have to say again, there is no evidence of harm. People talk about a blood-brain barrier. Yes, it's different in infants than it is in older children and adults. But what does that have to do with reactions to the vaccine? I mean, you can always find something if you look hard enough that you want to worry about. I just don't understand what people are worried about if we deviate from the current recommended immunization schedule, which we have shown, or the CDC has shown, is beneficial. There is no evidence of harm, and I'll stop at that point. Thank you.
But can I ask a point of clarification? Are there specific comments that you wish to make regarding the wording on vote 2?
Well, yes, thank you. I earlier on I've tried to make that statement. That is, we have no idea if less than 3 doses of the vaccine will be protective. We're not only worried about infection in the neonatal period, we're worried about infection throughout life. Yes, it's rare, but we know that intravenous drug abuse and sexual practices play an important role in hepatitis B transmission. We cannot identify, it's been shown that we cannot identify high-risk behavior. The safest way to protect the children, and it's not to protect society, it's to protect the children, is to administer the recommended hepatitis B series starting in the first 24 hours of life.
Good. So I respect, and we have heard that you've shared that opinion. but you have no specific recommendations on modification of the wording, is what I'm hearing. Dr. Milhouse.
Yes, I'd vote against. I'm going to vote against this. Yes.
Which is absolutely your prerogative, and I respect that. Dr. Milhouse.
As we consider this and talk about this, it sort of seems like we have two different things. Like it was okay to use a zero conversion to approve this, but now we're questioning whether that's adequate to actually say if we had an effect. When we use this for healthcare providers and others, it seems like we were okay with it to approve it, but not okay to see if it worked. I know this isn't the same vaccine, but when I go to Africa, to a highly endemic place with yellow fever, I get one vaccine. I didn't get a whole selection. And maybe it's time that we just really, for the first time, do the study. But as I said before, a lot of this stuff could be answered if the CDC would show us if there's breakthrough data, which I've never heard of any, on uncompleted vaccine series. This is a pretty large assumption that everybody needs 3, especially if we're going to use it. And this wasn't for efficacy. This was for seroconversion in the population with 3 doses. So if we take that as the point, then we're missing 1 in 20. Are people concerned about the 1 in 20 that might not be covered? So I think this actually plays both ways. It's interesting to see if we need more than 1. And that's probably different depending on when you got your first dose. There's some compelling data by the CDC contractor, Dr. Nevison. So that's interesting, but it's also, maybe it's a reassurance. Do people really know how well we know this has worked? Are they 1 in the 20? Some people wouldn't like those odds. We're saying you're all immune, but maybe some people don't like 1 in 20. I look at this as not like I'm trying to do this or I'm trying to do that. I'm just trying to give the families more information to decide, does it look like they're covered or doesn't look like they're covered? So I don't look at this as like I'm trying to burden someone. I'm trying to give families more information. That's how I would look at this. Thank you. And I don't have any problems with the language. I also wouldn't bother me if they changed it to may.
Can I get a point of clarification on this topic from Dr. Pebsworth, who chaired the committee? As I had understood this language, the testing opened the opportunity that for that 1 in 5 approximately who failed to technically seroconvert, that they might receive yet another administration of the product. This
1 in 20. It's 5%. 1 in 20, Robert.
So if it's 1 in 20, so for those that do not seroconvert after 3, this would leave open the opportunity to administer a 4th dose. Was that the intent? So Dr. Milhound is nodding in assent. So that's the clarification I wanted to make, was that this is this cuts both ways. That for the 1 in 20 who don't convert after 3, this would give information to parents about whether or not they wish to proceed with a 4th dose. With that clarification, I recognize Dr. Hindley.
Robert, can I comment on this? Because I think there's a lot of confusion. Yes. Okay, so I'll go ahead. First of all, yellow fever, there is no comparison with the yellow fever vaccine. That is an RNA flavivirus. It's completely different than the hepatitis B DNA virus. So I'm glad to hear you got the vaccine. That was the appropriate decision, and you got the appropriate number of doses. So I applaud that. But the point is, the point is that 10 million international units after 3 doses, if that's measured within 3 months after 3 doses, we know that's associated with lifelong protection as far as we know. We do not know if 10 milli-international units after a single dose confers lifelong immunity. So these are completely different conversations. I completely agree with Dr. Milhan that it would be nice to have the data, but we don't have the data. And in the absence of the data, and in the absence of any evidence of harm from the 3-dose series, it's very difficult for me to understand how we can make a recommendation for a change. We are going to experience increased rates of hepatitis B, and it is not the right thing for us to do. Over.
Thank you for that comment, Dr. Hiblin.
I will direct my comments towards the wording of the language. The context is that it has been identified that the hepatitis B vaccine program is one of the world's greatest achievements in medical health in the protection of children. And I will reassert that for that reason, we have a very high bar to consider before we make any changes to the current program. With regards to the language of this vote, of vote 2, the language has been confusing. The science behind the language has been confusing. There has been a great deal of discordant discussion in the limited time to address this question. So I would propose that the entire block of language for the vote be completely eliminated. That's my personal opinion, because we have to make our decisions based on data and not speculations, and we have to make our decisions on a careful consideration of the data, which has not occurred for this question. Thank you.
Roger, so entirely eliminating the data, just point of clarification, entirely eliminating the text would be equivalent to voting no on vote 2. Is that a fair statement?
We were only discussing at this point the modifying the text, and it is my opinion that the language should be completely eliminated. And you can interpret that if you desire as a no vote, but that has not yet occurred because we haven't moved on to voting.
Roger that. Dr. Milhan.
Interesting. I just got an email from one of the people on the work group who's a pediatrician, and he was saying he often has children say, "Well, how do I need?" The parent asks, "How do I know they need these extra doses?" I would be very happy if we were to vote to recommend that this needs to be studied. That would also serve the purpose to me, is that there's a paucity of data. There's a lot of speculation being called science. We are speculating about lifelong immunity. Adults are being treated differently depending on what their seroprevalence is, depending on what their risks are. And so I think that if you look at all around the world, 10 is typically used as the number. But if this is, to me, just to move this ball forward and ask for this to be studied, so we know. And I disagree that there's no, Dr. Miser, it is not true to say there's no risk at all. You cannot say this is 100% without risk. So you might say population-wise statistically, but for the parent who has damage, as the father who spoke the other day, we can't say that this has zero risk. So I would be very happy to move language to request full studies being done to look at dosages needed, or how we're going to evaluate when a child is truly immune. Because right now we accepted seroconversion. And if that's not true, then I'm not sure how we're going to back out of that.
So,
thank you.
Robert? Dr. Griffin is next in the queue, and then Dr. Levy. Dr. Levy.
Yeah, I appreciate the last proposal, but I think the discussion is also recorded, and
CDC director and other agencies are, it's accessible to them. I think the sentiment is very clear. I would like to motion to conclude the discussion with the hope that we can vote on the current version. No version is going to be perfect. I did not hear any substantial changes that are going to make this vote fundamentally different. I think we should be ready to vote, so I motion to conclude the discussion.
We have a motion to conclude discussion. Do we have a second?
Second.
Okay, we have motion and second. Are there any objections? We've moved beyond the open discussion period. Is there a motion to amend or not?
I motion to vote.
We have a motion to proceed to vote.
Second.
We have a seconded. Objections? Let's proceed to vote then. I'm going to call the roll. Dr. Pollack, on vote on question 2, yea or nay, and whether you have COI.
Raymond Pollack, I vote no, and no conflicts of interest.
Dr. Stein.
Catherine Stein, no conflicts of interest, and I abstain.
Abstain. Dr. Levy.
Retzef Levy, I vote yes, no conflicts of interest.
Dr. Pebsworth.
Vicki Pebsworth, no conflicts of interest. I vote yes.
Dr. Malone, no COI, yay. Dr. Griffin.
Dr. Griffin, no conflicts of interest. I vote yes.
Dr. Blackburn.
Hillary Blackburn, no conflicts. I support looking at studies. I vote no on this language.
Dr. Pagano.
Dr. Pagano, no conflicts, yes.
Dr. Meissner.
I vote no.
COI?
I have no conflict of interest. Strong no.
Thank you, sir. Dr. Hiblin. Dr. Hiblin, you're on mute again. I appreciate that you do that, but we need to hear your voice. You're still muted, Dr. Hiblin.
Thank you, sir.
There we go.
Thank you for your acknowledgement. I will try to improve my behavior. I have no conflicts of interest, and I vote no.
Thank you, sir. Dr. Milhound.
Hi, Kirk Milhound, no conflicts of interest. I vote yes.
Okay, what is our head count DFO? One moment. So we have a vote for the record of 6 in favor, 4 opposition, and 1 abstain. The motion passes. That brings us to our break, which we're half an hour behind time, but I certainly look forward to having 5 minutes to visit the facilities. I don't know about anybody else. I'm sorry, we have I thought that we already heard from the VFC. I apologize.
It's a vote on the resolution that we looked at yesterday. It hasn't changed, but it's the opportunity for the committee to vote about approving that.
I see. So we have another vote. Is that right? The vote on whether or not to approve the VFC resolution presented yesterday. So again, I will, VFC, can you briefly summarize the issue on the table for a vote?
So we looked at this yesterday. I'll just mentally walk you through. There was, the purpose of the resolution was to reflect the updated recommendations for hepatitis B. There was a change in the schedule for children who were born to mothers who are negative, where vaccination was beginning at 2 months. But there was also a footnote which indicated that infants born to mothers whose status is negative could, under individual-based decision-making or shared clinical decision-making as another term, could be vaccinated before 2 months of age.
So we've had a summary from our colleague at the VFC of the vote. Do we have a motion to proceed to vote?
I have a motion that we table this vote because we have not seen the specific language of the vote as we requested yesterday for all of the votes, and we have not had adequate discussion of this item. The specific language of the vote has only been given partially verbally, so we don't really know what we're voting on. So therefore, my motion is to table this vote until another meeting. Thank you.
Point of clarification.
motion.
Point of clarification. The language was fully presented yesterday and discussed, as I recall. Perhaps you were not.
For clarification, all of the voting language yesterday seems to have been revised, at least for some of the components, and this language may have been revised since yesterday. So,
but we have assurance from the VFC that in fact that's not the case. We have a motion. We have two. Please let me be the parliamentarian here. We have two motions on the floor. One is to proceed to vote, and one is to table the vote. Do we have a second on the motion to proceed to vote, which came before the motion to table the vote?
I second the motion to vote.
Are there objections to proceeding to vote?
yes, I object as previously noted.
One objection to not proceeding. Are there others? Then the motion to proceed to vote passes. And on the table is the vote to support the language presented yesterday by VFC and discussed that was just briefly summarized. This time I'll begin with Dr. Pagano. COI and vote.
Yeah, Dr. Pagano, no conflicts, abstain.
Dr. Blackburn.
I vote yes for approving VFC to have coverage of what it needs to have coverage for.
COI?
No conflicts of interest.
So our DFO has suggested a point of clarification that what is at hand is the vote to adopt the ACIP recommendations into the Vaccines for Children program. Is that an accurate reflection?
It is actually to approve the VFC resolution that was posted, that was presented yesterday. It's actual approval of the, and I'm happy to go over it again if folks would like to see it one more time. I'm very happy to do that. But it is to approve the resolution.
Roger.
Dr. Santoli, what happens if this does not pass?
So if this does not pass, then we would continue to have the existing VFC resolution as the VFC resolution, which does not align exactly with the vote. It does, so they would be different.
So we would have a difference between the recommendation, which of course doesn't become policy until the director or the acting director endorses it anyhow, just for clarification. Dr. Griffin.
Evelyn Griffin, no conflict of interest. I vote yes.
Dr. Malone, no COI, yes. Dr. Pebsworth.
Dr. Pebsworth, no COI, yes.
Dr. Levy.
Retzef Levy, no COI, I vote yes.
Dr. Stein.
Dr. Kathy Stein, no conflicts of interest, vote yes.
Dr. Pollack.
Dr. Pollack, no COI, vote yes.
Dr. Meissner.
Again, it's hard for me to know what I'm voting for. I don't want any difference between children who get their vaccines from VFC program and children who are not in the VFC program. So I don't know what that means if this doesn't pass. So I'm going to abstain.
Abstain, valid position. Dr. Hiblin.
I note that once again, we have great uncertainty and a lack of clarity of what these votes mean.
But can you
as
appreciate that? So
as
what?
evidenced by our last discussion. Thus, I concur with Dr. Meisner that it's very hard to know what we're voting for, and I can vote neither yes nor no and am forced to abstain.
Thank you, sir. Dr. Milhound.
And Dr. Kirkmel, no conflicts of interest. I vote yes.
So now I turn to the DFO for her summary. Just to recap the votes, we have some ambiguity. Dr. Pagano, your vote was?
I voted to abstain prior to getting a recap of what the substance was.
Dr. Blackburn, recap your vote for counting purposes.
Yes.
Okay, so we have 7 votes for and 4 abstain, so the VFC language has been approved. With that, the advice I receive is that this would be an appropriate time for us to break for lunch. And we would, please advise me, when shall we reconvene? Say again? So we will reconvene at 11:35. I thank you all again for your civility, your comedy, COMITY, and your commitment to the core principles of both public health and respecting the rights of individual patients. See you all at after the break. Thank you. Dr. Pagano.
James Pagano, no COI.
Dr. Blackburn.
Hillary Blackburn, no conflicts of interest.
Dr. Griffin.
Evelyn Griffin, no conflicts of interest.
Robert Malone, no conflicts of interest. Dr. Pebsworth.
Vicky Pebsworth, no conflicts of interest.
Dr. Levy.
Retzef Levy, no conflicts.
Dr. Stein.
Kathy Stein, no conflicts.
Dr. Pollock.
Raymond Pollock, no conflicts of interest.
Dr. Meissner.
Meissner, no conflicts.
Thank you, sir. Dr. Hiblin.
Joseph Hibbelin, no conflicts of interest.
Dr. Milhound, are you present with us? Noted that Dr. Milhound is not present virtually or physically. Dr. Hogue.
Dr. Tracy Beth Hogue, FDA, present.
Dr. Johnson.
Andrew Johnson, CMS, present.
Okay, I think we've completed roll call. I have a administrative note that between the two of us, the DFO and myself, failed in basic arithmetic, and the last VFC vote was 8 yes and 3 abstain. And whoever this is, I want them to go away. So now we proceed with this afternoon's agenda. It's going to initiate with a discussion of the childhood and adolescent immunization schedule from, yes. Oh, hi, Kirk. Dr. Milhound.
Sorry, my phone messed up. I was here the whole time. Sorry. Kirk Milhound, present. No conflicts of interest. Thank you.
So we have a full quorum. To introduce this afternoon's schedule, we have Mr. Aaron Seary discussing childhood and adolescent immunization schedule. I note once again that we had 2 other industry academic representatives who elected not to present today, despite having been invited. Following Mr. Seary's presentation, there will be a discussion by members and liaisons. And then at 2 o'clock, we have a hard start on that, which is to say a hard stop for the prior discussion. We will have a benefit from a discussion of the U.S. and Danish vaccine schedule as a comparison with Dr. Hogue presenting, followed by discussions. In time permitting, we will have a final discussion as an introduction to aluminum-based adjuvants. That Dr. Griffin will present if time is available. So with that, any objections to proceeding with? I call Aaron Seary to present his comparative analysis of the childhood and adolescent immunization schedule.
Good afternoon. I was asked to speak about the development of the U.S. childhood vaccine schedule, and I'd understood actually I'd be speaking about the schedule alongside Dr. Poloff and Dr. Peter Hotez, who I understood were invited, but it appears I will be presenting about this on my own. Obviously, it's a massive topic. There's a lot to discuss when it comes to the U.S. vaccine schedule. And so my presentation will be focused at a very high level. I don't plan to get into any particular issue too deeply or get into any specific injuries or specific efficacy points per se. And I'll try to make just a few small suggestions along the way.
One of which is improvement in our audiovisual capabilities so that the slide advance works.
Well, I found this here on the tape. Okay, there we go. Or did somebody move that for me? Did that?
Where are you supposed to point it? You point it down.
If there's somebody, well, if there's somebody who could guide me on how to.
Do we have AV support for manually advancing slides based on Aaron Seary's requests? One moment, technical difficulties. Here's
Yeah.
AV.
You're saying next slide? Okay, great. Go back one slide, please. Thank you. Okay, I'm going to start with a disclaimer. I'm the managing partner of Syrian Glimstead LLP. I'm an attorney. I manage a firm with over 100 professionals who handle civil rights, exemptions, immigration, employment, and injury claims related to vaccination. We do all of those things related to vaccination. For nearly a decade, I've regularly engaged with and sued federal and state health agencies regarding vaccination-related issues. I've also deposed and cross-examined vaccinologists. I also disclose that my firm currently is handling numerous lawsuits against HHS and its agencies and related government agencies, including 93 FOIA lawsuits against federal agencies, a large proportion of which relate to vaccination. We currently have a lawsuit against HHS, HRSA, and other government agencies and officials seeking to strike down the constitutionality of the PrEP Act, which provides immunity for COVID-19 vaccine injuries. We also have a lawsuit against the Air Force and the U.S. Army relating to COVID vaccine exemptions, which are close to wrapping up. We also have 492 claims that are currently pending against HHS with regards to vaccine injuries in the National Vaccine Injury Compensation Program. And we represent 8 clients in the CICP, the Countermeasures Injury Compensation Program. We also have other lawsuits against federal government, for example, regarding fluoride, though I don't think those are relevant to disclose, so I'm not going to go through all of those. And I will not be discussing any of the currently pending lawsuits in today's presentation. One more point before I get to the presentation. I should also point out that given Senator Cassidy's comment yesterday that I earn my living by suing vaccine manufacturers, I'd just like to point out that I do not earn my living suing vaccine manufacturers. That is because the vaccine companies have effective immunity for vaccine harms and claims because of the passage of the National Childhood Vaccine Injury Act of 1986. It is, in fact, childhood vaccines are, in fact, the only product in America where you can never sue a company to claim that your child would not have been injured or killed had the product been made safer by the company that sold it and profited from it. And I'm also the author of a book called Vaccines, Amen, The Religion of Vaccines. Okay. With all of those disclosures aside, next slide, please. I begin with the growth of the U.S. childhood vaccine schedule. Next slide, please. Now, ACIP was formed in 1964, and while it made recommendations since its inception, the first schedule effectively for vaccines that it published was in 1983. On the slide on your screen, you can see on the left side, this is from the CDC website. It has a page titled Prior Immunization Schedules, and you can see the oldest one listed is from 1983. On the right side of your screen, you can see a copy of that schedule. Effectively, there were 3 routine vaccines on it, DTP, including TD, OPV, and MMR. On your screen, you can now see the current vaccine schedule. This is just the childhood schedule. There's also an adult schedule. There are other schedules, recommendations for during pregnancy, travel schedules. I'm just going to be talking about the childhood schedule today, as I was requested to do. On the screen on the left side lists all of the currently recommended vaccines, and on the right side are the intervals. To provide a visualization of the schedule between 1983 and today, on this slide, what you will see are all of the standalone routine vaccines given in 1983 versus today, and they're listed at the earliest recommended age for each one. The ones denoted in orange are given on or before the first birthday, and the ones in black are given thereafter. So you can see there's been a significant increase in just the routine vaccines between 1983 and today. This slide includes the routine as well as the shared clinical decision-making vaccines on the schedule, which would mean including COVID-19 and meningococcal B. And otherwise, it's the same as the last slide. And again, the orange are all the doses, the injections given, on or before the first birth date, and the black are thereafter. One final visualization. On this slide, you could see just the vaccines that are routinely recommended. So just the routine vaccines routinely recommended by ACIP and on the CDC schedule in 1983 versus the current schedule. In 83, there were 2 oral drops and 3 injections. Today, there are 3 oral drops and 25 injections given by the first birthday, including in utero. And on this slide, you can see the difference in vaccine uptake between 1983 and 2020. This chart reflects the uptake rate by 2 years of age. That's how the data was collected, effectively for 2 years of age for both of them, with the exception of Tdap, HPV, and meningococcal ACWY, MENG4. Those are for the uptake for 13 to 17-year-olds because they're given later. And obviously, you could see quite a difference. In 1983, you had MMR's uptake, 1+ dose was 66%. For it is currently, at least as of 2020, which would mean a 2018 birth cohort, it is at 92%. For DTP, it's gone from 65%, 3+ doses, to currently 94%, 3+ doses. And the schedule currently has 5 doses of DTaP and 1 dose of Tdap, and then 3 doses of OPV, 57% in 1983, and currently it's at 93% for at least 3 doses of IPV, both polio vaccines. And for the remainder of them, they were effectively 0 in 1983, and they currently are between 60 to 90%, and over 90% today, or as of, 2020. Okay. Next topic is going to be the pre-licensure safety with regards to the U.S. childhood vaccine schedule. On this slide, we're going to take a look at each of the routine recommended single standalone vaccines on the CDC's childhood schedule. And those are all denoted in blue. And then the ones in orange are all of the vaccines that were used as a control to license any of the current routine injected childhood vaccines, and any relied upon to license those down the chain. This chart reflects the critical importance of clinical trials in the decision-making of ACIP over the years. And that is because, as we go through this, you will see most recommendations for routine use by ACIP of a particular vaccine happened very shortly after its licensure. And hence, the primary data often available for that specific vaccine would have been its clinical trial data. It hadn't been used yet. It had not yet been licensed and used routinely or otherwise in the American public. When you, as I just noted, the first column are every single current standalone routine recommended vaccine, again in green, and in orange, anyone ever used as a control to license those. In the second column, it was the year that the vaccine was licensed. In the third column, it has the year that the vaccine was recommended for routine use by this committee. And if there was an earlier recommendation that was less than routine, it's put in brackets. And then the fourth column, which is really what I want to focus on, the fourth column reflects, and we did it in days instead of years or months, because the number of days between the licensure and the recommendation by ACIP for routine use, or if something was less than routine before routine, how many days that was. What you'll see when you look at this chart is that often, for almost all of them, the time period between licensure and ACIP's recommendation was a month or two. I'll note the exceptions. The two standalone hepatitis B vaccines, Recombivax HB and Engerix B, did have a non-routine recommendation within about a year, half a year of their licensure, but the routine recommendation for each one came about 5 years later, and one was 2 years later. For IPOL, it was a significant amount of time, many years, as it slowly replaced OPV on the schedule. And then you have the two hepatitis A vaccines, Havrix and Vacta, which were each, did have within a year or two a non-routine recommendation for areas considered high risk of Hep A. But it was years before they actually made a routine recommendation for Hep A to be used universally. And of course, and in my experience, if I could interject my own personal view on this, when the government makes a decision to recommend something, to tell the public to do something, they're often very hesitant to admit they're wrong or go backwards, and hence the data available when these decisions were made to add each one of these vaccines as a routine vaccine to the schedule is critically important. So having robust clinical trial data, really important. It's not only important for what the work of this committee, I actually would add it's also important for the work that I do, in that when a client calls our firm, for example, about a vaccine injury, and we have to oftentimes prove causation, even when we go to the vaccine injury compensation program, we start with clinical trial data. We need good clinical trial data. And so when we look at a clinical trial, there are four main things that we looked at to see the quality of the trial. Obviously, we want to have good quality clinical trials that rely upon the licensed routine vaccine. First is, what is the baseline of safety? And that's dependent on what the control is. If the control and what the control group receives has not already been shown to be safe, then you don't have a good baseline of safety. And so the control should be a placebo, which is defined by the FDA as an inert substance, or it should be another vaccine if, for the same indication, if it was properly trialed prior to licensure. And of course, even if you have a proper control group, you still need to review safety for long enough during the trial, or efficacy as well. In a JAMA article, which was the authors were affiliated with the Office of Pediatric Therapeutics at the FDA and Duke Clinical Research Institute, they explain that, quote, to provide complete safety data across all critical periods of growth and development, that's what clinical trials should do, end quote, as compared to trials for adults, quote, data on drug efficacy and safety in children may require an additional 6 years, end quote. And that is because obviously when you give a product to a baby, or an infant in particular, you often won't know what neurological, immunological, or developmental issues that product can cause until you've tracked that child for at least a few years. And even if the trial has been properly controlled and has an appropriate safety duration, it still needs to be properly powered. If it doesn't have enough children in the trial, it's not going to catch safety issues. And depending on how efficacy is being determined, it won't determine if it's efficacious, whether it's using a correlate of protection or it's actually looking at reducing the burden of actual disease directly. And it should be randomized and blinded, obviously. On the next slide, we have some examples of drug trials relied upon to license 4 different drugs to avoid cherry picking as much as possible. I'm using on this slide the 4 most profitable drugs sold by Pfizer according to an article from 2019. And in those trials, you can see the safety was reviewed for years against a placebo-controlled trial prior to licensure. When it comes to childhood vaccine trials, here is what Dr. Stanley Plotkin, whose name is on the gavel at ACIP, and as well as Dr. Walter Ornstein, who I think are probably known to many of you, said very recently. They wrote that widespread vaccine hesitancy observed during the COVID-19 pandemic suggests that the public is no longer satisfied with the traditional safety goal of simply detecting and quantifying the associated risks after a vaccine has been authorized for use, and that post-authorization studies are needed to fully characterize the safety profile of a new vaccine, since pre-licensure clinical trials have limited sample sizes, follow-up durations, and population heterogeneity. And let's put some substance to those claims made by Dr. Plotkin and Dr. Ornstein. Let's begin with the controls used to license each clinical trial for every routine injected childhood vaccine. Again, controls are critical because if you don't have a baseline of safety in your clinical trial, your comparison may not be appropriate when it comes to safety. Might be for efficacy, but not for safety. And so for the two current standalone hepatitis B vaccines, Engerix B and Recombavax HB, what you'll see is that they were licensed for children based on an uncontrolled trial. So there was no control group in the clinical trial relied upon to license those for children. What they were comparing it against is unknown. For DTaP, there are two licensed standalone vaccines, Infanrix and Dapticel, both licensed based on trials where DTP was used as a control, but DTP was never licensed based on a placebo-controlled trial. The three HIV vaccines you can see on this chart again when you go down the chain, ACTIB, licensed against the Hep B vaccine, which itself was not licensed based on a placebo-controlled trial. Same thing for Hibarex, ACTIB, then Hep B, then no control, and Pedvax-Hib, which was licensed against where the control was a lyophilized Pedvax-Hib, but the control group in the trial relied upon for that vaccine was an injection that included lactose, aluminum adjuvant, and thimerosal all in the vial. Again, not a placebo, not inert. And then the two PCV vaccines, you can see the chain as well. They were both licensed based on trials where Prevnar 13 was used as a control. Prevnar 13 was licensed based on a trial which Prevnar 7 was used as a control. And Prevnar 7 was licensed based on a trial in which another investigational vaccine was used as a control. Prevnar 7 being the first licensed PCV vaccine, there was certainly no excuse to not use an inert control for that trial. IPOL, which was licensed based on a clinical trial with 3 days of safety review and no control group. It was licensed in 1990. This is not the same product that preceded it from 1955. The Salk vaccine, which was removed from the market in the 1960s. This one was made with Vero cells. It had 2, 4, or 8 times the amount of antigen, depending on whether you're talking type 1, 2, or 3. Had a different formulation, different manufacturing process, completely different product. At least OPV could have been used as a control, presumably, but that had no control. And then there's various influenza vaccines. I will not go through those because there are many of them, but they will be detailed in the memorandum that I'm submitting that will accompany this, that will include the citations for everything on some of these slides. Most of the citations are at the bottom, but for some of them, they were too voluminous. They needed to be put in a separate memorandum. And then on this slide, we're going to go through all of the vaccines given 7 months and recommended for routine injection 7 months and older. Again, these are all the routine injected standalone vaccines for 7 months and older on the CDC schedule currently. And as we go down the list, starting at the top, we've got MMR2, which was licensed in 1978 in a clinical trial that had less than 1,000 children, reviewed safety for 42 days. It was only 1 dose. And there was no control group. They could have presumably used the MMR1 was licensed in 1971, but they did not. They could have maybe used standalones. They did not. There was no control group. And it's a very different product, and it very much needed its own. It should have been done if they thought that MMR1 had a proper safety baseline. Unlike the prior versions, for example, each vial of MMR2 contains, because the rubella component was now was grown on the cultured cell line of aborted fetus includes billions of pieces of DNA from that cultured cell line, human DNA in each vial, which was not true of the prior vaccine. There are other major differences between the MMR2. Should have been properly trialed. There was no control in that trial, and it was underpowered anyway, and reviewed safe 42 days. And if, those trial reports I think are fascinating. Folks should look at them. About a third of the kids had gastrointestinal issues. A third of the children had respiratory issues. And there were other complications, but since there was no baseline of safety to compare it against, unclear how the FDA determined it was safe. Then Priorix, which is more recently licensed MMR vaccine, you then used MMR2 in its as the control. And actually, when you look at that clinical trial, and you look at the amount of adverse events, serious adverse events, as well as new onset medical conditions, in the 6 months that they finally did review safety in that trial, they were similar, but they were, I would argue, concerning. But because they were similar and MMR2 was presumed to be safe, it was not viewed as a concern. That brings us to Verivax, the very first and ever chickenpox vaccine licensed in the United States. No reason to not use an inert control group, but instead there were only a few hundred children who did not get an inert injection. They got an injection of 45 milligrams of neomycin, which is an antibiotic, which is per milliliter, which is obviously not inert. Topically, it can cause complications. Then you have two hepatitis A vaccine, Havrix and Vacta. They were both licensed right around the same time. No existing hepatitis A vaccine. No reason to not use an appropriate inert control to license those. But yet Havrix, for reasons that I cannot explain, had Endurex B as the only control that can be identified in one of its small trials. And Vacta was licensed based on a control group that received an injection of AAHS. That is Merck's proprietary aluminum adjuvant that scientists still are unable, independent scientists cannot get hold of to actually test, and thimerosal in the vial of each control. Why you would inject anybody with two substances that have no known therapeutic value when injected on their own is, I don't understand, and I don't even know how it's ethical, but yet that is what the control group received, again, not providing a proper baseline for safety. Then we have the two Tdap vaccines that were licensed in the U.S., Boostrix and Adacel. They used Decavax as a control. Decavac is only licensed for adults. Decavac was licensed in a trial with no control group. And then we have Gardasil 9, which was licensed in a control, based on a clinical trial in which Gardasil 4 was used as the control, for almost everybody, except for about 306 subjects who got did get a placebo, finally, an actual placebo, so you can use one, but only after they got 3 doses of Gardasil 4. And Gardasil 4 was licensed based on a trial in which almost everybody in the control arm was injected with AHS, the aluminum adjuvant, as well as carrier solution. Again, not sure how that's ethical, but that's a separate issue. And then a few hundred got just an injection of the carrier solution, which is labeled as a saline placebo in the package insert, interestingly, but in the underlying documents is clearly not. It included everything in the vial except for the antigens and the adjuvant, including the yeast protein and so forth. And finally, and I hope I'm not putting anybody to sleep, brings us to the meningococcal ACWY, and there's currently 2 on the schedule, Menveo and Menquadfi, and when you go down the chain of those, Menveo was licensed based on a trial in which Menoctra was the control, Menoctra and Menomune. Menomune was licensed without a control group. Same for the other one. Interestingly, today, if you pull up the package insert, and as required by federal regulations, Section 6.1 is supposed to reflect the clinical trial relied upon vis-a-vis safety for that product. And interestingly, the Menomune and the Menoctra package insert, those are the 2 oldest ones, both have the same clinical trial listed in Section 6.1. The clinical trial relied upon to license Menoctra, in which Menomune was the control. So apparently Menomune, Section 6.1 refers to a trial in which it was a control in its own package insert. Obviously, it didn't have that initially because that trial didn't exist. Okay, that takes us through every single standalone routine injected childhood vaccine on the schedule. And as you can see, the concern is that not one of them was licensed based on a placebo-controlled clinical trial, nor was any vaccine used as a control to license any of those vaccines licensed based on a placebo-controlled trial, nowhere down the chain. I know there's a lot of folks in the press who are here, and they might go ask other, what they would call experts about this question, but I would suggest to them very strongly, instead of asking people, to look at the primary FDA sources yourself. If you want to know what was relied upon to license a vaccine by the FDA, ask or look at the FDA documentation. And the memo that I'm going to be, I've done this many times already, it's all available. It's on the FDA website, actually. So you could just go to the FDA website, or you could look at the supplement filing that I will be providing. And I suggest you look at that, in which I will detail and list every single citation, which already might be on this ACIP website or it's in the works. Okay. And we shouldn't even have to do this because the Secretary of HHS has made this point clear many times, and it is in fact a fact. And it's not just it really is an important point. It's a critical point because without a proper baseline of safety, you're laying assumption upon assumption that the product is safe as you see serious adverse event rates in those trials, because you're just looking to see is as safe as the existing product. And we'll look at one or two examples of that. Now, even if it was properly controlled, it has to review safety for long enough to actually see if there are any issues. Again, as we talked about, especially for infants, not going to know if there are issues in various domains of bodily functions until the child's at least a few years old. But yet, unfortunately, safety for routine injected childhood vaccines, they're often 6 months or less, sometimes days or weeks. On the chart in front of you, excuse me. So sorry. Okay. There we go. And I think I showed this one already. And on the chart in front of you, this reflects every infant vaccine on the schedule. That's currently routinely recommended, and you can see the solicited and the unsolicited periods of time that safety was reviewed in their clinical trials. All of them are far too short. And then even if you have enough, even if you're properly controlled and you review safety long enough, you still need to have enough children in the trial, and often the trials relied upon to license childhood vaccines are unfortunately very underpowered. And we'll just go through an example or two of that. Let's first at the hepatitis B vaccine. As we noted earlier, there are only two routine ones licensed in the United States for Recombavax HB and Engerix B. For Recombavax HB, the first one licensed in 1986. Here is the summary of the clinical trials required by federal regulations in the package insert. I'll just read it. It says, in 3 clinical studies, 434 doses of Recombavax HB 5 micrograms were administered to 147 healthy infants and children up to 10 years of age, were monitored for 5 days after each dose. 147 healthy infants and children is not sufficiently powered to detect anything other than the most incredibly common reaction. And of course, there's a big age spread. It's not even like it was only infants. It was infants and children. And it only monitors safety for 5 days after injection in any event. Engerix B was licensed based on 4 days of safety review. And, unlike many of the other vaccines that we looked at earlier, where there was often only days or weeks, maybe 2 months, between licensure and the ACIP's recommendation, when it came to hepatitis B vaccine and the routine recommendation, there was a 5-year gap, as we saw, between the licensure of Recombavax HB and the routine recommendation for that product by this committee, and there was a 2-year gap for Endurex-B. So we actually had an opportunity. There was time for more data to be aggregated between the licensure and the routine recommendation by this committee vis-a-vis safety. And I have on the screen here is the top part of the actual ACIP report in which it made its routine recommendation, and it lists in there everything it relied upon to make that recommendation. When you look through that document, what you'll find that there are only 3 articles that it cites that involve children receiving Recombivac's, Endurex, or any other recombinant DNA technology vaccine, right? Because Recombivac's HB was the very first recombinant DNA technology vaccine ever. Was a completely new platform for making a vaccine. It was revolutionary for its time. And the 3 articles that were cited, you could see they're all listed there below with the PMID numbers. They monitored safety for 7 days or less. They were underpowered. They were industry funded. Critically, this would not be sufficient to affirm the safety of these products before the routine recommendation. And I don't want to jump ahead too much, but if you can go back to the slides on the screen. There we go. Thank you. And I'm going to talk about post-licensure safety in a bit, but I would be remiss if I didn't just quickly hit on the fact that, I watched the last ACIP hearing, and in it there was a slide put up that said that the Institute of Medicine has concluded that the hepatitis B vaccine is safe. But in the most recent Institute of Medicine review of the hepatitis B vaccine, it looked at, which was commissioned by the CDC and HRSA, the Health Resources Service Administration, HRSA, which basically is defending against vaccine injury claims, presumably wanted the IOM to conduct this review and help it make causality conclusions. And it submitted to the Institute of Medicine what it claimed were the most commonly claimed injuries from various vaccines, including hepatitis B. And the IOM, effectively reached 3 categories of conclusions. One is that the evidence supported causation, the evidence rejects causation, or the evidence was inadequate to accept or reject causation. And while there were some that it rejected causation in that report, when it reviewed the conditions, and these are serious conditions, commonly reported serious conditions from the hepatitis B vaccine, when it reviewed the existing science studies with regards to whether or not, what does that data show on whether this vaccine causes it, parents are complaining about it, people are bringing claims about it, that should be a sufficient basis to study it. It found that for every single one of them, except for one, the studies hadn't been done to reach any kind of causality conclusion. It includes conditions like encephalitis, brain swelling, encephalopathy, brain damage, seizures, acute disseminated encephalomyelitis, transverse myelitis, optic neuritis. The list goes on. They are very concerning conditions. Okay. Give another example. The pneumococcal vaccine. So the very first licensed vaccine for pneumococcals given at 2, 4, 6 months of age was the Prevnar vaccine, Prevnar 7. And it was licensed on February 17th, 2000. ACIP recommended it for routine use, voted to recommend it on February 16th, actually a day prior to its licensure by the FDA. So clearly, the data it primarily had available would have been the clinical trial data. And what was that clinical trial data? It was a clinical trial in which the control received a, quote, investigational meningococcal group C conjugate vaccine. The control...
effective. However, they're going to argue that, well, it was unethical to use that comparison in the first place because it wasn't a proven intervention.
I'm not sure. It was unethical to use that because of a proven intervention. Yes, that's exactly right. Whoever said that, the ghost in the wall. Yes, the argument will be, and I always share this. Well, it's unethical to test a later pneumococcal vaccine because we already have a licensed one. Sure, you do. And the very first licensed one ever was Prevnar 7, and the trial, was not against a placebo. It was not against something that was Earth. It was against another investigational vaccine. Okay, so that does not prove safety. And the safety review period was 30 days for emergency rooms, 60 for hospitalizations, and a little longer for select conditions. As a group of FDA and CDC scientists, interestingly, in a JAMA article, themselves said, quote, and that's on the right side of the screen, prior to licensure, the control group in the main study of Prevnar 7 received another experimental vaccine rather than a placebo. If both vaccines provoked similar adverse effects, little or no difference between the two groups might have been evident, end quote. They also noted that it had limited sample size. So, you know, here's the FDA and CDC scientists themselves reflecting on this, you know, the fact that we really can't rely on this trial for safety, but yet it is then used, PCV7 was used as the control to license PCV13. And in PCV13, it was licensed on February 24th, 2010, and ACIP recommended it for routine use on that very same day. So again, clinical trial data, critically important for making that recommendation. And in that trial, what it found was that serious adverse events reported following vaccination in infants and toddlers, again, this is given at 2, 4, and 6 months of age, in 8.2% among Prevnar 13 recipients, and 7.2% among Prevnar recipients. So these are typically healthy infants and toddlers who, within a 6-month period, those are the percentages that developed a serious adverse event. And a serious adverse event, as defined by the FDA, means on the right side of the screen, death, life-threatening, hospitalization, disability, or permanent damage, congenital anomaly, birth defect, required intervention to prevent permanent impairment, or require medical or surgical intervention to prevent an outcome above. The result in this trial, and I'll interject my personal view of it, should have caused concern given what Prevnar 7 was licensed again, but because the serious adverse event rates were similar, and you can look at the underlying FDA documentation, that was one of the reasons for not having concern. Well, then Prevnar 13 was used to license Prevnar 15, and in Prevnar 15's clinical trial, and there was 5 days between the licensure of Prevnar 15 and ACIP's recommendation of routine use. So again, clinical trial, critically important, one of the primary data available to this committee to look at. And what it found was that serious adverse events up to 6 months following vaccination with the 4-dose series were reported by 9.6% of Vaxneuvance, I'll just call it PCV15, recipients, and by 8.9% of Prevnar 13 recipients. But if you look down at the yellow highlighting below, it was found that there was no notable patterns or numerical imbalances between vaccination groups, and hence not apparently a concern. So just to recap, you have an investigational vaccine used as the control to license Prevnar 7, 7 to license 13, 13 to license the two currently used Prevnar vaccines, PCV 15 and PCV 20. In almost every instance, the primary data that would have been available about those specific products to this committee would have been the clinical trial data, and we've just reviewed that. It highlights. I say that not to pick on a particular vaccine. I'm not trying to get into the safety per se, though I think that the data we just looked at raises some very serious safety concerns that should have been and should still be, by the way, looked very carefully at. But to just point out how important these clinical trials are to the decision-making of this committee and how it should really be demanding robust clinical trials. Let me continue. One more final example, and that is the DTaP vaccine. So there are two current standalone DTaP vaccine, Infinrix and Dapticel. Both were licensed based on a trial in which DTP was used as a control. They were both routinely recommended by this committee within about 2 to 3 months of their licensure, hence again, the clinical trial being really important. And in 2014, SAGE, which is the committee that related to immunizations that advises WHO, conducted a systematic review actually with regards to DTP and mortality. And what they found is that, quote, the majority of studies indicated a deleterious effect of DTP on mortality. However, what SAGE concluded was that those studies are not going to be relied upon to conclude that DTP actually does increase mortality, because they raised three concerns. They said that those studies, despite the fact that a majority of them did show that DTP increased overall mortality, while it may have reduced deaths from diphtheria, tetanus, pertussis, the kids getting the vaccine died overall at a higher rate than the children who didn't. It said that those studies were conducted, number one, in an environment with children also got OPV vaccine. Number two, long after the vaccine was introduced. And three, and hence, what they would call a post-elimination environment, though, put that terminology aside. And three, that they weren't randomized. And so another trial was was conducted, if we can go to the next slide, please, in 2017, actually to specifically address those limitations brought up by SAGE. This was a trial conducted by Dr. Peter Abe and a group of scientists who I understand are highly regarded in the world of vaccinology. And what they did is they said, okay, let's see if we can construct a study that avoids those limitations. So in Guinea-Bissau, in the Badao Clinic, they went back and they looked at when they first introduced DTP vaccine. And these are this is the group that actually was bringing vaccines to Guinea-Bissau, to other, and so they certainly were trying to promote vaccines, not the other way around. And they went back and they looked at their data, and what they found is that, before I get to what they found, is that they went to when it was first introduced. So that first avoided the post-elimination environment issue. Second, they only compared children that got TTP and no other vaccines with children that got no DTP. And third, the vaccination was given based on birthdays, which is considered an acceptable form of randomization. So they specifically conducted a study that would directly address the three limitations that the SAGE brought up. And what they found was that, quote, vaccination with DTP vaccine the first 3 to 5 months of age was associated with a 10-fold higher mortality rate compared to unvaccinated infants. So that means that the vaccinated children died at 10 times the rate as the unvaccinated children. And vaccinated in this instance means just DTP, to be clear. Unvaccinated means no vaccines. The article concludes, all currently available evidence suggests that DTP vaccine may kill more children from other causes than it saves from diphtheria, tetanus, and pertussis. I bring this up. Obviously, DTP is not really relevant to the U.S. It's not relevant to the U.S. It's been phased out in the 1990s. But to point out that this is the vaccine used as the control, as the baseline of safety to license DTaP vaccine. Which, by the way, would have been appropriate if DTP vaccine had been properly licensed. And maybe had it been properly licensed with a randomized, blinded, double-blind, placebo-controlled trial of sufficient duration and power, it would have found this very issue before it was even licensed. Next slide, please. I'm going to give an example of a non-routine vaccine. That's the dengue vaccine. And in this trial for this vaccine, it actually reviewed safety for 6 years for severe dengue and hence mortality. It had a placebo control and had a size of over 30,000 children. And by doing a trial that's far more appropriate, obviously, compared to what we've seen thus far, what it found was that children that were under 6 years of age had increased risk of severe harm and death from the vaccine. Hence, it's not recommended for children under 6 years of age. Period. It's not indicated for that use because it increases mortality. They discovered that because they did an appropriate trial. And for children 6 years of age and older, that have never had dengue, again, they found that it increased the risk of severe harm and death from the vaccine. This is, by the way, in the package insert. You could just pull it up and look at it. So again, it is not indicated for any child that has never had dengue, because if they get this vaccine, again, the data reflect it will increase their chances of death and severe harm. But this was only uncovered because it had appropriate trial. I'm going to need to go quicker, I realize. Moving on to the next slide. Again, drug trials versus vaccine trials, you can see a big difference. And the question I get often asked is why, or that's raised is why is there a difference between how dengue vaccine and non-routine vaccine or drugs are trialed versus versus how routine vaccines are trialed? And, you know, what I will, I think that the answer really comes down to the law that you have right on your screen, and that is the National Childhood Vaccine Act of 1986. Economic interests drive corporate conduct. Companies, including pharmaceutical companies, are driven by economic self-interest. They want to make a profit, obviously. That's what their investors expect. That's what everybody with a retirement account expects. That's what Wall Street expects. That's what the board expects, and so forth. And so with drugs and non-routine vaccines, they are liable, remain liable for the injuries that are caused by those products after they come to market, and hence they have an economic self-interest in doing robust clinical trials beforehand. But when it comes to routine childhood vaccines, because of this law passed in the 1986 Act, they don't have those same concerns. A child can never, a parent can never bring a claim against a pharma company on the basis that their child was killed or injured because the product could have been made safer by the company and wasn't. That was the immunity granted. And why did this immunity come about? That's because leading up to 1986, as we saw earlier, there were only 3 routine vaccines on the childhood schedule, DTP, OPV, and MMR, but they were causing so much harm that all the manufacturers stopped making them or went out of business. When I say cause harm, they had a lot of liability relating to harm and and so there were about 6 companies that made measles vaccine down to 1, about 6 that made pertussis down to 1, 3 that made polio down to 1. Now, many industries face this crossroads where their car gas tanks are exploding, or there are other issues with their product. They cause cancer. They have other detrimental effects. And when an industry faces that crossroad, for every other product that I'm aware of, the solution is make a better, safer product. But when it came to these vaccines, Congress went a different way. They passed the National Childhood Vaccine Act, which gave these companies unprecedented and broad immunity. And again, this is the only product I'm aware of in the United States that has this immunity. And what that did was it inverted the economic self-interest. And I think what it does is with drugs, again, and non-routine vaccines, there's an economic interest to want to do a robust trial because the company has an economic interest to know that it's safe before it goes to market. They don't want to end up financially upside down, but they don't have that same economic interest when it comes to childhood vaccines. They're being good corporate stewards to their shareholders and trying to increase profit. Why the FDA would allow the licensure of routine injected childhood vaccines based on the trial data we've seen, that's best to ask the FDA. Now, next slide, please. There are ethical considerations on relying upon improper trials. This is from the British Medical Journal, and I'll quote it. In some trials, placebos were omitted on ethical grounds. This is illogical because studies destined to produce unreliable results should themselves be considered unethical. And so, my recommendation, or I should say my continence, that before recommendations are made by the ACIP committee, it should have robust clinical trial data, especially when there's a very short time gap between licensure and the recommendation, and also that there should be an insistence that for any continued recommendation should be based on robust safety data. Okay, let's get to post-licensure safety on the U.S. child vaccine schedule. I'm going to start going a little bit faster. When the 1986 Act was passed, there was a provision in there that Congress did ask that HHS look at whether certain conditions are related to certain vaccines. It did that presumably because those were commonly claimed injuries from those products. The HHS in turn commissioned the Institute of Medicine, now known as the National Academy of Medicine, to review various serious harms claimed from rubella vaccine and pertussis vaccine. And the IOM issued its report in 1991. What you'll find is that the IOM found that for 4 of those conditions, the evidence favored rejecting a causal relationship. For 6 of them, the evidence favored accepting or convincingly supported a causal relationship. Those included acute encephalopathy and a few other very concerning conditions. But, and maybe this is equally concerning, for 12 of those serious conditions, the IOM said, you haven't done the studies for us to reach a causality conclusion. The IOM was again commissioned to look at a whole bunch of other commonly claimed serious adverse events from vaccines, and that was for a whole slew of other vaccines: diphtheria, tetanus, measles, mumps, OPV, IPV, Hep B, and Hib. And what it found in that instance when it published this report was that it could find only studies to rule out 4 of them as being causally related to vaccination. But for 12 of them, it found that the evidence did support or convincingly supported a causal relationship, including a number of very concerning conditions. And equally concerning, maybe even more concerning, for 41 of these serious conditions back in 1994 that were being claimed to occur from vaccination, the IOM said, you haven't done the studies for us to reach a causality conclusion. We can't rule them out. We don't know. And so this IOM said, it cautioned, it said, quote, the lack of adequate data regarding many of the adverse events under study was of major concern to the committee. Presentations at public meetings indicate that many parents and physicians share this concern. And obviously, what the IOM was saying is you got to do more studies. You have to get better data. You have to properly study this. Fast forward to 2012, almost 2 decades later, as we discussed earlier, the CDC and HRSA this time paid the IOM to do another review. This time of what HRSA said were the 158 most commonly claimed adverse events from vaccines. I'll interject my personal view, is that many of these are the ones that happen very soon after vaccination. There's often no differential diagnosis and are harder to ignore. But putting that aside, here's what the IOM found: that the evidence that they could locate favors rejecting a causal relationship for 5 of them. For 16 of them, the evidence favored accepting or convincingly supports a causal relationship. And again, here we are almost 2 decades later, and for 134 of them, the Institute of Medicine said, you haven't done the studies for us to reach a causality conclusion. I mean, we can reach a conclusion to rule them out as a cause or to say that they are a cause. We've done that for some, but you haven't done the studies for almost all of them. And these are, it's not like HHS, CDC, HRSA were not aware. They're the ones who said these are the most commonly claimed injuries. They're the ones who said it. They're the ones that went to the IOM. And here we are, and you could see it looks like the amount of vaccine safety science post-licensure has gone down because the percentage of issues that IOM could reach a causality conclusion in 2012 versus 1991-94 went down. Over 80-something% they could not reach conclusion because the studies had not been done. And these are serious conditions: encephalomyelitis, autoimmune hepatitis, CIDP, encephalitis, fibromyalgia, GBS, hearing loss, ITP, juvenile arthritis, optic neuritis, small fiber neuropathy, SIDS. Okay. And this just combines all 4 of them. And I think that if you're trying to get a handle on, because I've heard a lot of discussion yesterday and today for the portions that I was able to hear about how, well, there's no indication they're not safe. Well, you can't find what you're not studying. That's first of all. That's critical. And at least for 34 of the conditions, there was causality conclusion. For hepatitis B in particular, has been studied. Most of the most commonly claimed conditions vis-a-vis what the HRSA said are the most commonly claimed. I would say that if you asked me to create a list from the interactions we have with the public, obviously that wouldn't be as, it would be of a different nature, but there would be certain other conditions I would add to that list. Okay, going back to Dr. Plotkin and Dr. Orenstein, here's what they have to say about post-licensure safety, and this is in a 2024 article, so just last year. They said it is critical to examine adverse events following immunization that have not been detected in clinical trials. I'll interject and say that will be pretty much everything. To ascertain whether they are causally or coincidentally related to vaccination. Although the ACIP acknowledges the need, there are currently no resources earmarked for post-authorization safety studies beyond annual appropriations, which must be approved by Congress each year. The budget for vaccine safety monitoring at the CDC, which is responsible for the majority of U.S. federal efforts, has remained stagnant at about $20 million a year, which they say is an inadequate level of funding. And to really highlight this point, I'm just going to go through the injury that's claimed to be most thoroughly studied vis-a-vis any other injury, the one that's also probably the most controversial. Not to discuss or to go in any way into how vaccines might cause it, but whether or not the scientific community has actually studied whether or not the vaccines don't cause it, okay? And I start with 1986, and this is what was provided by Congress in the National Childhood Vaccine Injury Act. It says that the Secretary of Health and Human Services shall complete a review of all relevant medical and scientific information on the nature, circumstances, and extent of the relationship, if any, between vaccines containing pertussins, including whole extracts and antigens, so meaning acellular, and the following illnesses and conditions. And it lists 11 conditions, one of which are autism. So this was Congress saying, hey, this is apparently was enough, a commonly claimed enough injury all the way back in 1986, even when ASD wasn't as common, to make it on this list of 11 conditions that Congress said to HHS, you need to review to see whether they're causally related. The HHS commissioned the Institute of Medicine, as we discussed, and the Institute of Medicine in 1991 published their report and said, we can't find a single study, no study. There's no category of evidence was found bearing on a judgment about causation. All categories of evidence left blank in Table 1.1. Fast forward to oh, sorry. There's the slide. Apologies about that. Okay. And then fast forward to 2021 and 2012, excuse me. And the Institute of Medicine, again, at the request of HRSA, as it remained one of the most commonly claimed injuries from vaccination, again looked at whether pertussis containing vaccine, including tetanus and diphtheria, cause autism. And it again could not identify a single study conducted that would rule out or that would have it draw a conclusion that it may not be causally related. In fact, they only did identify one study, and that study did find that there was a association between DTaP vaccines and autism, but it was not given weight because the IOM said, quote, it was based on passive surveillance system and it lacked an unvaccinated comparison population, which I agree with. You need to have an unvaccinated comparison population if you want to do proper vaccine safety studies. So the causality conclusion was the evidence is inadequate to accept or reject a causal relationship between diphtheria toxoid, tetanus toxoid, or acellular pertussis-containing vaccines and autism. I also had an opportunity to pose Dr. Stanley Plotkin, again, whose name is on the gavel, with regards to why would the medical community tell the public that vaccines don't cause autism if they don't have the studies to show that DTaP doesn't cause autism? I don't hear audio. I don't hear the audio.
Oh, we're tracking. Yeah, no audio. Oh, we're not set up for audio.
You're not set up for audio. Okay, well, the link will be in my submission, and anybody can watch it if they want. Anyways, Dr. Plotkin, I'll just summarize. It says, he affirms that that is the conclusion of the Institute of Medicine. There are no studies. This is in 2019. He doesn't identify any other studies that would rule out DTaP vaccines as a cause of autism, but he says he'll still tell a parent that vaccines do not cause autism, even though he doesn't have the studies to support that claim. On behalf of a nonprofit we represent, ICANN, the Informed Consent Action Network, we actually submitted 6 FOIA requests to the CDC asking them for the studies relied upon to claim that vaccines do not cause autism for each of the vaccines given in the first 6 months of life, as well as individually and cumulatively. The CDC did not provide any studies. We sued them in federal court, and we ended up having a settlement in which they enlisted 20 studies to claim that those vaccines given in the first 6 months of life, DTaP, Hib, Hep B, IPV, and PCV, do not cause autism. And on that list of 20 studies, not a single one relates to those vaccines, to those vaccines on the current schedule. 18 involved thimerosal and/or MMR vaccine. MMR is not given until 1 year of age. None of these vaccines contain thimerosal. One involved antigen, not vaccine exposure, which itself said it can't rule out that vaccines cause autism. And then the last thing it cited to was the 2012 IOM review, the one we just looked at, that showed that it could not find any studies that show that DTaP doesn't cause autism, and only one study that did find association. And so the CDC website, as everybody knows, and as the press has reported widely on, has been updated to reflect what shouldn't be a controversial reality, right? Which is there are no studies that show that the vaccines given in the first 6 months of life do not cause autism. And that's an important question. And it's important because 40 to 70% of parents, when surveyed, do point to vaccines still today as a cause of their child's autism, often pointing to vaccines. And they point to the vaccines given in the first 6 months of life, as well as MMR. Do you hear that noise? I do. What is that? As well as, and so in any event, so obviously it's critically important that it be properly studied, not just claimed. And as I think it's heartening to see that the HHS website now says CDC website, and I will say that what I'm about to read is probably more likely to build vaccine confidence than most things I've read on the CDC website. It says, this statement, the statement that vaccines do not cause autism, has historically been disseminated by the CDC and other federal health agencies within HHS to prevent vaccine hesitancy, meaning it wasn't disseminated because it was a scientifically based claim. It was disseminated because it was done to prevent vaccine hesitancy. That's not the way decisions should be made. I wholeheartedly agree with a lot of the comments made over the last day, or today and yesterday, that decisions should be made with data. And if you're going to say vaccines don't cause autism, have the data to say it. Now, while the IOM can't identify many studies to rule out commonly claimed vaccine injury claims, there are data that are not available to the IOM or to the public, and some of that data is in the hands of the manufacturer sponsors of these vaccine products. And you can get in a typical lawsuit about a drug injury, often the way you prove that the drug caused the injury is when you get those underlying data that the company has and their internal reports and so forth. Well, with vaccines, you can't bring those kind of lawsuits typically, but you can get a glimpse into that data. And the way you do it is this. Under federal law, the vaccine package inserts are supposed to include, quote, only those adverse events for which there's some basis to believe there's a causal relationship between the drug and the occurrence of the adverse events, end quote. The FDA's guidance to industry says the same thing. There has to be some basis for the company to believe that it's causally related, not that it's just correlated with the product. And so when you pull up the package insert for each vaccine in section 6.2, when it lists those injuries or adverse events, it only, if it's in compliance with federal law, is only listing those that it has a basis to believe are causally related. And I will say that those are similar injuries that the IOM gets. It's the similar injuries that HRSA claims are common ones my firm gets calls about. And in any event, to properly study whether or not vaccines are causally related, you really need an unvaccinated group. This is not controversial sometimes, and it's controversial at other times. So in the CDC manual for the surveillance of vaccine-preventable diseases, it explains that because there's a lack of an unvaccinated group for comparison in VAERS, reports of VAERS are useful for generating hypotheses, but studies with vaccinated and unvaccinated subjects are necessary to confirm any hypotheses. As we saw earlier, the IOM, for example, discarded DTaP and autism study because it lacked an unvaccinated group. And in fact, typically when a study has a result that shows an association between a vaccine and a harm, you will often hear the argument made in literature, in the scientific literature, that, well, that there isn't a proper control in unvaccinated group. I would say on that basis that all of the clinical trials relied upon to license these vaccines have been improper and so forth. But the important thing is to use good data to make decisions, in particular at ACIP, given how important the decisions are that this committee makes, because they often result in mandates across this country. And in 2013 IOM Vaccine Safety Review, they were commissioned to look at the entire vaccine schedule and its safety, and they said that, quote, no study compared the differences in health outcomes between entirely unimmunized populations of children and fully immunized children. Experts who addressed the committee pointed not to a body of evidence that had been overlooked, but rather to the fact that the existing research has not been designed to test the entire immunization schedule. Also, studies designed to examine the long-term effects of the cumulative number of vaccines or other aspects of the immunization schedule have not been conducted. The IOM explained that there is no evidence that the schedule is not safe. But those studies can be done. There are an estimated 45,000 children in the United States right now are 2 years of age who are completely unvaccinated based on the CDC data, and about 650,000 between 2 and 17 years of age. Those are children are already not receiving vaccines. They are unvaccinated. Those cohort data exist in HMO databases. They exist in captive payer environments. And the children, the health outcomes of those children and children who do receive vaccines can be compared. Unfortunately, our existing surveillance systems do not engage in that. They could, depending on the system, but they don't. VSD, for example, has an estimated around 20,000 unvaccinated children in its database, but I have never seen the Vaccine Safety Data Link used to publish a study comparing health outcomes between children, those children, and the health outcomes of vaccinated children. In fact, the Institute of Medicine in 2013 specifically said the VSD could be used to do that comparison. The CDC then commissioned a white paper on how to do that comparison, published in 2015, but yet to date, no such study has been published. I'll also point out that the VSD used to be housed in the CDC, but was removed out of CDC to take it out of the reach of FOIA and the ability of others to get access to it after scientists conducted studies in the VSD that I think were the CDC didn't agree with. And that creates obviously selection bias, because to use the VSD, you've got to go through the CDC effectively to get approval, or one of their partner organizations. And also the data underlying those studies are not available to the scientific community or the public effectively, I should say. There's a process you can ask for them, but you're not going to get them. We've tried. And we also, I should stop there. VAERS, CDC has refused to automate the capture and submission of VAERS reports. AHRQ actually funded a study at the Harvard program that did create a system to automate VAERS report capture and submission. They ended up capturing about 35,000 adverse events at a population of about 300,000 individuals. They created the system to submit it automatically to CDC, but when they contacted CDC, CDC refused to engage with them to actually connect the system they created with VAERS. And hence, VAERS to this day remains an unautomated system. If you want to submit a VAERS report, it is an extremely arduous process. It takes a lot of time, and I'm amazed any medical professional, frankly, ever submits one. Then there's VSafe. VSafe is an automated system. It was developed initially for COVID vaccine, has been expanded slightly to monkeypox, and it is automated, but it fails to list reactions of interest. I'm going to rest on my submission on that, given the limited time. And CISA is another surveillance system, but it's not designed to assess population safety. There are studies that compare vaccinated with unvaccinated populations. That means no vaccines. Most of these studies are smaller. Some of them are based on parental surveys, which obviously come with confounders and bias. And they are not, and like every retrospective study, they are subject to confounders and to criticism. I can certainly level and point out problems with every single one of the studies I just listed on the screen. And there's a whole slew of others. There are a bunch of other studies, published and unpublished, that compare vaccinated and unvaccinated children. What I can say about them as a whole is that they consistently show the same outcomes, which is that the vaccinated children have multiple times the rate of chronic health issues. And which chronic health issues? Often the very chronic health issues that we have seen rise precipitously since the early 1980s. If I can go to the next slide, please. In the early 1980s, less than 10% of children, according to certain data, had a chronic health issue. Today, it's over 40%. And most of that rise is in issues such as asthma, allergies, ADHD, and so forth. And when you look at the underlying etiology, they're often based on some form of immune system dysregulation, even ones like ADHD that you don't often think of that way. And again, I lay all that out in the accompanying memorandum. By the way, these same harms that have increased precipitously are also often disclosed in package inserts in section 6.2 as well. I'll just go back one slide, and I will point out that one of the big problems with the data and the studies, I should say, relied upon, I've seen historically at this committee, is that they often, on safety, they compare vaccinated with unvaccinated children, and hence they almost all are confounded by healthy user bias, where it is the healthier children that go on to get more vaccines, and it's those who are injured by vaccines earlier that stop. And using risk windows is what I've also seen often be conducted with VSD studies. They'll look at a window of time after vaccination in a group that all got vaccines and a window of time after vaccination. At least they should compare, the time period before vaccination and after vaccination. And I think that as a recommendation to look very critically at any study submitted to this committee when they don't have a unexposed group. I'll end with one last point about post-licensure safety, and that's related to aluminum adjuvants. This was a study that was conducted that looked at a bunch of the vaccines given to infants in the United States, and it actually found that for 6 of the vaccines, it contained a statistically significant greater quantity of aluminum adjuvant in the vial and they tested different lots than is on the package insert. And that for 4 of the vaccines, there was actually significantly lower quantity of aluminum adjuvant. Aluminum adjuvants are not like ionic aluminum. This animal studies where they have injected aluminum adjuvants and put fluorescence on it, and then track where the aluminum adjuvant goes in the animals. It often deposits in organs, particularly as well as the brain. Obviously, that's not good. Aluminum adjuvants can cause immune activation. They can cause, they're neurotoxic and they're cytotoxic. And so you don't want those in the brain, and obviously carefully studying aluminum adjuvants and looking at the existing body of literature is important. But at the least, your product label should match what's in the vial. We actually submitted a petition to the FDA about 4 years ago now, asking the FDA to confirm, and we did that on behalf of one of the scientists on the study as well as a nonprofit, to confirm that this study's findings are wrong, that the labels in fact are correct, or to pause until you figure that out. And we have, they have sought extensions but have still never provided any proof that the labeling is correct. So with regards to post-licensure safety, when robust clinical trial data is not possible to obtain, robust post-licensure safety data should support recommendations, condition recommendations on sponsors providing any requested follow-up safety data. I know that's often requested, and I'm not so sure that it's provided, and revisits recommendations regularly. Efficacy in preventing transmission on the U.S. childhood vaccine schedule. I often don't hear this discussed at the committee. I thought this would be a good thing to just quickly touch upon as well. Live attenuated vaccines, such as Varivax or varicella, they generally prevent transmission of the target pathogen in most recipients for an extended period post-vaccination. Obviously, if it's preventing transmission, It can have reduce the pathogen in the community, but not all vaccines do that. And for example, the polio vaccine that we've used exclusively in the U.S. since 2000, inactivated polio vaccine does not prevent intestinal infection and therefore does not prevent poliovirus transmission. That's also reflected on the CDC website, where it says inactivated poliovirus vaccine does not stop transmission of the virus. It does not produce mucosal immunity, and hence it doesn't stop the proliferation of the poliovirus in your intestines and its transmission. Pertussis vaccine, similarly, we moved to exclusively acellular pertussis vaccine in the United States in the 1990s. The acellular pertussis vaccine, the amount of circulating pathogens did not seem to decline. That was observed because the inter-epidemic intervals were not getting wider for pertussis, which would happen if there was less circulating pathogen. The FDA conducted a study where they had a group of naive baboons, meaning no vaccine, never had pertussis, and a group of acellular pertussis baboons, as well as convalescent. There was also wholesale, but that's not relevant to the U.S. Then they exposed them all to pertussis. Those that had never had pertussis or vaccine, they were able to swab pertussis from their nasopharynx for about 30 days. Those that had been acellular pertussis vaccinated, they were able to swab pertussis vaccine from the nasopharynx, if we can go back to that slide, please, for almost 35 days, though I'm not sure that was deemed statistically significant. For the convalescents, meaning those that had pertussis before already, they weren't able to swab any pertussis. And so this reflected that, as the title from the FDA article states, acellular pertussis vaccines protect against disease but fail to prevent infection and transmission in a non-human primate model. And as a consensus paper, including some of the world's leading pertussis vaccine experts and organizations said, natural infection with pertussis evokes both mucosal and systemic immune responses, while APVs, acellular pertussis vaccines, induce only a systemic immune response. Mucosal immunity is essential to prevent colonization and transmission of Bordetella pertussis organism. Consequently, preventative measures such as APVs do not induce a valid mucosal response and can prevent disease, but cannot avoid infection and transmission. Acellular pertussis vaccines do not prevent colonization. Consequently, they do not reduce the circulation of Bordetella pertussis and do not exert any herd immunity effect. One of the authors of this is actually one of the editors of the Pocket Vaccine book, and as well as the author of the pertussis vaccine chapter, and again, as well as some of the organizations you can, World Health Organization, that you can read on there. The point here is this. If it doesn't stop transmission, but it reduces symptoms, those who are vaccinated actually are going to be less likely to know to stay home in bed, are actually more likely to continue to circulate in the community and in schools, and probably are more likely to spread the pathogen. But I've never heard that type of, concern be brought up or raised. In fact, it's it's part of why we actually petitioned the FDA to add to the label of each pertussis vaccine that it doesn't prevent transmission. But the FDA responded by telling us that FDA's licensure standards for vaccines do not require demonstration of the prevention of infection or transmission. The pertussis vaccines that the FDA has licensed are for prevention of pertussis disease, not infection with Bordetella pertussis. FDA also noted that it's not convinced that there's any widespread misconception about this. I would disagree with that conclusion, but that's fine. Critically for ACIP, I would say it should demand, I would say, data demonstrating prevention of transmission and what effect a pathogen does have on introducing a vaccine does have on transmission. As you can see from this study article, it notes that the inter-epidemic intervals have not changed in any way since mass vaccination, which you would expect to have if it was preventing transmission. In fact, some of them have found they've gotten a little narrower, which would reflect an increasing amount of circulating pathogen. ACIP provides that, unlike routine catch-up and risk-based recommendations, ACIP makes shared clinical decision-making recommendations when individuals may benefit from vaccinations, but broad vaccination of people in that group is unlikely to have population-level impacts. And so when you think about that standard, query whether it is appropriate to ever make a routine recommendation for a vaccine that doesn't prevent transmission. Okay. Efficacy on preventing mortality, U.S. childhood vaccine schedule. Vaccines are intended to prevent symptoms if the vaccine is infected with the target pathogen, thereby potentially preventing disease and mortality. Obviously, if it's going to prevent you from getting measles, it will prevent you from the harm of measles. But we should also obviously need to take into account the risks as well. On to the benefits, this is the most widely cited article I typically see about the benefits among children born during 1994 to 2023, so 30-year period. Routine childhood vaccines will have prevented approximately 508 million cases of illness, 32 million cases of hospitalizations, and 1.1 million cases of death. That 1.1 million cases of death is what I've routinely have seen over and over again, and given the time constraints, especially right now. I'm only going to go through the mortality, and I'm going to go through it a little quicker. Here's the issue with the mortality figure in this study. It's taken as lore, it's cited as science, it's cited as a fact, and it's repeated by the press sitting over here to the right over and over again. I've seen it in a million articles. But it ignores, as the study says, it ignores all confounders, explaining, quote, this is what the study says, factors other than immunization, meaning hygiene, clean water, sanitation, anything else in the world, improvements in healthcare, improvements in acute care, might have contributed to lower disease risks in certain decades, and reductions resulting from these contributions have not been incorporated into the model. And hence, it pretty much ignores every confounder. It does the opposite of what science and studies are supposed to do. And hence, it's not surprising that it has no confidence intervals, because there can be no confidence in what it's claiming. In fact, it could be that it caused 1 million kids to die, and that would be within its existing confidence intervals, which are unbounded. The data also is unreliable, as I'll go through in a minute, because it doesn't actually seem to have really looked at the CDC mortality data, and it did not go through peer review to the extent that peer reviews, putting aside any issues with peer review. It went through the clearance process at the CDC, and the clearance process at the CDC is one in which it only publishes things that align with the CDC policy, and the CDC policy are that vaccines are safe and effective. Citations for that for the ACIP CDC policy on that is in the memo that I'm submitting along with this. So let's just take a quick look at diphtheria. Diphtheria accounts for 750,000 of this 1.1 million lives saved, okay? So this article is claiming diphtheria saved 25,000 lives a year in the United States over the last 30 years. Here's the problem with that claim. Between 1900 and 1926, diphtheria mortality declined by over 80%. There was no vaccine. Between 1926 and the 1940s, there was a vaccine that was introduced, but it was only used in certain areas. And in the areas it was used and the areas it wasn't used, the mortality declined at the same rate. Hence, the vaccine does not have an impact. That's in the literature, and it's also cited in the memorandum that should be on the ACIP website. And so that takes us to 1949, when the first DTP vaccine was introduced. And it's when routine vaccination really first began. And in 1948, there were 634 deaths from diphtheria. Keep in mind that by the early 1980s, as we saw earlier, just for 3 doses plus, you only had a 60-something% uptake. And so to claim 25,000 deaths a year averted, it just ignores the historical data. It also ignores the fact that diphtheria immunity wanes such that an adult needs to get a dose every 10 years. 40% of adults don't get it, yet we haven't had a case of respiratory diphtheria in 30 years. And so when you actually look at the mortality data in context, as well as the coverage rate, and then you look at diseases that are similar, like scarlet fever, which is also a lyophilized bacteria, which went away without vaccination. They tried to make a vaccine for it, but they failed. The 25,000 deaths a year just, it defies data. It claims 30,000 deaths from hepatitis B vaccines are prevented a year in the last 30 years. That's 90,000 to 1.1 million lives saved. I'll just point out that in 1980, the year before the very first hepatitis B vaccine, there were 294 deaths in the United States. And then for measles mortality, it claims that that measles vaccine has saved 2,833 lives a year in the United States over the last 30 years. In the late 1950s and early 1960s, before the very first measles vaccine it was introduced in the United States, there were only around 400 deaths a year. And I'll point out that there were about 4.2 million births a year in those years, and right now we have 3.8 million births a year in the United States. So there's less children being born now than the late 50s and early 60s. And at a time when measles was endemic, everybody got it. There were about 400 deaths a year, but yet measles vaccine today is estimated by this report to save 2,833 lives. And I will also point out that measles mortality between 1900 and 1963 declined by well over 98% into a rising population. And that had nothing to do with vaccination. So you have to assume, number one, that it would go the other way, even in a declining birth rate between the 60s and today. It just defies the data. There are also studies on nonspecific effects related to mortality, live versus non-live. We saw earlier how DTP vaccine has been found to increase all-cause mortality beyond any lives it might save, whereas live vaccines such as MMR and chickenpox have been found to have the opposite effect when used in developing countries. They have been found to reduce mortality in studies, though they are considered controversial by some, including, I believe, some at the FDA. They have, but the studies have, just like DTP, have found that they reduce all-cause mortality beyond the potential prevention of mortality from measles. Putting aside whether the accuracy of those studies, their applicability to the developed countries like the United States, which is what we're talking about today, that is even more difficult to ascertain at best, I'll put it. And I think the data on that is far more, is not as reflective. But when it comes to adults and the impact that eliminating measles has had in adults, there is some very clear data. This is a 100-plus person prospective 21-year-plus study in Japan that reviewed 100,000 individuals in Japan. So it was prospective. It looked at them forward-looking rather than retrospective. And one of the measures that it looked at was deaths from cardiovascular disease amongst those that had measles and mumps versus those that had not had measles and mumps. And what it found was that after 20 years, those that had measles and mumps had a 20% less death, statistically significant, from the than those that did not have measles and mumps. So for men, that was reported as 0.8 with a confidence interval of 0.71 to 0.89. For women, it was a 17% reduction, reported as 0.83 with a confidence interval of 0.75 to 0.92. And so cardiovascular disease kills 900,000 Americans a year. Obviously, they're older. And so in a life years basis, maybe less than a child dying for sure. But those type of data, I think, are also critical when ACIP makes their decisions about introducing a vaccine product. What is the total societal health impacts? And on this screen, I have the number of deaths in the year prior to the introduction of the first vaccine for each of the diseases listed. And for DTP, I use 1948, the year before the first vaccine. And you could see that it's often a few dozen or 100. Every life death's a tragedy for sure. But it's hard to get to 1.1 million with this kind of data. I would also just point out that the further in history you go, the larger the numbers are, reflecting that, putting a polio aside, for every other one of these, for almost every other pathogen, the mortality was declining precipitously without a introduction of a vaccination. And I'm going to wrap up, and I'm going to say that when it comes to informed consent, I think that's really critical. It is really critical. I've heard a lot of comments about informed consent here, and I'm heartened to have heard them, because I think it's the lack of respect for informed consent that often leads to the very vaccine hesitancy that I think some members have expressed concern about. And the ACIP guidelines provide that, unlike routine catch-up and risk-based recommendation, Shared clinical decision-making recommendations are individually based and informed by a decision process between the healthcare provider and the patient or parent guardian. I would submit to you that that is what should exist for all decision-making. It should be an individual-based and informed by decision-making process. So, based on this standard, I would say all recommendations should be shared clinical decision-making. I'll end by saying that if there are members of this committee and prior committees and any future committee that wants to increase vaccine confidence, I would say that there are three things that they should think about and look at. Number one, need to depoliticize vaccines. I hear that all the time. But the only way you depoliticize vaccines is you need to take them out of politics. And the way you do that is you have to end mandates. Mandates make vaccines political. When you take away somebody's right, you have made it no longer just a medical question. You've made it a legal one. You've made it a political one. When you argue vaccines should be mandated and somebody's rights should be taken away on the basis that a vaccine is safe and effective, you've now made the safety and efficacy no longer just a medical question. You've made it a legal question. You've made it a political question. That's probably in part why you find me here today as a lawyer speaking about this topic. When you mandate vaccines and you eliminate exemptions, you destroy confidence. Look at countries like Denmark, numerous other European countries, many other provinces in other developed countries. They don't have mandates, and they have very high uptake rates. There's far less controversy there about vaccines. There's no controversy in America about maternal screening. I didn't hear anybody talk about the concerns that people would be issues with maternal screening. Why? Because nobody's mandating it. They're recommending it. They're encouraging. They're persuading on the merits. And who do mandates impact? They impact not those who want to get the products. They impact those who most need to avoid it. And the reason I bring this up is because what ACIP does and then what the liaison members do filters down often into mandates. Directly by some of the liaison members and indirectly by what the work of this committee does when they make routine recommendations. And those folks who most need to avoid their products, what happens to them? Because oftentimes, and these are folks who contact our firm who are injured by a vaccine, those in the medical community, and I've heard some of them today and yesterday, they just pretend like they don't exist. This vaccine's safe. As if the father who talked about his child dying, how about the parents whose child died of a Hep B vaccine who was compensated not long ago in the VICP program, not on the basis of a table injury, not on the basis, as I heard earlier yesterday, of some kind of, a settlement, but on proving the vaccine killed their baby. It was a newborn. It was just given the Hep B on the first day of life that died from that vaccine. But the medical community often, to avoid vaccine hesitancy, does not give. Those folks feel like they're as if they don't exist. Every one of them, then they get kicked out of school, kicked out of their jobs. Things are said about them that are not always very nice. And those are the folks who then go and tell their stories. And their stories then can result in what folks describe as vaccine hesitancy. But they're really people who are trying to be heard, and mandates are the precipitator for what often results in that. And so liaisons, what I would urge is that for the liaison members in particular, to adopt policies that provide that they should persuade on the merits of these products and not coerce folks to do it. I'll wrap up in a minute. And I think that that's critically important if they want to increase vaccine confidence. After all, they have billions of dollars of federal government money and state health agency money and of their own money to promote these products. So they should be able to persuade on the merits. Lastly, I would say we do need to care about everyone. We should absolutely, critically important to care about any child that will be injured or die from an infectious disease. Critically important. But we also need to similarly give the same care and attention to any child that could be injured or die from these products. And I really believe we can do both, but we can't do that if we're licensing products and then they're recommended based on clinical trial data like we looked at earlier, or a post-licensure vaccine safety literature. And as we saw earlier, when parents contact our firm about a vaccine injury, that's what we look at. We go to look at the clinical trials because we have to prove causation often, even in the VICP, if it's off table, which most claims are. And then we look at the post-licensure literature. We need that data, too, to do that work, and it's vacuous. Why do we need the 1986 Act if vaccines are so safe, too? Why does a product need immunity if it doesn't cause harm? And why does products that have been on the market for why do products that have been on the market for decades, like the hepatitis B vaccine, still need that immunity? Do we still not know they're safe enough to lift the immunity on those products? Look, drug products that have very limited markets, tiny markets, that are given to very few people that have really bad adverse event profiles can still be sold profitably. Why? Pharma companies typically need to do two things. Number one, they need to make the product as safe as technologically feasible. And by doing so, they avoid design defect claims, which is the primary way you hold a company accountable for harms from their product. The type of claim you can never bring for a childhood vaccine. The second way is they disclose the risks that product can cause, and hence they avoid failure to warn claims. Those are the two primary claims that would be levied against a pharmaceutical company. I do not understand, well, I shouldn't say that. It's not true. There's probably a reason that this immunity still needs to continue for these products. And pretending that that reason doesn't exist is not going to make the problem any better, and it's not going to safeguard the kids that are injured by these products. I will close with that and just say that I hope that this presentation has been helpful. I appreciate the opportunity to present, and I welcome coming back at any point if you want to bring some of the other medical professionals, and so we can have a more robust debate with them as well here.
Thank you, Mr. Siri. I am directed by the DCP that we need to address the question of why Mr. Siri was here and whether other voices or points of view were solicited to participate in our discussion this afternoon.
Thank you, Mr. Siri. Just for everyone's knowledge, we invited several people to give us a broad perspective on the U.S. vaccine schedule, how we got here, and where we are. We invited 3 experts. We invited Dr. Paul Offit, a former ACIP member, to come and present his perspectives. And we also invited Dr. Peter Hotez, a vaccine developer at the Texas Children's Hospital. Unfortunately, they declined. And we appreciate your comments. Thank you.
So with that, we have a hard stop at 2 o'clock because our FDA liaison representative, who's going to be presenting, Dr. Hogue, is required to complete her presentation and then participate in a crucial meeting on behalf of the FDA. So we do need to move through this. We begin with questions, and please be focused, to Mr. Siri concerning his presentation from the ACIP members. Do we have any? So, Dr. Levy.
So thanks. This was a lot of information, and many of the issues that emerged were, touch upon things that we discussed today, among other things. I wanted to ask a question. So you mentioned mandates, and that sometimes recommendations by ACIP, the CDC, and maybe other professional organizations are leveraged by different entities to impose mandates. I personally think I share the sentiment that they're ethically wrong, but they're also fundamentally wrong from the perspective of a good public health policy. And I think I agree that the evidence from different countries suggests that policies that are based on teaching, educating, giving people, empowering people to have choices based on good information are much more successful. My question is to you as a lawyer, if we as ACIP, which is only advisory board, but on a federal level, what decisions or what ACIP can do in terms of its decisions, and what maybe the CDC at the federal level can do to make mandates less possible or less feasible?
Well, I think that anybody, any state, any entity, public and private, below the federal level that is engaged in conduct that would violate an individual's civil individual rights, for example, the right to a religious exemption, should not be funded by the government. The federal government has a duty to abide by the United States Constitution, and the very first freedom under the very First Amendment is the freedom of religion. And so any entity, private or public, that's violating that right, obviously private entities don't have an obligation to, but if they are, the government should be participating in it by providing funding.
Your perception is that this is allowed by the current legislation, or it needs some more work and amendments to the current legislation?
I think it's a mix of statute, regulation, and policy. I think it would happen at all levels. For example, the American Academy of Pediatrics, which is, I understand, not here at the moment, so they can't respond, but has put out a statement calling for the elimination of all non-medical exemptions for children to attend school in the United States.
Okay, Dr. Griffin. Concedes her time. Dr. Meissner.
There we go. Thank you, Robert. I don't know quite how to respond to this presentation. Mr. Siri, you live in this country, so you're entitled to the same First Amendment rights that we all are. But what you have said is a terrible, terrible distortion of all the facts. And I would like to be able to go through them one by one, but obviously Robert will be on my case after a few seconds. So I cannot do that. So I've got to select what I want to say. First of all, I'm very sorry that Paul Offit isn't here, because I certainly cannot speak as effectively to your comments as Paul Offit could. But I can say a few things. There's just so much to say. It's hard to know. First of all, you began with slides that showed the increase in the number of vaccines that have been administered. What was your point? I mean, that is a phenomenal accomplishment. That's why we have the lowest rates of infectious disease in the United States, because we have the highest uptake of vaccines. And if vaccine uptake goes down, we're going to see an increase of these diseases, such as with hepatitis B, which I think is going to happen. Now, you clearly confuse associations. That is, there is a temporal association and a causal association. Remember, there are tens of thousands of vaccines that are administered every day. And just because there's an adverse event that occurs around the time of vaccine administration, it doesn't mean there is any causal association. And you're jumping to the conclusion that, yes, there is. And that is not fair. You invoked Stanley Plotkin and Walter Orenstein, whom I know well, and that is so disingenuous. They have done more to support the vaccines and the health of children in the United States than almost anybody else. And for you to include them as skeptics is a gross distortion of the facts. Now, let me just go to a couple of points. You talked about the polio vaccine, and you said the current killed, that is the Salk vaccine that we're using now, does not prevent transmission. Well, that is correct. But why are we using the Salk vaccine instead of the Sabin vaccine? It was because the Sabin vaccine was associated with about a dozen cases of vaccine-related paralytic poliomyelitis every year. And so the decision was made to switch to the killed vaccine. You said, oh, it doesn't block transmission. Well, it doesn't block transmission, at least not very effectively. But there's a reason, because it would have been much more harm if we continued using the live vaccine. Let's go to the acellular pertussis vaccine. You said the acellular pertussis vaccine does not block transmission. That's probably true. It doesn't block it as well as the whole cell vaccine. But the reason we stopped using the whole cell vaccine is because it was associated with an increased risk of side effects that we could avoid by using a cellular vaccine. So, of course, it's an issue of weighing. We're going to lose the prevention of transmission, but we're going to reduce any harm and make the vaccine safer. How about the diphtheria vaccine? Well, you know, there was a recent report about from Europe that described over 500 cases of diphtheria in immigrants who had not been vaccinated. And there were, two or three deaths among that cohort. Well, it goes to the point that the pathogens that cause these diseases are still around us. And if we stop vaccinating, we are going to see increases in rates of disease. So the same thing about your discussion about Prevnar. Prevnar began at 7-valent. It's now a number of additional serotypes that are included in the vaccine. That is the most wonderful, remarkable vaccine. It has had an enormous impact on public health. In fact, the public health benefits have been far greater among people who were not vaccinated, that is the adults, than it had on children who were vaccinated. Because initially it wasn't recommended for adults. Now it is recommended for adults. That's another conversation. But the implication is that the safety of this vaccine was not measured. That's outrageous. You compared it. You said that you can't do seroconversion studies as a means of evaluating vaccines. Of course you can do seroconversion studies, because if we did efficacy trials with new pneumococcal vaccines or new pertussis vaccines, it would be almost impossible because the disease has become so rare. So if there are trials that would reasonably be done, they would. You say, oh, the FDA has licensed a vaccine, and then the next day or a few days later or a few weeks later, the ACIP recommends that vaccine. Well, that's a good thing, right? We're preventing disease. All you're focusing on are these very rare, ill-defined side effects and completely ignoring the extraordinary benefit and promise that these vaccines apply to us. You're a very effective lawyer, no question. You're very smooth. You know how to present the facts that are favorable to you or to your client. That's your responsibility. That's what you're paid, I suspect very handsomely. I suspect that's what you're paid to do, to sue people. But for you to come here and make these absolutely outrageous statements about safety, I think it's a big disappointment to me, and I don't think you should have been invited. I will be completely honest. Over.
Thanks, Cody. That just to keep track of time, we now only have 8 minutes left. But Mr. Siri, a number of, I hope you're able to keep track of that.
Yeah.
You have the floor.
Thank you. Appreciate that, and Cody, thank you for the comments. I'll just respond to them in turn. In terms of why I had a slide about the increasing number of vaccines is because I was asked to discuss the development of the U.S. schedule, which I figured showing how many vaccines increased was part of what I would present. In terms of your comment that is, something to be marveled at, I never addressed that, but I will point out that we, in terms of developed countries in the United States, have the worst health outcomes amongst all developed countries. And so that is something to, really think about when you're thinking about overall health in this country. In terms of your claiming that you may not have the time to address all my points, I welcome a debate with you if you'd like. I will sit with you for 2 hours here in this forum or any other forum if you'd like, and we can go point by point. If you'd like to do that, I open that. I welcome that. In terms of Dr. Paul Offit, I should say I have had a back and forth with him online in writing, and it's all available. It was on Twitter first, and then moved over to Substack, so on mine, then on his. So you can feel free to see Paul Offit and I debating actually specifically about vaccine clinical trials. And I think actually it's a very telling exchange with citations instead of just verbally. And I encourage everybody in the media in particular to go look at my exchange with Dr. Paul Offit and look at every single cited reference that he cites and what I cite. In terms of Dr. Plotkin and Dr. Orenstein, I was citing their article. I'm sorry you take offense to that, but that just is what it is. And obviously, if Dr. Plotkin and I have spent 9 hours together in a deposition, you can watch all of that if you'd like. In terms of IPV not preventing transmission, yes, I certainly understand the switch over from OPV to IPV, and it was good that OPV caused paralysis was recognized, but I would say that there's a number of vaccines today that also cause paralysis via transverse myelitis, Guillain-Barré syndrome. I have clients whose children are in a wheelchair today from vaccines. I don't think that those folks are considered ill-defined or rare, and that's exactly the point I was trying to make earlier. Treating those folks like they don't exist, Dr. Meisner, is what is going to breed vaccine hesitancy. They're there, they exist, just like they happen for OPV. It just took a long time for folks to accept that. In terms of DTP vaccine, I would say that most of the circles in the medical community in America still don't admit that vaccine was really problematic, though it's nice to hear you slightly admit that on right now. In terms of diphtheria, the point is that there are environmental factors that impact diphtheria, in particular its pathogenicity. And so those, for example, those immigrants you discussed who have diphtheria, when you look at the underlying science, when the studies around this, certain living conditions create an environment where diphtheria can be more harmful and cause disease, where it doesn't seem to be the case when those environmental factors are absent. I never said, by the way, stop vaccinating. I don't know why you're saying I said that or reflecting that I did. I think this is America. I agree with you. Everybody should be free to get as many vaccines as they want. I support everybody's right to get as many vaccines as they want. That's freedom. And the same token, everybody should be free without any coercion or penalty to refuse a vaccine. In terms of saying that it's ridiculous to claim that PCV was not properly trialed before licensure, respectfully, sir, I think it's ridiculous to claim it the other way. Just using your term, I normally wouldn't use that word. I think the data speak for itself. Licensing a vaccine by using another experimental vaccine as a control, I think fairly falls into the word, again, your word, ridiculous. I would just say it's not proper. I would just say that that's not an appropriate control. It does not establish a baseline of safety. And had the subsequent iterations of after that had not had serious adverse events, we're talking about babies, 2, 4, 6 months, at 8, 9%, okay, but it did. And that should be highly concerning when you don't have a baseline of safety in your initial trial. I don't understand why that should be controversial. I really can't. I also never said you can't use correlates of protection. I don't know why you're saying that, sir. Obviously, if you have a properly licensed, effective vaccine for a disease that has been properly licensed, that is the standard of care, and that should be used as the control. And obviously, in a post-elimination environment, if that vaccine prevented transmission, obviously you'll have to use correlates of protection. I have no issue with that. I've read Chapter 2 of Plotkin's vaccine book and correlates of protection. I reflect back to you, Dr. Malone, your comments about correlate of protection and the complexities on them. I'll actually have to litigate correlates of protection. In any event, I'll just, in terms of being paid handsomely, I will assure you that this is not a very lucrative endeavor. But putting that aside, I think the most egregious thing, if I may, is to call and reflect on folks who've been injured by these products as somehow rare and ill-defined. There are clear, serious risks. You just stop listening to parents. The Institute, HRSA didn't give that long list of harms to the Institute of Medicine out of nowhere. Didn't come out of Grok or ChatGPT. It's real. These are real lives. These are real people. Now, I understand, I totally understand that an infectious disease doctor every day is confronted by folks who are harmed by infectious disease. So I understand that they are more oriented towards that. And obviously for me, I every day have encountered folks who are injured by these products. And so obviously I'm more oriented to that. I accept that bias, by the way. I accept it. But I am willing to say that vaccine, that children can die of infectious disease. But the families who are impacted the other way, they're just not treated right. And until they are recognized, treated well, accepted by the medical community, don't have nasty notes put in their file if they say it's from vaccine. I've seen that often and over and over. That's just going to continue to grow vaccine hesitancy in this precious program that you're worried about. You're going to be its own undoing.
Well, can I respond, Robert, or no?
The problem is we're now at the witching hour.
Okay.
But I think we can agree that dialogue is the essence of how best we proceed towards truth and common understanding. And I volunteer that my personal opinion that the chairperson, whose image is below you right now on the screen, Dr. Milhound, may wish to consider future agendas, including continued dialogue, and I say that carefully, in the spirit of comity, COMITY, between the different communities, so that we can approach shared understanding. That's the best I can do right now, Cody. I apologize, and I also apologize to our liaisons. I hope you know that, and you can see my commitment to listening to you. But the reality of federal government official scheduling is now upon us, and we need to allow the new appointed head of Center for Drug Evaluation and Research to give her presentation. Dr. Hogue.
Okay, thank you so much. And I want to thank Aaron Seary for his talk, and I want to say that I would pay to see the debate between Dr. Meissner and you, and I also think it's it's important for people to realize what you were alluding to, that in your law firm, that it's a net loss to take on these cases of vaccine injury. Did I understand that correctly? That you really don't make money, taking on these cases? Not to put you on the spot, but I mean, I think it ties into this issue.
I think what you're saying is, when I said it, I
Like-
didn't mean it for a public forum, but yes, not something I meant to say
not that
public,
it's a
but
big
our
money
vaccine
maker.
injury compensation program, a practice will lose a significant amount of money and has lost a significant amount of money every year. Yes.
Okay, I'm sorry to put you.
No,
on the
that's
spot.
okay.
That was- God, that- if I shouldn't have shared that, but I think it also, it ties into the fact that the way that the challenges that the vaccine injured face in our society. And I wasn't planning on starting out my talk this way, but I do think that that's something to consider as we are making these recommendations, that we may not fully understand the picture of what patients are facing, because they are not able to litigate these challenges, and because a lot of these problems are not being brought to light. And I did want to say that I read Aaron Seary's book, and so I'm not, I try to learn, and I'll keep an open mind about what I don't know, and it was very educational. And I think you're not, and I recommend anyone who thinks that they disagree to read it, because I think you're trying to lay out the facts, and you're not trying to advocate for any specific vaccination schedule, if I understood correctly. But just to give us an understanding about the history of the data that we're working with, the clinical trials that were used to license the vaccines, and to understand the data that we're using to make our decisions to make vaccine schedule recommendations, and so I think that's a good segue to what I'm going to talk about, which is there are countries that look at the data that we have differently than we do, and so I'm gonna actually steal this, and acknowledging that we have imperfect information from these clinical trials, and we have some information that is very helpful, and we have diseases that are serious problems, that we need to make decisions about these vaccines based on the data that we have, and about which vaccines to approve, and then which ones the ACIP and CDC will recommend. And so I'm going to be talking today about the core vaccination schedules of the United States compared with Denmark, and I'm also going to look at a few other developed nations as well. And I think it will be eye-opening for people to see that the differences in the recommendations between our country and Denmark, and our country and other European countries. And I'm going to get a little into the basis for the decision-making that Denmark has used, and much of this is published in Danish, and so I think a lot of people have not have not gone into the rationales for their decision in great detail, and it's been very interesting to read through. So I want to explain that in addition to now, so I currently work at the FDA, as Robert alluded to. I was just appointed to be the acting director of the Center for Drug Evaluation and Research at the FDA on Wednesday night. I was, I have been working at the FDA as a senior advisor in the Office of the Commissioner and CBER since March of 2025. And my background is that I have an MD PhD. I'm a Danish and U.S. dual citizen. This is a picture of me and one of my sons in Denmark before we moved to the United States in 2015. So he was born and raised in Denmark along with his older brother. And I got a PhD in epidemiology and public health at the University of Copenhagen. I worked as a physician there as well. And it really opened my eyes to the different approaches that countries can take to public health. And it also was a reality check for me that, children and life in Denmark is not completely different than it is from the United States. And I realized that in the COVID-19 pandemic, that people kept thinking that the situation was so different in Denmark that it was, therefore fine for Denmark to open the schools during COVID-19 after 6 weeks, whereas places like we were in California kept schools closed for a year and a half, in close to 2 years, as if that would be scientifically justified because of the differences between the two countries. But in reality, life is not as different, and humans are not as different as people think. So I have 45 peer-reviewed publications, and I was actually at MIT. I was working with Dr. Levy at MIT before I started at FDA, and was a practicing physician as well. So now let's look at the core vaccination schedules for a few different countries here. And as of January 1st, 2025, the United States was really an international outlier in giving 72 doses of vaccines compared to much lower amounts, under 30 doses of vaccines during childhood. And that did include the COVID-19 vaccine, and this includes also the yearly influenza vaccine. So it shows how much we really did diverge, especially at this point, from other developed nations. And we also target the most diseases. And so, gets to the question of why are we so different from other developed nations, and is it scientifically and medically justified? And I will also say that this is part of the difference is because we give individual, or we can, not always, give individual vaccines for DTaP, Haemophilus, Hep B, and IPV, whereas Europe tends to give combination vaccines in those circumstances. And I'll get more into more details about that. So I was happy to see that it was pointed out when I was my first meeting as the ACIP ex officio from FDA in April of 2025, that the U.S. was an outlier in terms of recommending the COVID-19 vaccine to all children as a general recommendation. And I'm very glad to see that was recently reversed, and that it's no longer a general recommendation for all children. But I bring that up to point out that we were really behind the rest of the developed world in making that decision to not have that on our core vaccination schedule or a general recommendation for all children. And so just to look at the Danish versus the U.S. vaccination schedule by diseases. So here are the diseases that the U.S. vaccinates for versus those in Denmark. And so I'll get to some common misconceptions. And the Danish vaccination schedule is there on the right, and you can really see how simple it is from a parent and family standpoint in terms of how many doctor visits and shots this involves, and it's much fewer than it is in the United States. And here's another visualization of the differences. So everything that is redded out here is not recommended generally, a general recommendation in Denmark, but is recommended in the United States. And this was including the COVID-19 vaccine. So this was an image that was made in 2024, and I've sort of I corrected a few mistakes. It was made by someone else, Jonathan Pellison, and I should have given him credit on here, and I just added a couple more reds in there. And then you can see that these are the differences between the U.S. and other developed countries in terms of which diseases we vaccinate for, and then Japan vaccinates for a couple additional diseases, tuberculosis and Japanese encephalitis. And the difference in the number of doses of vaccines and diseases that we vaccinate for does result in an increased exposure to aluminum. So by age 2, children in the United States will have received close to 6 milligrams of aluminum, and it's up to 8 milligrams by age 18. And in Denmark, by comparison, it's only 1.4 milligrams by age 2 and 2.9 by age 18. And so I'm not going to get into any specific health concerns here because I don't think the data are robust to insinuate that there are any specific health concerns that I have with regards to this exposure to aluminum. But what I want to say is I do not feel like we have the data to show that there is an established safe amount that children can receive before the age of 2, before the age of 18. Considering that this is parenterally given, this is not something that's eaten, this is not digested, and so this is a different way of, delivering aluminum to a human body, and so may have different effects. And so I think we need to, admit that we may not know that, what the side effects of doing this, especially given all at once, could be. And so what do we owe our children? We owe our children science-based recommendations here in the United States, and we need to understand the potential for absolute benefit for low-risk populations when we're making a general recommendation for all children. Understand the limitations in our knowledge about adverse effects, perform proper randomized placebo-controlled trials, continue to monitor safety signals. We're not going to find things that we're not looking for, that's been mentioned before, and update our recommendations based on evolving knowledge, and have vaccines treated like all other medical products, and admit when they may not be appropriate for all children. And avoid over medicalizing childhood. Time in pediatrician's office can be spent differently, less focus on medical products, more on healthy living, and decrease overdiagnosis and overtreatment would be some benefits of, making a focused, vaccination schedule and making sure that each vaccination, the benefits we expect will outweigh the harms and have a reasonable degree of certainty when we make that recommendation. So we also should not be politicizing our recommendations like Aaron Siri alluded to, and we have seen the problems with that in the past. This is, of course, referring to Lysenkoism in communist Russia, where neo-Lamarckism was the favored scientific belief of the day, which did result, many believe, in the worsening of the Chinese famine, and opponents who expressed dissenting scientific views, which of course were proven to be more correct, were silenced, and this of course can be deadly when science is politicized, and we need to be aware of that, and we may have seen that. The most recent example of that was, of course, scientists in the United States speaking out against school closures and lockdowns. I think that we saw something similar during the COVID-19 pandemic. So again, we need to avoid political polarization, and I think a lot of people watching this meeting today maybe find themselves on one or the other side of the debate. They're very focused on, deaths due to vaccine-preventable illnesses such as polio or measles, or deaths due to injuries from vaccines. But in reality, we want to minimize harm, and to do, the best that we can at this, and recognize that, we shouldn't be divided on this. We should all be united in trying to make the best recommendations that we can for our children. And this is why, Denmark does I think one of the reasons Denmark may do a better job at making their vaccine recommendations is it's not a politicized discussion, and they have a multi-party system. They have a culture of debate, which I really loved, being part of and reading in the newspapers, living there and watching on the news. Transparent decision-making, a research culture where they really rely on randomized control trials, extensive documentation about the decision-making about which vaccines they do and don't recommend, good at acknowledging unknowns and uncertainties and promptly reversing their recommendations when they're proven not to be evidence-based, or when there's something that is identified that they maybe didn't know initially when they made the recommendations. So just focusing a little bit on the health of children in the United States. So we do not have a good track record in terms of raising healthy children, at least recently compared to our peer nations. And, we have a high obesity rate, and then I included mental health conditions here, showing that we have slightly higher rates of mental health conditions. I actually regret now that I didn't include showing that we have higher type 1 diabetes and higher asthma rates as well. Now, some of this could be differences in diagnosis and genetic factors, but the truth of the matter is, some of these we actually don't know the underlying reasons that we may have higher rates of these conditions. And so, but part of the reason that I bring this up is I want to mention that just because the U.S. has a larger high-risk population of children, should the core childhood vaccination schedule be larger? Like, does that address the problem? Or should healthy children without underlying risk factors, really receive different vaccines than they do in Denmark or other high-income nations? And I think scientifically it doesn't make sense, to make different recommendations for low-risk populations from one country to another. And so I think we've already gone over this slide, and so I want to go over this. One misconception may be that the difference in the vaccination schedules has to do with difference in prevalences of diseases, and I'm going to focus on U.S. versus Denmark. And this is the incidence of hepatitis B in mothers and the prevalence of chronic hepatitis B. And as you can see, the United States and Denmark are roughly comparable in these incidences and prevalences, and Denmark does not recommend routine vaccination of hepatitis B to children at all. We're not just talking about the birth dose. They do not recommend it at all. And so in terms of the incidence of meningococcal disease, which is also a vaccination that they do not recommend in Denmark, we also have very similar incidence rate of meningococcal disease in the U.S. versus Denmark. And I'm going to get into a little bit more detail about that in the next slide. So here you can see on the left incidence of meningococcal disease in the United States versus on the right in Denmark. It's not exactly the same because on the right it's actually number of cases per their 5.5 to 6 million population over time. And so, but the major point that I wanted to make is the incidence has been decreasing in Denmark in spite of not implementing routine vaccination, and it has been decreasing here as well, not clearly related to the implementation of the vaccination program. So then I want to transition to measles. So there has been an increase in measles cases in both the U.S. and Europe. And I think that the increase in Europe has not gotten as much attention as it has in the U.S. and Canada. But I think, that's an important point to make, that we're not alone in that increase. And that the increase is predominantly among the unvaccinated. So this is reality. And so, it's important to state, we know that the measles vaccine does prevent measles, and that we are seeing measles cases among unvaccinated children. And this is these are data from Europe here. And Denmark does have a very high vaccination uptake rate in their population, and they have not seen an increase in measles cases over time. And here are the vaccination rates, however, overall. And very interestingly, so in 2024, we had very similar rates of MMR and DTaP, Hib, and IPV vaccination rates as Denmark at the age of 5. But here's a difference that I want to point out. So it varies a lot in the United States, and there are some areas of the United States that are well below that 90% threshold that is commonly cited to prevent outbreaks of measles. And so I think that this can explain why we are seeing outbreaks and Denmark is not. And so Canada recently lost its measles elimination status, and will the U.S. be next? And so what did Canada and the United States have in common besides geography is that we both recommend a very large number of vaccines and also start vaccinating children immediately when they're born. And, I'm not proving cause and effect here, but it is interesting to note that, we are having issues with outbreaks of vaccine preventable diseases because of many areas of low uptake of vaccines. And we, despite along with the fact that we also recommend way more vaccines than any other countries do that are less likely to currently be seeing outbreaks. And so, you know, I think it ties into trust. And so I was going to talk about rubella as well, because we are actually, and I'm going to get back to this issue of trust and in a moment, but I want to talk about rubella for a second here, just because it does cause congenital rubella syndrome and has a community immunity threshold of 83 to 85%, and there's some pockets of America and entire states where average vaccination rates are below this, and we may start seeing congenital rubella cases again, which we would like to avoid. And so I want to talk about this issue of trust in the U.S. healthcare, how it decreased from 72% prior to the COVID-19 pandemic to 40% more recently. This was from last year, from 2024. And so you can see that trust this is in physicians and hospitals, declined actually most in around 2022. And if you think back, I mean, that was really when we were still seeing issues with vaccine mandates, and we were seeing, you know, continued masking, and there was this sort of, the United States was departing more and more from the rest of the world in terms of continuing sort of COVID measures, when the rest of the world had really moved on at this point, and there was a lot of trust lost. And I don't want to say cause and effect, but it's interesting to note the timing of this loss of trust in public health. And so this ties back into mandates, which Aaron talked about as well, in that the United States has this history of mandates which departs from most high-income nations, and almost every country in Europe do not have vaccine mandates. And you know, it's interesting how we got to that point that we develop mandates, but I do think that has contributed to a loss of trust when people are coerced to take vaccines. So now focusing on Denmark. So here again is the core vaccination schedule in Denmark and how it differs from the United States. And Aaron went over a little bit how the schedule was developed over time, but most of the ways in which our schedule deviates from Denmark are the more recently added vaccines, with the exception of with the exception of HPV, and let's see what else is the pneumococcal vaccine. And so otherwise, Denmark has been much less willing to adopt the newer vaccines into their core vaccination schedule. So including Hep B, varicella, influenza, and rotavirus, all of those, Hep A, they do not recommend. Meningococcal, COVID-19, and RSV, none of those. Denmark still has not recommended the use of those routinely. And are they seeing outbreaks of those diseases that are more than we are in the United States? The answer is no, that I have not seen that. I have not seen evidence of that. And so let's see. So I want to talk now about how Denmark makes its decisions. And examples of some decisions that they have made with regards to vaccines. So Denmark was the first high-income nation to remove the COVID-19 vaccine from the childhood vaccination schedule, and they were ahead of the international curve there. So here in June of 2022, the Danish Ministry of Health stated that vaccinating children for COVID-19 had been a mistake. In retrospect, we didn't get much out of vaccinating children, and at this time, they took it off of the child vaccination schedule for all children under the age of 18. Influenza vaccine. So historically, Denmark, along with almost all European countries, they do not recommend the influenza vaccine for all children. But Denmark recently started recommending it for children ages 2 to 6 in 2021 in an attempt to prevent transmission among the elderly. They saw the uptake was low. They also saw that it didn't have the desired effect of reducing transmission to the elderly. So by 2023, they took it back off of the schedule. So they tried something and monitored it, and it did not work. And so then they removed that from the schedule. So influenza is an interesting vaccine because, as many of you know, we do not have randomized controlled data in any age group showing that it reduces hospitalization, death, or transmission. So that's outlined in 3 different Cochrane reviews of different age groups. And then pandemics vaccine, that actually was something that I think alerted a lot of Europe to this issue of the problems that you can see when you vaccinate a very low-risk group. And so the pandemics vaccine resulted, actually, it had a very high high rate of side effects, of severe adverse effects. But the most famous was narcolepsy, which developed in over 1,000 children. And there was very delayed recognition and reporting of this occurring, which is a very serious side effect. And so it really, at that time, that vaccine was recommended in countries such as Finland and France and Sweden. And I think it made a lot of countries in Europe, kind of consider, be more careful about their vaccination recommendations in low-risk groups. And as I stated now, essentially all of Europe does not recommend yearly vaccination of children with the influenza vaccine, unless their countries have different recommendations for children with risk factors. So the hepatitis B vaccine, so I'll get into the English version there. So if one includes this is the Danish decision making behind whether or not to include the hepatitis B vaccine in the child vaccination schedule. So they state, if one includes a vaccine which some consider less important, it could negatively affect the view of vaccines in general. The result of this could be that the current vaccination program would have lower uptake. So these are the sorts of things that they consider in their decision making. And then they have, I alluded to this yesterday, that they have this extensive risk-benefit analysis that they published along with their decision not to recommend the hepatitis B vaccine. And they publish these analyses regularly because they continue to monitor if they have more information about the risks and benefits. And so there are substantial costs of the hepatitis B vaccine and low opportunity for benefit. So this is for the childhood program. Population-wide vaccination could not be justified from a health economics perspective. And so instead they've created this list of high-risk groups which they will give vaccination and so in coverage for, so insurance for vaccination. And in terms of the meningococcal vaccine, so this is also, they published their decision making, and this is their medical journal. So they state again, the opportunity for benefit among non-high-risk children is very low. Again, I'll get back to the point that I made about the very similar incidents between Denmark and the United States. They cited uncertainty about effectiveness, and adding additional vaccines to the core vaccine list may cause some parents to opt out of other vaccines. If the vaccine causes fevers in an infant when given with other vaccines, this could have negative consequences for physicians and parents. So they take these things into consideration when making their recommendations. And then they make a list of the high-risk conditions that where they say that people should consider getting the vaccine. And one of them is that I thought was interesting was they actually specifically mention, U.S. is the only country that they mention where they say it is going to be required if you travel to the United States as a student to study. And so they make that caveat. So again, showing how we're an outlier in requiring that vaccine. So rotavirus, the rationale for not including the rotavirus vaccine is, so and this is going to be up for review again. So it has until now been the message of the Danish Ministry of Health that Denmark not introduce vaccines into the child vaccination schedule just because it is an option. The Danish child vaccination program has a goal of protecting children from infections that can be either deadly or have long-term health consequences. Infection with rotavirus essentially never results in death or chronic consequences in a country like Denmark. Literature review has not shown that this vaccine has an effect on children's mortality. So this was the basis of their decision-making. In terms of the varicella vaccine, which they also don't currently recommend, they worry that natural immunity is stronger. Only 4% of general and family physicians would recommend the vaccine to healthy children, and there's insufficient data about long-term effects. As in the pros in their decision-making was that Denmark has very low rate of stay-at-home parents, and they would miss less work. But so they, thus far, have decided not to implement that into their vaccination schedule and prefer children to get varicella at a young age. Now they're going to revisit this, interestingly, because they have made the vaccine available for purchase, which they believe is increasing the average age that the children are now getting varicella, and it's causing more severe varicella infections. So they may actually end up introducing this into the vaccine schedule because of having made the vaccine available for purchase. And I went over that already. So here, RSV, long-acting monoclonal antibodies, also not on their schedule, and it's not even available for high-risk infants in Denmark. There are actually very few countries that are currently recommending this. This was discussed in the previous ACIP meeting in June, that there is this unfavorable imbalance in all-cause mortality in all 4 phase 3 randomized trials, and the 2 nirsevimab and clesrovimab are the 2 long-acting monoclonal antibodies for prevention of RSV. So I just made this forest plot to show visually what that looks like, and the p-value that I got, and there's different methods for calculating the p-value, but I got a p-value of 0.068, so not quite statistically significant, but yet this is very concerning to see this in all 4 randomized trials, to see that there's actually a higher death rate. And so, you know, I think that this is something that could also be revisited by ACIP, and this is just to show that Denmark has taken the approach of giving parents the option of buying certain vaccines if they're not generally recommended and covered. And so I just wanted to show that that's another way that they differ from the United States. So some of the benefits of the Danish child vaccination schedule, that it may increase trust and focus on the core vaccines. It may be increasing general uptake of those vaccines throughout the entire population. It's based on thorough, transparent decision making, which is continually updated and debated. They have been able to prevent outbreaks of the most deadly and serious vaccine preventable diseases. The fact that so they do things differently than are done in the United States in terms of their recommendations does mean that there is international equipoise. So for these vaccines, we really do have an opportunity to do randomized trials to look at, you know, for potential safety concerns, if there's residual questions about efficacy. So I think that's important to keep in mind. You know, when people say that it's unethical to do the trial, look at other high-income nations and see, you know, do they recommend it? If not, you know, it would be ethical to do that trial in almost all circumstances. I mean, there could be exceptions I'm not considering, but something to consider. And make more, so I got into this already, that, you know, if there's less focus on vaccines, there's more time for addressing overall health at doctor's appointments, and less visits to doctors means less time in the healthcare system and decreased medicalization of childhood. So I think you know, there is an opportunity to better define high-risk groups when you don't make a general recommendation to all, so to be sure to target them for vaccination, and improve informed consent, and minimize coercion because they do not have mandates. And I think that's just about it. So, yeah, I think I'll actually end there. Thanks.
Thank you, Dr. Hogue. Allow us to take a few more moments of your time, if you don't mind, before your upcoming important government meeting. We have on the schedule until 2:55, and it's currently at 2:37. So once again, we're a little bit tight. Starting with ACIP members, questions for the presenter, Vicki?
So I know you were here to talk about the childhood schedule, but I'm just curious about whether Denmark vaccinates pregnant women.
So I know they recently removed the recommendation for the COVID-19 vaccine during pregnancy because they had listed that, and now they removed that. They do recommend, so I hope I'm not wrong about this. I'm going from memory now, but so they do recommend the influenza vaccine and during pregnancy, and I am actually not sure about the RSV vaccine. I would have to look that up. I apologize.
Dr. Levy.
So thanks. This was fascinating. When I listened to your presentation, I kind of there were three things that were highlighted to me as fundamentals for creating trust in public health policies, and maybe more specifically vaccine programs. The first of which is common sense. It seems that they apply a far more common sense approach, and it starts with the way they think about risk and the way they think about the risk of the infection, of getting infected, and the outcomes, and really focus on medical interventions on the places where it matters the most.
Yes.
The second thing is that they avoid mandates and coercion, and they avoid and they give education and give people the sense that they can make decisions based on information. The one thing I wanted to ask you is how do they perceive and how do they treat the vaccine injuries and vaccine injured people? Because I feel that that's here in this country one of the other really ethical failures that we have had as a society, that we've and partially it's because we have a religious belief that vaccine cannot cause real harm, and I think that connects with basically not only acknowledging vaccine injured people, but more often than not gaslighting them, not investing in understanding the risk factors and the treatments. This has been very, very visible on the COVID-19 in the context of the COVID-19 vaccine, but I think it's probably a more general phenomenon. So I wonder if you can share what is the situation in Denmark.
Yeah, I mean, it's something that's actually discussed much more openly and more often in the public and in the news. Is vaccine injury and just drug and vaccine medical product injury, and they do actually tend to. I know that it's a struggle for many vaccine injured to get their conditions recognized and have it compensated in Denmark, but I would say that they have been more willing to recognize and compensate vaccine injuries than the United States has. And so, yeah, they definitely have been. And I think that's such an important discussion because really, the VICP and CICP, from what I hear, it's incredibly difficult to get compensation for, even established vaccine injuries. And I think I've heard the most about CICP in the United States, that even, well-established side effects and safety issues from the COVID-19 cannot be compensated.
And if I may add, I think it starts with the scientific and clinical community, and it also relates to the media. So these programs have their own problems, but I want to call out us as a society, as a scientific community, as a clinical community, and more broadly as a society. I think we have failed in a very, very significant manner to address these issues that I believe is fundamental for the success of vaccination programs and building trusts.
Do you mind if I, Vice Chair Malone, do you mind if I jump in here? This is Dr. Grimes with HRSA.
Go ahead, please. You're on the list. You had just been at the bottom of the list, so go ahead.
Oh, great. Sorry. So I just wanted to throw in here as the director for the Division of Injury Compensation Programs, where we administer both the National Vaccine Injury Compensation Program, or the VICP, and the Countermeasures Injury Compensation Program, or the CICP. We have two systems in place in this country. One is a medico-legal process where the VICP resides, and that is a no-fault alternative to the traditional tort system. I mentioned yesterday about 77 to 78% of claims are compensated in that program. And so that is kind of a medico-legal process that is a tripartite system between HHS, the Department of Justice representing HHS, and the U.S. Court of Federal Claims, specifically the Office of Special Masters there, that work with both the DOJ and the plaintiff's attorneys at the petitioner's bar to support those cases. In last fiscal year, or actually I should say fiscal year 24, that program paid out approximately $203 million in claims. The CICP is an administrative system for handling compensation claims. It has a different evidentiary bar, so where the VICP is a more likely than not standard, the CICP has a compelling, reliable, valid medical and scientific evidence standard, so it's a higher bar for compensation in that program as dictated by statute. My understanding of Denmark is that they have an administrative system for handling compensation claims related to treatment of injuries. And because they have a universal healthcare system, there is kind of easier access into who has those injuries and some easier communication, I would say, with those potentially vaccine injured in that country. They do have caps on compensation in Denmark that the VICP and CICP do not have caps as far as what can be compensated. My understanding is that for vaccine injuries in Denmark, they can be compensated up to, I want to say it was $1 million US or 5 million Danish kroners. And as a comparator between the VICP Denmark system in 2024, I believe they paid out about 7.5 million US dollars. And again, much smaller country. Thanks.
Thank you for those clarifications. Do you have follow-ups, Tracy? Are you okay with that?
No, that was fascinating information. Great. I really appreciate that.
So with that, Joe Hiblin.
Thank you very much for this new view of the world from Denmark. And since getting data on risks and benefits and communicating risks and benefits are so fundamental to making informed policy processes and communicating them, I'm glad that Denmark uses the evidence to recommendations practice. How do you think we can better get data that neutrally evaluates both the risks and the benefits in our trials and in our communications? How can we do better?
Fantastic question. Thank you. Tracy?
Yeah, I love that question too. I do think that we need a dedicated team of scientists to put together risk-benefit analyses, and who that should be. I think it could fall under HHS for sure. It could involve NIH. It may involve people on the ACIP. But it's definitely something that I think should accompany, vaccine recommendations. And I think that would help inform the public so much if they could read the evidence and rationale behind the decision making made, especially when a new vaccine is recommended, a vaccine or product is recommended, and so that they can read the data themselves and decide if they're comfortable with that. And I think that that's, that means a lot to Danes, that information like that is in general available to them. So I'm not sure exactly where it should come from, but I really think that would be helpful if and would really inform the decision making of ACIP, because as we learned from Aaron, it's, after the approval, they're recommended and put on the child vaccination schedule so quickly. It's hard to believe that there has been time to get the information to even do a thorough risk-benefit analysis for the recommendation, because really, just because a vaccine is approved, it doesn't mean it should just, approved for all age groups or all children. It shouldn't automatically go on the child vaccination schedule. There needs to be some deliberation about how appropriate it is for all children.
Well, what a blessing to hear that from a senior FDA official. Cody Meissner.
Thanks, Robert. First, I want to acknowledge Dr. Kirk Milhone, because it's 13 hours ahead, I believe, of Eastern time, and so it's 3:45 in the morning, I think, where he is. So he should get a pat on the back for his fortitude. Secondly, Tracy, it was a wonderful and very interesting presentation. I really enjoyed one of your opening slides that showed your healthy, happy son, because that's the objective of all of us. I mean, we're really trying to ensure that everyone has as healthy a child as is possible. So I thought that was very helpful. The question I have for you, and this may be more appropriate for the CDC, but can you estimate, do we have any assessment of how many of the increasing number of cases of measles that are occurring in the United States and in Europe are occurring among immigrants who lack immunity to the virus? And then I have one more, while you're thinking that, one more question for Dr. Reed Grimes. One more point that I've always thought was the reason that the Vaccine Injury Compensation Program was important is because they reached a settlement much faster than the ordinary tort system. And so if an award was indeed made by the masters, then the award came quicker than if it went through a regular civil court. Over.
So I can answer a little bit of I can answer partially the first question, which is we did see that the increase in Europe, they at least have the data in Europe in the measles cases, was among unvaccinated. Now, if it was immigrants, I don't know, but it did look like they lacked immunity. I will put it that way. I don't know if they were immigrants or not.
And I think the data in the United States indicate that something in the range of, is it 93% of the cases are in unvaccinated and the others are potentially breakthroughs. Does that sound about right?
I mean, that would be consistent with, it looked like what they were showing from Europe, so that would not surprise me.
Now, my interest, if the CDC is on board, is how many of those are, because I think that's about right in terms of breakthroughs, are occurring in immigrants, but that may be a CDC question. But I see Dr. Grimes is here.
Yeah, so I can just say that the VICP was designed to be a no-fault compensation program to work faster and with greater ease than the civil tort system. So it's meant to facilitate quick adjudication of claims, particularly those table claims where there's a presumption of causation at the time of injury. or at the time of filing, I should say. And so it is meant to work faster. It still takes approximately 2 to 3 years from time of filing to time of payment or time of adjudication, but it does typically work faster than the civil tort system. Over.
Can we, in terms of additional CDC subject matter experts, Dr. Meissner is particularly focused on incidence of measles and correlation with unvaccinated immigrant populations. And I infer from my physician colleagues who have been managing border vaccination stations that if one comes across with authorization, one that becomes fully vaccinated, irrespective of your prior history. So that would imply non-traditional immigrants. Am I using the correct PC term? So do we have, from the CDC, do we have data on measles incidence or risk associated with non-traditional immigrants?
Hi, this is John Sue from the SME speaker room. I believe that question would be appropriate for colleagues within immigrant and refugee health or potentially within measles, but we do not have any such SMEs present in the room at the moment.
Roger,
we can get back to you maybe.
Yeah, we'll get back or posting in some public forum. I imagine that there are many that have that question, and putting that to rest would be useful. I have some information about the history of the original West Texas outbreak, but that's anecdotal and secondhand. So let's see, Dr. Pagano, you're going to pass, okay? Which leaves us with 2 minutes left. I apologize again to my valued liaison colleagues. Dr. Robert Schlechter, are you available? Do you have questions for Dr. Hogue? Not hearing from Dr. Schlechter. Dr. Munoz.
Yes, thank you again. I just wanted to comment regarding the overall dynamics of recommendations for vaccines in the interest of the public health, and that we do recognize and appreciate the discussion regarding the fact that the recommendations for vaccination must take into consideration new data and information to be adapted to needs. However, I would have to say that unfortunately some of the information presented this afternoon was misleading and probably a misrepresentation of actual data.
I'm sorry, we're focusing on Tracy's presentation. Does this relate to
Yes,
Dr. Hogue's presentation?
Yes, it relates to that as well, because I would just point out that it seems to be irrelevant to compare United States policy with Danish policy, given that indeed the data and the decisions need to be based on our local information and needs. And if anything, what we have seen with our yet imperfect system is that it works because we're able to identify safety signals and we are able to adapt guidance.
Okay,
And
Dr. Munoz,
Yes, sir?
thank you. So I register your belief system that comparison of the two systems is irrelevant and inappropriate. And I think we can take one more question. Dr. Stacy Buchanan, are you here?
Good afternoon. Yes, I'm here. With regard to looking at our current measles state and what's going on across in Denmark, there are lots of pockets of communities within the United States that are unvaccinated. And, you know, just briefly looking, it doesn't seem like Denmark has those pockets of communities. So when we talk about that type of comparison, I think that we should be clear on what the community population basis is, because Denmark is a small country in comparison. My understanding is that it's the size of Wisconsin. So when we talk about changing policy for the entire United States, we need to take that into consideration.
Roger that. I'm not aware
I
that
mentioned
changing
that.
policy on measles vaccines is
Yeah, exactly.
consideration currently, and
That
I
was-
am very aware that the Secretary has been explicitly clear, despite various commentary from our good colleagues in the press. The Secretary of Health has been explicitly clear that measles vaccination works, and he has recommended measles vaccination. Is that consistent with your understanding, Dr. Hogue?
Yes, I want to say that it is a common vaccine on the child vaccination schedule between the U.S. and Denmark is the measles vaccine, and I did point out in my talk that there are pockets of the United States with very low measles vaccination uptake rates, and that may relate back to this broader issue of loss of trust in public health in the United States.
Dr.
Perhaps I
Hogue?
missed that point. I'm sorry about that. One last comment.
No, I'm sorry. We're now at the witching hour. Dr. Hogue, you are released to your higher level responsibilities. I wish you well with your upcoming teleconference or Zoom or whatever it is. And with that, we're going to transition straight to a presentation from Dr. Griffin concerning overview of aluminum-based adjuvants.
No worries. Thank you. I'll be tasked with keeping everybody up for the last portion of the day. All right. So good afternoon. Again, my name is Dr. Evelyn Griffin. I am part of 3 work groups with the Advisory Committee for Immunization Practices, the Childhood and Adolescent Immunization Schedule, Human Papillomavirus, and Vaccinations During Pregnancy work groups. Today, I will be giving a very brief presentation on adjuvants, specifically aluminum-based adjuvants. A little background, I'd like to take a moment to discuss the background rationale for this presentation. During our childhood immunization schedule work group research on the birth dose of hepatitis B vaccination, studies and a discussion arose regarding aluminum adjuvants. We wanted to spend more time on the topic, but quickly realized that it was beyond the scope of the work of the work group. So furthermore, the topic of adjuvants is germane to most ACIP work groups, given that most deal with adjuvanted vaccines. The topic of vaccine adjuvants is extensive and complex, making it challenging for any single work group to conduct a comprehensive evaluation. Therefore, it was proposed that a brief discussion be prepared and presented to the full ACIP committee, with consideration given to establishing a dedicated work group on adjuvants and perhaps other ingredients. Discussion will follow at the end of this presentation, very likely brief discussion, and then we will have more time for discussion in a follow-up meeting after a debrief after this meeting. There will be no vote. So therefore, this presentation will have a twofold objective in alignment with the ACIP Charter, which directs us to provide advice and guidance to the Director of the CDC regarding the use of vaccines and related agents. The initial objective here is for ACIP to consider establishing an adjuvant work group to support the formulation of guidance towards a recommendation. Alternatively, the committee may explore other ways to address this topic along with a broader landscape of vaccine ingredients. The other objective is educational, to help the public better understand the composition of the vaccines that they and their children receive. In this way, hopefully together, along with manufacturers and research scientists, we can achieve the best products and overall outcomes. Please know that none of the ACIP members are adjuvant researchers, so it bears repeating that this is a very cursory presentation. Vaccine overview over here. This is not a complete list of all the vaccine categories, but some of the more common ones that are listed here. Measles, mumps, and rubella is an example of a live attenuated vaccine. There are gene therapy-based products. There are also killed subunit or recombinant vaccines. Hepatitis B vaccine is an example of a recombinant vaccine. The category of killed vaccines refers to pathogens that have been inactivated, cannot replicate and cause disease, and are subsequently used as the antigen portion in vaccine formulations. Vaccines contain multiple components, including antigens, adjuvants, preservatives, and so on. Detailed information can be provided and read in a vaccine's package insert. So as you can imagine, every vaccine is unique, and each ingredient, each component may contribute to the risk, safety, efficacy, and effectiveness of a vaccine final product. Briefly, for the general audience, an adjuvant is any substance or compound added to a vaccine to enhance the body's immune response to the antigen. Antigen is the portion that mimics the pathogen. Adjuvants stimulate the innate and adaptive immune systems and immune responses to augment vaccine efficacy as well as long-term effectiveness. The vaccines that contain adjuvants are typically the killed subunit recombinant types. Adjuvanted vaccines make up the majority of the childhood and adolescent immunization schedule. Some vaccines administered in pregnancy are also formulated with adjuvants. Of note, the FDA approves final drug products. It does not approve adjuvants. As such, there are no FDA-approved adjuvants. There is a variety of different adjuvants, as you can see here. Most of the killed subunit recombinant vaccines rely on aluminum salt-based adjuvants. They have been in formulation since the 1920s and are most widely used adjuvants in FDA-licensed human vaccines. Common examples are aluminum oxyhydroxide, or trade name alhydrogel, or aluminum hydroxyphosphate, trade name Adjufos. Environmental aluminum is the most abundant metal in the Earth's crust. It is never found as a free metal in nature because it is a very toxic element, reactive element, as described by the Agency for Toxic Substances and Disease Registry. It is, of course, very important to note that environmental aluminum is not the same as aluminum salts used in vaccine adjuvants. The vaccine adjuvant activity of aluminum salts was discovered largely by accident by British immunologist Alexander Glennie in the 1920s. Mechanisms that underlie the use of aluminum salts in vaccines are not fully understood. However, they are known to trigger local inflammation and recruit antigen-presenting cells, such as dendritic cells and macrophages. They predominantly drive an antibody response rather than the Th1 type cellular immune response. To date, Mosas and et al. Study from 2013 is the only published peer-reviewed study of aluminum blood levels observed in infants after aluminum adjuvant containing vaccine administration. It was fairly small sample size. Serum aluminum levels were measured before and 24 hours after vaccination. There was no significant detectable mean increase at 24 hours relative to pre-vaccination levels. This study did not collect any long-term data. The United States ATSDR, or Agency for Toxic Substances and Disease Registry, determined a minimum risk level, or MRL, for orally ingested aluminum. They determined that this to be about 1 milligram or 1,000 micrograms aluminum per kilogram per day based on animal data. This assumes about a 0.1% oral absorption. By design, a healthy gastrointestinal tract effectively limits systemic absorption of potentially harmful or xenobiotic substances, something that Dr. Tracy Hogue referred to, the difference between getting it injected versus eating it. So if this calculation is converted to a injected equivalent threshold, this approximates 1 microgram per kilogram per day. Now, there is dispute over this derivation that is beyond the scope of this cursory talk, but serves as a relevant topic for further discussion, for example, by a dedicated ACIP work group, and separately as additional opportunities for study grants. Now, regarding ATSDR, it is important to mention that the agency focuses on environmental exposures through inhalation, dermal contact, and ingestion and not injected substances. However, it is rational to deduce the need to exercise great caution and scrutiny for substances delivered via injection, given that they circumvent the human body's primary immune defenses. So for vaccinations, the U.S. Code of Federal Regulations limits aluminum to 0.85 milligrams or 850 micrograms per dose, regardless of age group. So how did we arrive at 850? In the 1997 Flarand animal study, rabbits were administered doses up to 850 micrograms total intramuscular aluminum and conducted over 28 days. Aluminium, by the way, is the preferred name in or name and pronunciation in British Commonwealth English. It's the same thing as aluminum in American English. This 850 microgram dose included aluminium hydroxide and aluminium phosphate adjuvants. This resulted in transient blood level increases that resolved quickly with no acute or chronic adverse effects observed. This is still the FDA-accepted benchmark for human vaccine adjuvant dosing, which has been critiqued for how much these conclusions or how these conclusions were made, and for the basis by which this regulatory threshold was thereby established. So why focus on aluminum dose in vaccines? Infants receive multiple aluminum-containing vaccines in a single visit under the current schedule. And as you just heard, in additional vaccines that have been added to the schedule, the appropriate testing was not performed. Another pharmacokinetic consideration is that dose per kilogram body weight is far higher in early infancy than in adults. Most significantly, neonatal kidneys, blood-brain barrier, and detoxification systems are not yet mature. There are, of course, similar considerations when studying vaccinations for children as well as for fetuses through vaccination during pregnancy. So let's review the aluminum content in vaccines. Here you see listed different vaccine products, whether monovalent or multivalent, in rows, according to their trade name and with respect to antigens in the columns. The aluminum content varies from 0.225 milligrams to 0.85 milligrams per dose. Here's the rest of the schedule. Of note, MMR, varicella rotavirus are live attenuated vaccines, and along with meningococcal A and influenza vaccines, they do not contain aluminum. Here is a graphic showing the amount of aluminum in some of the vaccines in the childhood schedule. At one pediatrician visit, a child may be administered multiple aluminum adjuvanted vaccines. In one example, if a child receives Prevnar 20, Pedvax Hib, and Engerix B, and Infinrix, this is a total of 1,225 micrograms of aluminum. Noted here is that PCV, or pneumococcal conjugate vaccine, Hib or Haemophilus influenza type B vaccine, hepatitis B vaccine, and DTaP or diphtheria pertussis and acellular pertussis vaccine are administered multiple times by 6 months of age. It does bear reminding that the rate at which aluminum from vaccines migrates from human muscle at the injection site to the bloodstream, that rate is not known. Therefore, accumulation in tissues is not only a possibility, but a warranted concern. This slide demonstrates the difference between vaccine brand and combination selections. It is striking that there can be a twofold difference in the aluminum exposure despite the same schedule. Please keep in mind that there are proprietary reasons beyond the scope of this talk for these dose differences, and more importantly, that there may be other ingredients in each of these products that are not being shown here. So again, this can be another point of discussion for an ACIP work group that may choose to review this topic. Of note, by age 12 months of age, in contrast to the US, in Denmark, the children are exposed to roughly 3 to 4-fold lower amount of aluminum, as you just heard from Dr. Hogue as well. Taking into consideration child health concerns with respect to aluminum exposure, the FDA cited the Federal Register in 2003, saying the following: term infants with normal renal function may also be at risk because of their rapidly growing and immature brain and skeleton, and an immature blood-brain barrier. Until they are 1 to 2 years old, infants have lower glomerular filtration rate than adults, which affects their kidney function. The agency is concerned that young children and children with immature renal function are at higher risk resulting from an exposure to aluminum. Now, I need to mention that this was being described in the context of environmental exposure, dermal exposure and absorption to aluminum antiperspirant. The aluminum antiperspirant is very different than aluminum adjuvants, obviously. However, the significance of this citation is that it acknowledges the immaturity of organs in infancy and their capacity to eliminate xenobiotics. And indeed, experimental and clinical data suggest that intramuscular injected aluminum and aluminum salts can persist at the injection site, then migrate via immune cells to liver, spleen, and other organs, including the brain. Referencing back to the Flareland rabbit study, it was demonstrated that the distribution profile of aluminium to tissues was the same for both adjuvants, including aluminium hydroxide and aluminium phosphate, most in the kidney, then spleen, liver, heart, lymph node, and least amount in the brain. It is troubling that this was detected in the brain, however. There are yet other concerns in the study, but again, this would serve as topic for ACIP work group. Gherardi and colleagues were the first to characterize macrophagic myofasciitis. Muscle biopsies showed aluminum-containing macrophages in granulomas at previous intramuscular vaccination injection sites coined MMF lesions. An association was additionally observed between the condition and chronic myalgias, fatigue, and cognitive difficulties. A causal link between injected aluminum and aluminum salts, such as aluminum oxyhydroxide, with systemic symptoms is not universally accepted. However, MMF lesions certainly demonstrate long-term persistence of aluminum in human tissue. So are aluminum-based adjuvants biocompatible and always well-tolerated? Further studies are certainly needed to determine which individuals may have reduced tolerance to these adjuvants and whether a prolonged asymptomatic interval precedes symptom onset. Basically, this is what was mentioned yesterday with chronic disease or autoimmune conditions taking years to decades to develop, certainly more than 5 days. An expanding body of research indicates that cumulative burden of aluminum merits careful evaluation. This includes studies detecting aluminum in postmortem brain tissue of neurologic patients, autoimmunity, investigations into aluminum neurotoxicity, neuroinflammation, and atopic conditions. Advances in technology and contemporary scientific insights are facilitating the characterization of aluminum-induced oxidative stress mechanisms, including pathways that disrupt mitochondrial function and impair cellular energy metabolism. In the interest of time, I will not review these data gaps as we all get the picture, and these can be discussed at a potential future work group. So that brings us to this query we have for our ACIP colleagues. How should ACIP continue to assess effectiveness and safety of adjuvants in currently authorized vaccines on the schedule, meaning childhood, adolescent, adult vaccines, and vaccinations given during pregnancy, and related implications for the entire schedule? Some other considerations: should multiple aluminum-containing vaccines be administered on the same day in early infancy? Should lower aluminum formulations and spacing strategies be preferred when possible? What research is needed to define a genuinely evidence-based safety margin for injected aluminum? What prudent policy would reduce peak and cumulative aluminum exposure in the most vulnerable while urgent research gaps are addressed? And before we get into this discussion, I would like to acknowledge the decades worth of relenting work in the field of vaccinology. Pharmaceutical companies, researchers, both independent and academic institutions, regulatory bodies, public health agencies, healthcare providers, manufacturers alike have been working for decades towards the prescribed common goal of preventing communicable diseases. And I applaud hearing that we are all interested in the same goal of both vaccines preventing communicable diseases, but would also encourage that we focus on programs that will improve our own immunity so that our own defenses can also be of help, because we cannot out-vaccinate ourselves against every pathogen in the world. Nevertheless, we should note that vaccinology, as with all science, it does have its limitations. Ensuring safety will require all of us to study it and monitor it continuously. May we all come to the table. Finally, I would like to address to the media regarding this presentation as well as the events of the last 2 days. Important and impactful information was shared, and I encourage the media to share full segments of these sessions, even the debate. We are not scared of it. Media polls show that strong public interest in long format, in-depth coverage is successful if Joe Rogan's popularity is any sign of that. So I find the public to be thoughtful and discerning in an era of healthcare skepticism. Including direct, unedited information helps rebuild trust by allowing people to make their own informed consent. And finally, I would like to recognize that we are sensitive to children and people that succumb to pathogens, and that is a sensitive matter. That is allowed to be talked about. What has not been allowed to be talked about is injuries to vaccinations, and that's why it tended to have dominated conversation here. But one example as to why this may be not as known, respectfully to Dr. Meisner and others, is one example of profound autism. These children, often there will be an autistic child, and it is unclear whether this is related to a vaccination or not. The problem is, in terms of why it is not investigated, is because these parents often can't leave their homes. Profoundly autistic child can be found to be very disruptive, sometimes violent to themselves and family members then come to practices, try to address whether this is due to or associated with a vaccination, ask to have vaccinations spaced out, and they are discharged from their practices, pediatric practices. So the system does de-incentivize this from being discussed. And that is why I felt the need to additionally recognize these parents and children. So thank you very much for this presentation, and I will bring it back to, if I can, to the slide of the query question. Maybe not. Thank you.
Thank you, Dr. Griffin. So this is, if I'm understanding you correctly, please correct me, the intent of this deck is to provide some general structure to asking the question of whether or not there is merit for the ACIP or a working group to begin as another investigative matter in assessing the data regarding the safety of adjuvants in general and their risks and benefits, as well as that of aluminum-based adjuvants, recognizing that they're not a separate regulated product, but rather an ingredient in a number of vaccines. Do I understand that correctly? So that's the core question here to the ACIP membership here at the end of this very long 2 days is what opinions do we have among ourselves about this question that Dr. Griffin is posing to us? Is there merit to further investigation by the ACIP of this topic area? So questions open for discussion?
I may add, this was not on my behalf, but a collective request.
A collective request. I apologize. So do we have any discussion about the merit of taking up Dr. Levi? I'm stunned. Please share.
Yes, so 2 quick thoughts. I think that one of the things that I think we are not humble enough is the very partial understanding that we have what is happening in the body of young babies when they're exposed to different stimulus, and including vaccines. I think that unfortunately babies cannot tell you how they feel more often than not. And I think that the biology of our body and our immune system and our central nervous system is complex. I think that there is evidence that stimulation of the immune system in utero or early childhood can interact with the neurodevelopment. This is actually studies that come from Duke and talk about different sources of stimulation, not on vaccines, but I think vaccines is yet another form of immune stimulation. I think that when I think about aluminum in particular, I think that the tension here is between the recognition that aluminum is a major component that is common to a lot of the non-live vaccines. And I think that it was mentioned in one of the previous presentations that non-live vaccines seems to have non-specific effects, namely those that are not corresponding to the target virus that are typically negative versus live vaccines that seems to have non-specific effects that are positive. And aluminum is one thing that is common to a lot of vaccines. So that kind of drives maybe some tendency to think about it as one topic that is separated. I think the disadvantage is that it's not clear that that's the only source of risk when you think about vaccines, and there are other sources of risks. So I think that there is a tension here between thinking about it as a standalone topic versus thinking about it vaccine by vaccine, and aluminum being part of the consideration of different vaccines. So I think that I hope that the chair and others can sort of be thoughtful about what is the best way to organize ourselves across these different work groups, so within one work group. But I definitely think that we need, as a strategic direction, to improve our understanding of what are the underlying biological mechanisms that take place when we vaccinate children with one vaccines, with multiple vaccines, and how timing, genetics, and other factors impact this.
So I think probably fortunately I am not the chair, but rather Dr. Milhound is, and that question specifically referred to the chair's opinion. Dr. Milhound, do you wish to share with us your thoughts on this?
Yeah, I wish I could have been there at the beginning to explain my how I look at this committee. I look at this committee of how we have been tasked with how do we make the best product possible, giving the best protection from infectious disease, and at the same time make sure it has the lowest risk possible. There are so many different issues or maybe correlations you could see onset, dose, timing, year, adjuvants, live versus inactivated. These are all things that are by nature correlations with getting vaccinated. And because of how the early studies were done and the lack of a rigorous and long-term safety, really studies looking specifically at safety, I think we have to start taking these sort of one by one. And I think it's reached a threshold that it needs to be considered. And I think that that's where we'll be moving forward is probably hopefully developing a work group on this and asking significant questions on what is it going to take to see whether aluminum is causing a role in the adverse reactions, long and chronic, that we're seeing in children. I think that there are some very compelling and very intriguing allergic issues that have been brought up many times before. But I think it's worth for us to take an eye on it if we're really going to try to advise the CDC on how do we make the best product, also the safest product. So thank you.
Thank you. Dr. Hiblin, you are a particular expert on mental health. And some of these questions impinge on your core competence. What are your thoughts on these issues?
Well, thank you. I try to be an open-minded scientist, and I think that there are certainly valid hypotheses of aluminum impacting the immune system that can cross into the brain and potentially cause adverse neurodevelopmental or psychiatric effects. And since it is so abundant in the vaccines, I think that it is prudent to ask the question, and especially ask if there is sufficient enough human data to trigger a thorough inquiry and use of our time. I think that it is both useful and important to develop the basic mechanistic hypotheses and then look at the human data. And I think that if we endeavor to thoroughly examine this in a scientific manner, we'd have to also consider, gosh, can we do randomized placebo-controlled trials? Adding or comparing vaccines with and without aluminum, it's going to be very difficult to do. And I think that if we endeavor to do this, we'll just right up front have to be very cautious in the limitations of our methodologies and the limitations of our evaluations. It's a very interesting question. And the public, now that it's alerted to these issues, may demand us to make an evaluation of this question.
Thank you very much for that insightful and informed commentary. I can just share a tiny sliver as a clinical trial specialist that's completed a fellowship in the area. I can imagine multiple strategies wherein one could acquire epidemiologic data concerning variable levels of exposure to risk that might inform eventual more gold standard trial design. But certainly a place to start is through field surveys, both comparing, for instance, we had the example of Danish exposure and American exposure. There's some natural studies, trials available there that could be designed and implemented, but we might, as a committee, begin to gather data about relative risk correlated with aluminum exposure. And I note also that we have a natural experiment stateside where we have we have the natural experiment that we have populations that are not fully embracing the current schedule. So that means we have populations of children that have received variable doses at different ages, and those communities could be sampled for information about these kinds of concerns such as neuropsychiatric. So I think it's possible to get there,
Robert,
without randomized trials.
Just to build on that, I think I want to highlight Dr. Griffin. One of her slides suggested that even vaccines to the same pathogens in the U.S. for different brands can have vastly different aluminum quantities. And my hypothesis would be, and I think it needs to be verified, that potentially the use of the specific brand by different people is not something that they really choose. So potentially you can even have people or children that were exposed to the same schedule but with different brands or different combinations of vaccines that really gave rise to different exposures to aluminum. And that could be another potentially natural randomized experiments that nature kind of created for us. But again, I think we need to dive into the data and see what it tells us.
Dr. Meissner, you're not showing on our screen, unfortunately. I love watching your visage there. But there you are. What are your comments on this?
Okay. I'd like to follow up on Dr. Milhone's comments because I thought they were great. There are a number of what you might call rabbit holes, or a number of issues that we might consider in terms of a possible association with neurodevelopmental abnormalities. And so what Dr. Milhone is going to have to do is to decide where he wants to put time and energy, because it is limited. And I will just note, one of the great tragedies of Andrew Wakefield's faults and incorrect association of the measles vaccines and autism, one of the tragedies was that time was taken away from looking for real possible causes of autism. Money was spent in trials that obviously have demonstrated there's no association between vaccines and the development of autism that can be found. So I think to have ACIP and the CDC spend more time on the aluminum issue, I don't think it's going to be very productive, as Dr. Hibline said. So, because it's going to be very hard unless you want to replicate the study that was done in Denmark, and was just published, or a couple of years ago was published in the Annals, and because there, children born at different times during that 21 or 22-year period received different amounts of aluminum. And so they were able to develop an association, or a lack thereof, between the amount of aluminum administered in a vaccine and the development of problems. I'm not sure. Our assessment would be much different than the one that's already been done, but I defer to others on the committee as to whether that's an appropriate way to spend limited resources. Over.
Okay, I think that's a great closing comment, if you'll allow. Do I have a motion to adjourn?
Motion to adjourn.
We have a motion to adjourn. Do we have a second?
Second.
Are there any, is there any dissenting votes to adjourning for today? Hearing none, I call this meeting concluded, and my responsibilities as vice chair for the moment have been completed. I thank you all, and particularly Dr. Milhound for his fortitude. Okay. Bye-bye all.